Okay.
Thank you so much for your presence and for your support of this conference. Thank you, Simona. Good
No
day.
problem. I'm very happy. So, good morning, esteemed colleagues, distinguished guests, and friends. It is my great honor and privilege as the president of the EURO-FDI and as fellow orthodontist to welcome you to the third day of the InnoBioDent conference. Over the past 2 days, we have witnessed the power of collaboration, innovation, and shared knowledge in advancing the profession. Today, we will continue to build on this momentum, exploring cutting-edge breakthroughs and transformative ideas. I am very pleased that the first speaker of today is fellow orthodontist Dr. Kenneth Lee, who will speak about a very interesting topic, 3 faces at the same beast, the manifestation of airway cranial distortions and malocclusions. We are here with my postgraduate students at the University in Bratislava, and we are very eager to hear your presentation, Mr. Lee. Please take over.
Okay.
Thank you.
Good morning, everyone. Good morning, colleagues and students, and all those who are tuning in. Please excuse me. It's 3 a.m. here in New York. I'm visiting New York. Is my presentation on?
Not yet.
Okay.
No, you need to
Share,
share your screen.
Yeah.
Yes.
Yeah, I'm sharing right now.
So it's a little bit different system as in a Zoom. So the technician will explain you, but you are doing very well,
Okay,
and the
it's okay.
presentation is on
Yes.
now.
Yes. Yes. Can you see that all right?
Yes,
Yes.
we can. You can full screen the presentation to be more manageable. In the right corner, the lower right corner, next to the Zoom bar, you have a button to the left. Okay, that's the one. That's the one. Yes, press it, and now it should be in presenter mode.
Yes. Yes. Correct. So can you see that all right?
No, we cannot see the presentation. Can you turn back to the PowerPoint?
Okay.
Uh,
Can you see that?
okay, yes, wait a little. Can you see your presentation, your
Yes.
PowerPoint?
Yes, I
So,
can.
please go to slideshow on the
Yep.
top bar. Select setup slideshow.
To the left.
Yeah, a little bit to the right. There is a setup slideshow. That one, press it.
That one. Okay.
Yep.
Now you should be able to see an option browsed by an individual window.
Yep. Got it.
Press it and press OK.
Yep.
And now start again the presentation, please. There we go. We can see the presentation. Thank you very much.
Okay. Thank you for your assistance. Much appreciated. Otherwise, we'll be here for a lot longer trying to log back on. It's a pleasure to see everyone. Now I just can't see my camera, so there's no way of showing it. All right. Welcome and thank you very much for logging on to my colleagues and my friends who are here. My name is Kenneth Lee. I'm from Sydney, Australia. I run 3 practices there, and I'm a professor at UVI University in Castellón, Spain. I also run the InnoBioDent Academy in Australia, where we teach orthodontics and dentofacial orthopedics, as well as all things implant related. Just a little bit about me. So I've been practicing orthodontics for over 35 years now, and so it's one of my passions and my loves. And I would classify my orthodontics as more along the lines of health-based orthodontics, where we're looking primarily at increasing the health and well-being of the patient primarily, and then as a consequence of improving their health by fixing cranial distortions, by maximizing one's airway to the maximum genetic potential, and by putting the joints in the right position, being healthier, they also will look better. Basically, it's Wolff's Law all over again. What looks good works well. What works well looks good. I accepted the chair of UHI in this year, so now I'm the chair of postgraduate studies in dentistry. Okay, just last week we left Kosovo. We went on a mission there, and we treated 71 cases, implant-related cases. In Kosovo, I brought a team of 12 Australian doctors across, and we treated, as I said, 71 cases. We did very complex cases, sinus lifts, lateral wall sinus lifts, full mouth rehabilitation, extractions and immediate replacements. So it was a very, very challenging and fun trip, and we had a great time. Managed to get on national TV and meet the Chancellor and Vice Chancellor. So it was a great time. A bit about our organization. We run. I'm part of InnoBioDent, and we run orthodontic and implant courses throughout Australia. So we lecture primarily in Sydney, but we also teach in Melbourne, Brisbane, and Perth. And so we travel all around Australia. As part of my faculty, you can find us on social media, where we act as support mechanisms for our students. We graduate about 150 students, postgraduate students, a year. And through UHI, we offer diplomas in implantology, in orthodontics, and dentofacial orthopedics, as well as temporomandibular joint dysfunction and sleep-distorted breathing. We also offer master's degrees in orthodontics and dentofacial orthopedics, for which I'm the head of department, and oral implantology. Okay. As a disclosure, I'm not endorsing any product. I'm a foundation member, and I teach for InnoBioDent. I'm in private practice in Australia. I own 3 clinics, multi-group practices with multiple dentists working for me, and I don't receive any income from any commercial organizations. So I have no conflict of interest when I talk about a certain product or a certain technique. I receive no financial benefit whatsoever from talking about anything which I do clinically. As a matter of professional courtesy, no recordings allowed, no videos allowed, and no photographs unless I'm given permission. No reproduction of my material, and no redistribution of my material. Okay, so what are we talking about today? Will be 3 faces of the same beast. What we're looking at is basically, as orthodontists, we look at malocclusion, and we treat the malocclusion, and on a general basis, we treat the malocclusion well. But a lot of the time, we fail to ask the question, why is there malocclusion in the first place? Why are we getting an unfavorable skeletal class relationship very young, very early on? Why are we seeing gummy smiles? Why are we seeing faces, asymmetrical faces, what we in Australia call banana faces, where the face grows this way? Or why are some faces growing very, very long, which we nickname horse faces, really long faces, the dolichofacial faces? Or why are we seeing that when we shouldn't really be in young patients? Because if you think about it, all babies are born class 2. The mandible is at its very, very minimum. And before you become a genetic class 1 or genetic class 2 or genetic class 3, you need to work through all these phases of growth and development. And so if you see a class 3, when the child is in single digits, like 6, 7, 8 years old, then something's not quite right. If you see that they're a class 1, early in their infancy, something's not quite right. And so you should be asking yourself, what should we really be seeing at that age? And if we're not seeing it, why aren't we seeing it? We look at cranial distortions, so we're looking for asymmetries in the face and the proportions. So we work towards the golden proportion, or in a very, very rough manner, the rule of thirds: 1/3 equals 1/3 equals 1/3. And what is it that's what is it when we see a mismatch in the proportions? What do we see when the patient is not developing in the sense of the golden proportion? What is interfering with that growth, normal growth and development? What is causing the dentofacial dysmorphosis? And so we need to get to the reason for it, because if you don't treat the underlying problem, then you're only fixing the symptom, not the cause. And I think that's a very, very important factor for us as physicians and as doctors, to be able to get the patients healthier at the end of treatment than before. If all you're doing is treating malocclusion, then you may be making the patient more unhealthy at the end of your treatment than before. And the same applies for craniofacial pain, TMD. If the patient's in pain, why are they in pain? Is there something that's happening to the craniomandibular or cervical structures? What is it that's causing a change in the head posture? What is it that's causing a change in the mandibular position? Is there a compression of the condyle within the fossa? Is there some kind of issue that's interfering, that's causing maybe a compression of the neurovascular bundle? Is there any form of internal derangement that's causing, and what's causing the internal derangement? Okay, malocclusion, but why is the malocclusion causing the internal derangement? We need to dig deeper. Rather than just treat the symptom, we should be treating the cause. That's what I'm saying. Yeah. So in our practices, when we're practicing on patients, we see on a regular basis, on a daily basis, patients with malocclusion. We see patients with head and neck pain, joint pain, headaches, migraines. Okay, we see on a daily basis patients who don't get a good night's sleep. For whatever reason, when we have to dig deeper, they don't get a good night's sleep. They manifest with sleep disordered breathing. That can be something as simple as snoring, all the way up to obstructive sleep apnea, central sleep apnea, things like that. Okay. And then we look at all these things: malocclusion, head and neck pain, and sleep disorders, and we realize that there's actually an interconnection. There's actually interconnection between these three manifestations that we see clinically, and we have to ask ourselves, how are all these related? Do you see that in your practice? I dare say you do. You just don't recognize it yet. If you don't recognize it, you don't know what you don't know what you don't know. That's what it boils down to. You just don't know what you don't know. Okay. So if we take a young patient like this, and we look at her, I mean, from a cranial point of view, there's some cranial distortions going on there. Can you see that her right ear is not equal to her left ear? Her head isn't forming straight along the body. She has a forward head posture. Yep. She's got dark circles under the eyes. When she looks at you, she shows the whites under the eyes. She has incontinent lips, so the lips aren't together at rest. You can see there's a lot going on there. The facial proportions aren't quite right. And associated with the breathing issue, associated with the cranial distortions, is malocclusions. Okay, she's got a very, very gummy smile. She's got a very high smile line. And then we ask ourselves, okay, what are the three main causes of a gummy smile? And you may say back to me, vertical maxillary excess, canted down premaxilla, short upper lip, which is all correct. You've given the right answer, but the next question is why? Why have they canted down? Why have they got vertical maxillary excess? Why have they got a canted down premaxilla? These are the questions you have to ask yourself. Why when they are in primary dentition are we already seeing crowding issues? Why in primary dentition are the teeth so close together? Because quite frankly, they shouldn't be so close together. So I would say that someone like this has got a lot of airway issues, has got some cranial distortions, and also has malocclusion. So we have to dig deeper and see what it is, the cause, not just treat the symptom. Okay, and the same thing with if you have cranial distortions, airway issues, and malocclusions, you'll notice that there'll be a change in the overall posture of the patient. So what we're looking at is what we call descending influences. So whatever happens to the head and neck area manifests itself down the rest of the body. So if there's a breathing disorder, there's a compensatory mandibular position, and associated with the compensatory mandibular position will be a compensatory cervical neck muscle and cervical spine compensation for that as well. And that travels down the whole body. And, then you have a shoulder displacement, you'll have forward head posture, rounded shoulders, suboptimal breathing, like breathing from the chest, not from the diaphragm, and it'll go all the way down to the lower spine and hips, hip rotations, and basically an unfavorable lordosis or kyphosis of the spine. So that happens throughout the whole body. So there's always a descending compensatory issue that happens when the head and neck are not developing properly. So it's all about correct function. And you have to ask yourself, are your patients functioning correctly? And it starts from birth. Okay? Every child is born an obligate nasal breather. So if you see a person breathing through the mouth, that's not normal. That's actually aberrant breathing. Okay, we are all born and we all function much better when we breathe through the nose. Okay, normal growth and development occurs when the lips are together, the tongue's in the right position, and we are nasally respirating. That's where we're coming from. And some of the worst things we could do, I suppose, in growth and development is to rely too heavily on bottle feeding and to do what's known as perioral stimulation, feeding the toddler or baby soft foods. We're not designed to have mushy soft foods, and I see this all the time. Parents with all the best intention, parents and grandparents with all the best of intention, give very, very soft mushy food, and they give it to the child. And the child at this stage, when they're toddlers, babies to toddlers, their infantile swallow reflex is very, very different from an adult swallow reflex. With an infantile swallow reflex, they can breathe and swallow simultaneously. With an adult dentition, with an adult swallow, you cannot breathe and swallow and chew at the same time. So with an adult swallow, when we swallow, we stop breathing momentarily. And so that is the correct swallow pattern for an adult. What happens because of this aberrant feeding with soft foods and with bottles, we develop an aberrant swallow pattern. And that aberrant swallow pattern actually changes the facial development of our patients. So it causes dentofacial dysmorphosis, due to the aberrant swallow pattern. And so we have to be very, very careful when we advise our parents to absolutely minimize bottle feeding, because bottle feeding is too easy for the baby to feed. And when we feed them mush, soft foods, like in this last picture, the one on the far right, what happens is when we feed them mush, they just put the food in their mouth and they just swallow it. And then they don't develop a good lip seal. They don't develop good perioral musculature. And so when they don't develop good perioral musculature, they get bits of food coming out from the side of the mouth. And then what happens is we parents, the parents and the grandparents and the carers, with all the best intention, start wiping up all the food on the sides of the mouth and on either side of the mouth and on the lips. And that is actually what we call perioral stimulation. So when we bring a baby to breastfeed, to get them to feed, what the lactation specialist teaches us to do, we do this. We do perioral stimulation, and that gets the baby to start their suckling reflex. So when you do a perioral stimulation by cleaning up the excess food around the lips and the mouth, you're actually conditioning the baby to keep their infantile swallow pattern, that suckling reflex, rather than develop an adult chewing pattern. So that's one of the worst things you could do, is to feed them mush and then let them, and then clean up the mess on their face afterwards. As I said before, all babies are born obligate nasal breathers. What I want to see is a baby and a child sleeping with their lips together, because when their lips are together, their tongue's in the right position, and nasal respiration has the benefit of being able to breathe in filtered air. Not only is the air filtered, it's also humidified. So breathing through the nose moistens and heats up the air. And thirdly, which is very important for cellular regeneration, breathing through the nose gets the oxygen, nitrogen, carbon dioxide ratio correct for maximizing cellular function. In other words, maximizing the genetic potential of the patient. If I see a baby sleep with their mouth open or assume a position like this, then this is called the alarm position. That means the child already has some sort of sleep disordered breathing. And this is basically the life-saving position if you think about it. Okay, head tilted back and mouth open and head to one side to try and maximize airway. And so if I see a child in this kind of position, then that is what we call the alarm position. We are very alarmed because there is some kind of breathing difficulty going on, and the baby is just compensating for it. Okay, like I said before, these are the symptoms of airway problems. If we see anyone breathing through their mouth, then that's a problem. If we see chapped lips or some gingivitis, that's a problem. If we see venous pooling, dark circles under the eyes. So the three main reasons why we see dark circles under the eyes is, number one, allergies. Number two is underdeveloped maxilla, and number three would be poor oxygenation, so deoxygenation of the patient. We shouldn't be seeing when the patient's awake, either a forward head posture with the head tilted back, or of jaw position forwards to help with the breathing, or a jaw downwards position with the mouth hanging open to try and maximize airway. So if you see poor head posture, or the head too far forward, if we see poor head posture, that tells us that they're making a compensatory structural move to maximize the airway, because they don't want to die, and they need to keep on getting air down. But remember, for every change in head posture, there's a compensatory change in the neck, cervical neck, the neck musculature sees a different tone, and that travels all the way down the body. And that's what we call a descending influence. We see adenoidal or tonsillar hypertrophy, large adenoids or tonsils, then that's a problem. Reflux in the eustachian tube, okay? Reflux in the gastrointestinal tract also causes airway problems, yep. If we see a loss of hearing, in other words, we have middle ear stenosis, right? And they put what's known as grommets in there, where there's fluid in there. You know, that's also for kids a telltale issue for us. We know straight away that there's something happening that's interfering with normal craniofacial development. If the patient presents with head and neck pain, that's not normal either. Pain is a sign that something is wrong, and it's up to us to investigate what's causing the pain. Okay, I already talked about the importance of nasal breathing, and so it's needless to say, breathing through the nose is extremely important to maintain good health and development, and it maximizes a person's ability to call for cellular regeneration. It helps with every single cell in the body. So when we look at a face that's a patient that has dentofacial dysmorphosis, we can see now that this is a teenager, and you can see that unfortunately there was no intervention. The advice given was, oh, the kid's got malocclusion, and because they've got malocclusion, let's wait a little bit longer, and then after that, we can do the orthodontics and straighten their teeth. Well, by this age, it's too late. Let me say this again. If you're telling the patients to wait till they're in close close to permanent dentition, then starting orthodontic treatment, then you've left it to too late, because most of the cranial facial features, most of the cranial facial development is done. More than 90% of it is complete by the age of 12 to 14. And so the craniofacial dysmorphosis is now in effect. It's very hard to undo. Look at the small nares, small nostrils. When the lips are together, you see all the muscle tone in the mentalis muscle, the strain in the orbicularis oris as the patient tries to keep their lips together. You see the venous pooling, the dark circles under the eyes and around the eyes, the craniofacial dysmorphosis, the lack of bone structure, cheekbones, right? The lack of bone structure tells us that the maxilla is underdeveloped. Because just remember that the maxilla is 85% airway. And because the maxilla is 85% airway, if we don't maximize the size and shape of the maxilla, as well as its position, the position of the maxilla in relationship to the anterior cranial base, then the patient will not be at their maximum genetic potential. Okay, so we look for things like long lower face and open bite tendency, cross bites, retrognathic maxilla or mandible, or a combination of BR, bidental retrusion. Okay, vertical and posterior rotations of the mandible, gummy smiles, a high arched palate, marginal gingivitis of the upper anteriors. Now, class 2 or class 3 occlusion at a younger age. Something is wrong. Okay, something is wrong. So if you see a young child like this, don't think, oh, what a cute kid, they're going to grow out of it. They will not grow out of it. And if someone doesn't intervene, things will get worse. Okay, it's a sign of dysfunctional breathing. And by breathing through your mouth, you increase your risk of upper respiratory tract infections, ear infections. Okay, now if you don't know, the middle ear, if the maxilla is underdeveloped, the eustachian tube, the middle ear, but the drainage point is horizontal. And once you develop the maxilla, you establish a gradient, and that gradient allows for natural drainage, and you won't get as many ear infections. So kids won't need all those grommets which the ENT surgeons put in to help with middle ear infections in young patients. Okay, we see the formation of malocclusion, a high upper arch, raised vaults, narrow faces, narrow maxillas, retruded mandibles. All these are indications that something else is happening that's interfering with normal craniofacial development. Okay, so when we see malocclusions like this, don't say, oh, I'll treat this malocclusion because that's all I need to do, just treat the teeth and everything will be fine. Dig deeper, find out what the cause of the malocclusion is. And not only will the patient end up with a nicer smile, a more balanced face, but they'll also be much healthier, and their quality of life will be much better. Okay, you need to have a well-shaped parabolic horseshoe-shaped arch. Where's the maxilla and mandible in relationship to the airway? Okay, if you have a retruded maxilla that interferes with the nasopharyngeal area, and if you have a retruded mandible that interferes with the oropharyngeal area, and so the oropharyngeal and nasopharyngeal airways get constricted. If they get constricted, you have suboptimal breathing, then compensatory head and neck posture to try for the patient themselves to try and maximize their airway. And you can see how airway changes according to different classes. Yep. And just as a side note, you can also see where the adenoids are. And adenoids in the nasopharyngeal area do cause a constriction in the airway. So what we want is we want a balance between horizontal and vertical growth. So if this is the occipital bone, the face should grow forwards and downwards, forwards and downwards, and forwards and downwards, and we get volume that way. What I don't see often enough, and what I see too much, is lots of vertical growth, but insufficient horizontal growth. That's why we have flat faces. That's why we have long faces. That's why we have gummy smiles. That's why we have cross bites. You know, and these are all manifestations of an aberrant growth and development. Something has interfered with normal growth and development. And if all we do is dentally correct it, then we are basically not treating the patients to the best of our ability. We as dental physicians are not treating them to the best of our abilities. We should be treating the cause, not just the symptom. And this is what I'm talking about. If there's a compensatory head and neck posture, there'll be a compensatory craniofacial development going on. So you have a rotated, elongated mandible, a retruded maxilla, and a compensatory head posture, which leads to compensatory cervical spine posture. Okay. So this is a very important thing to realize, that if you have a normal face that's growing horizontally as well as vertically, you maximize the genetic potential. The airway is at its maximum, the cervical spine is at its maximum, and the head and neck posture is at its maximum. If you have a vertically growing patient, you have a forward head posture, excess stress on the cervical spine, and a cervical curvature. The cervical spine curvature changes, and that all impacts on airway. Okay, so that's what I'm talking about. So if you look at the red line is the horizontal growth component, and if one doesn't have a large enough horizontal growth component, there is a rotational axis on the mandible, and the face rotates, and the airway is compromised, and you get a face that doesn't look as good as it should look, because you've allowed dental facial dysmorphosis to occur. We look for cranial distortions. Okay, so not only so we do some form of triplanar analysis, hard and soft tissue triplanar analysis, and we look to see where the distortions are and see how we can impact on those distortions. You want to have as balanced a face as you possibly can. Okay, you look at the joints. Are the joints worn down? Is the condylar head worn down? Can the condylar head come in line with the articular eminence, or is there a restriction to full opening? Do you see a beaking happening? Okay, so this is what we call a beak or a bird beak, and you see that very often when there's an unusual wear of the condylar head or a bending of the condylar neck. Do you see osteophytes? Do you see a decalcification, demineralization of the bone? Okay, with some beaking, do you see that? Then is there a chronic low-grade inflammatory process happening there that's melting the bone? So you need to look at all that, because that's all interrelated. You need to be able to do a very, very thorough occlusal analysis and muscle palpation, because that tells you the occlusal analysis where you measure the vertical, you measure, you take your C line, your indicator line, your Shimbashi number, you look at the full jaw opening, your left and right excursions, your protrusion. If it falls outside of normal, firstly you have to know what normal is, and if it falls outside of normal, then you have to ask yourself why. Are they tracking left and right in lateral excursion? Are they tracking symmetrically? Are they tracking enough? Because that tells you how the medial pterygoid muscles are working. Are they protruding well? If they're not protruding well, what's happening with the lateral pterygoid muscles? Yeah. If they're opening, full opening with no pain, and they have a full opening with pain, and these two measurements, there's a big discrepancy, ask yourself the question, what's happening there? Why is the patient muscle splinting? Why are they in a protective mode to protect their jaw? What's happening there? Have a look at when you go to the oropharyngeal area. Let's have a look at the tonsils. Have a look at the uvula. Have a look at the size of the tongue. Have a look at the position of the tongue to see how much available airway happens there. And so the two numbers we look at, the two measurements we take, is a Malin-Patty or a Friedman. And then you need to investigate their sleep, because there's a strong association between sleep and pain. And suboptimal sleep leads to suboptimal function, and it affects every single system in your body. When your body has insufficient sleep or poor quality sleep, you don't get enough oxygenation. Enough oxygenation changes the pH of your blood, and if your pH becomes more acidic, then you have multiple systems affected. In fact, almost every system in your body is affected. So if your pH goes up, and the body functions best in a slightly alkaline environment, somewhere between 7.2 to 7.4. So if you have a deoxygenation happening when you're sleeping, then what happens is you throw yourself into the acidic phase of your body, and your blood becomes acidic, and that leads to atherosclerosis, leads to cardiovascular issues, leads to diabetes, can lead to diabetes. It's cancer cells function best in an acidic environment. So all the inflammatory problems which we have, rheumatoid, different kinds of arthritis, all these are associated with a high acidity index. Okay, there's a high percentage of sleep disordered patients with TD problems. So patients who are in chronic pain also have sleep issues, and people who have sleep issues can't seem to handle pain as well. So there's a strong interrelationship between pain and sleep, and we have to relate, and we have to basically recognize that. And I won't go into all these, but these are all referenced, and you can look them up yourself, or later on, well, I can help you with that. But there's a high frequency of patients with sleep disordered breathing and with what's known as chronic pain, and chronic pain is also known as fibromyalgia. Okay, so there's a relationship between sleep disordered breathing, even bruxism, and temporomandibular disorders. And I won't go too much into it because I haven't got much time to speak. But what we're looking at is that people who have some form of sympathetic dystrophy, this is basically the sympathetic nervous system, some form of sympathetic dystrophy will brux more. The sympathetic dystrophy can be in the form of chronic pain, chronic head and neck pain, TMJ pain. It can be from a deoxygenation. So when the patient deoxygenates, the brain says to the body, I need to get muscle tone back into the oropharyngeal so I can breathe better. And the fastest way of getting muscle tone back into the oropharyngeal area is a very quick spasmodic muscle twitch. And that if you look at PSG sleep studies, that's called an RMMA, rhythmic masticatory muscle activity. Rhythmic masticatory muscle activity. And this rhythmic masticatory muscle activity usually precedes awakening. So that disturbs one's sleep. So bruxism is a survival instinct to keep the patient alive. It's a sympathetic downregulator when the patient's in sympathetic dystrophy. So when they are in sympathetic uptake, to help calm the patient down, the body bruxes, and the brain tells the body to brux, and that bruxism is a sympathetic downregulator. Okay, there's a lot of evidence to show that that sleep bruxism is basically a little bit is very bad for you. Too much is very bad for you. You need a little bit, you need some bruxism to keep you healthy, because it's a sympathetic regulator, a sympathetic nervous system regulator. Okay, so you should be asking these questions. Okay, you should be asking these questions, and you should be looking as a dentist for all the signs of parafunctional activity. You know, tori. Look for tori. Look for abfractions. Look for unusual wear, enamel pitting. There's so many things you look for. Look for large muscles of mastication. Okay, you should be looking at all that. Okay. Discuss sleep position, because sleep and bruxism are very, very interrelated. Okay. Sleep and sleep disorder breathing and bruxism and pain. Okay. So it's all about, so what I'm trying to show you here is that sleep, malocclusion, cranial distortions, and craniofacial pain are all interrelated. Okay. They are all interrelated. We look at things like periodic limb movement disorder. We used to call that restless leg. We look at reflux. So what's reflux? A lot of reflux is due to the upper airway constricting, increased intothoracic pressure due to respiratory effort, we make a greater effort to try to breathe at that greater intrathoracic pressure from the effort. Draws up the gastric juices, causes the mucosa to inflame. That has a sympathetic effect of if the gut lining inflames and the esophageal tissue inflames, then it inflames the mucosa all the way up to the nose. And we know that because if we have a hot and spicy meal, there's a little bit of inflammation going on in our gut, but that causes our nose to water and we have to blow our nose. Yeah. Okay. I think the most important thing is to take a really good history. Okay. Find out exactly what's happening with the patient. Evaluate the patient. Do a good occlusal analysis. Do a good muscle palpation. Take a 3D CBCT or alpha patient. Check their airway. Yeah. Check their bloods. Check their vitamin D. Check their ESR. Check to make sure that they had their inflammatory indexes are not too high, because there's always a reason if there's an increase in the respiratory in the inflammatory indexes. Okay, so for bruxism, what do we do? Well, it's been found that just a norm. What most of us do for bruxism is make a flat plane splint. That's actually bad for the patient. That's actually counterintuitive. It actually increases the sleep disturbances, so it closes down the airway. So maybe making a flat plane splint or flat plane splint with canine risers, maybe that's not a good idea for a patient who's got some form of sleep disorder breathing and they're bruxing, because not only will they not wear it, but you'll make their sleep disorder breathing even worse. Okay, so you need to find a splint that protects the joints, keeps the airway patent when the patient's asleep, and helps with the bruxism. Okay, decreases the intensity and the rate of masticatory muscle activity. Okay, the use of CPAP. CPAP is a lifesaver. It helps very much people who can't breathe on their own and get sufficient oxygenation, but it is only a short-term fix. It was designed that the inventor of the CPAP, Professor Colin Sullivan, has said on record and to me as well that the CPAP, the purpose of a CPAP was to keep a patient alive just prior to surgery. Okay. And CPAP should only be used short term, not for life, because that causes a lot of problems in the future. Okay, a lot of problems. So you need to see. And if a patient's put on CPAP, the evidence shows that their bruxism goes down, their nocturnal bruxism goes down. Okay, surgery is an option. So for growing patients, adenoids. I don't know whether you can see my cursor, but adenoids and tonsils are an issue. A large uvula could be an issue. Okay, tongue position could be an issue. So we can affect all of that. Yeah. Right. So in summary, it's all related. Malocclusion, dental facial dysmorphosis, TMD, bruxism, they're all interrelated. So I look at it I teach this to my students, and I have the same philosophy in my private clinics, that orthodontics, sleep disorder breathing, TMD are basically different faces of the same beast. Thank you very much for having me speak to you. It's been an absolute pleasure. I will log off now, and I don't know how you're going to handle questions, but I'm happy to entertain questions at a later date if need be. Thank you very much.
Thank you very much, Professor Lee, for the most interesting lecture you had. And I open the floor for any questions, if they are at this moment. I checked the chat, but I don't see questions in the chat now.
Okay.
So thank you very much once more. and I wish you all the best for your professional career and good luck with the airways.
Yes. All right. Thank you, everyone, and may your patients continue to get healthier and healthier.
Thank you.
All right. Bye-bye.
Thank you, Ken. Thank you so much.
You're most welcome.
So now we invite you to hear and see the other professor who is coming to have a speech on the InnoBioDent conference third days, and that would be Dr. Niraj Kinarivala. Do we have Niraj online?
Yes, he's in the chat, but I don't think he's active. I'm gonna give him a quick message.
Okay, please. So speak with Dr. Niraj. I would introduce him in the meantime. He is a proficient clinician and academician with expertise in contemporary endodontics and digital dentistry. He is associate professor at the Karnavati University in Gujarat, India, co-owner of the White Dental Lounge in India. Dr. Kinarivala has numerous national and international publications, and he has been a guest speaker and lecturer at esteemed national and international congresses and conferences, including Cons Asia, AEDC Dubai, and World Dental Conference. He's a passionate proponent of magnification and digital dentistry. Today, he will be speaking about digitalization in endodontics, and to make an abstract accessible for all listeners, I would say that with advent of latest bioactive materials and applications of digitalization, endodontics microsurgery can be performed with better safety and predictability. The first part of the lecture of Dr. Associate Professor Kinarivala would be about applications of the novel radiographic techniques in endodontics, mostly with the use of CBCT and 3D imaging of the teeth dealt with endodontically in surgical endodontic cases. The second part of the presentation deals with other digital applications and systems such as digital access to root canals, the evaluation of complex roots, and the variation in tooth morphology. The final third part deals with the digital systems in guided endodontics procedures, which are constantly evolving and gaining more followers in cases where conventional endodontics have technical difficulties. The lecture will provide insight on cone beam computed tomography and its impact on diagnosis and endodontic treatments, applications of static and dynamic navigation in endodontic treatments. So thank you very much for listening to the abstract. And if we have Niraj now online, then I would let the floor to him.
Dr. Niraj?
Hello.
Yes.
Hi. I
Yes.
hope you can see me.
Yes,
Yes,
we can see you and we can hear you very well. Please, Associate Professor Niraj, the floor is yours.
Thank you. I hope my screen is visible.
Yes, it is.
Perfect. Thank you for a warm welcome and subtle introduction. Just there is some change in my bio, which I usually would like to start with. I'm additional director now at the university, and I'm director for the Center of Dental Excellence. In next 30 minutes, I'm going to talk about digitalization in endodontics. I am director at the university, which is located in a city called Ahmedabad, which is a small part in India. The beautiful campus where now we are trying to incorporate more and more courses in and around digitalization, not only in dentistry, but even beyond that as well. We have started with our AI courses and a different AI lab as well. Uh, at the same time, I also own three different practices in different parts of the city. To begin with, today's session, usually when I talk about digitalization or when we go to conferences and listen about digitalization in dentistry, usually it is always revolving around either implantology or prosthodontics. Being an endodontist, I firmly always believe that there should be more efforts needed towards saving the teeth and how digitalization can help a clinician to save the tooth. Sometimes we feel that dentistry is now delivering content, delivering knowledge, which is more of a company centric rather than the science centric. And that's where, with that thought in mind, we decided to write a book on digitalization endodontics, which conceptualized as guided endodontics. And along with my mentor, Dr. Lakshman Samaranayake, we published this book with Springer Publishing House in 2021. And within last 4 years, it has penetrated across the world. I really take pride in saying that this is the only literature about guided endodontics available in a textbook form anywhere in the world. So when I started lecturing with this in year 2020-21, we used to propose the first question: what is the need of navigation in dentistry? And now in 2024, the way world has pivoted towards digital dentistry, now almost it's easy for people to understand why we need navigation in dentistry. But I would like to start the session with this particular slide. What you can see on your screen is a CBCT of a female patient of a mandibular arch. Now, in this section of CBCT, just to give you patient's brief history, patient age 24 years, a very young lady. She had undergone a root canal treatment 4 years back. And after that, she started experiencing some pain in relation to tooth number 4, 6 on chewing. Accidentally, this young lady was pursuing her master's in dental surgery in oral and maxillofacial radiology. And we advise her to undergo CBCT, and that's what you can see on your screen. If you look closely towards the mesial root of the first molar, you will notice there is a big radiolucency, which is having gradio-opaque lining. On radiographic differential diagnosis, it may look like a radicular cyst, but as an endodontist, when I ask any of the senior endodontist or a beginner, what would be your treatment approach? And the answer would be extraction of the tooth, because this is in very close proximity to mental foramen. As an endodontist, we have been trying to save the teeth, but whenever we have teeth which are already compromised, but they are in a close proximity to any of the vital tooth structure, it can be maxillary sinus, it can be infraalveolar nerve, we do not even attempt to save that tooth because of the first reason: we do not want to harm our patient, right? The first rule is do no harm. But that's what digitalization can do for you. Digitalization should help us and enable us to carry out the treatments more safely, with better accuracy and with better predictability. And that's why I say that there is a need of navigation in endodontics. Now, when I talk about digitalization in endodontics, it is nothing new. Dentists, particularly endodontists, they have been always on the forefront of digitalization. The highest penetration of digital radiography was amongst endodontists when the wave started. Be it endomotors, apex locators, endodontists always have been familiar with digital tools, and there has been a different passion of playing with these toys and different gadgets. Now, in 2024-25, when we look at dentistry from the perspective of retail dentistry, all the tools and techniques can be divided into three categories. The first category is static navigation. Static navigation, where we are heavily relying on 3D printing. Second category is dynamic navigation, which is a camera-based system. We usually call it semi-robotic navigation. And the third category, which is in a way robotic navigation, where you are just dependent on a camera system along with the robotic arm or the virtual reality, which will help you to deliver better treatments. The use of digitalization in dentistry, particularly endodontics, has been clinical, experimental, and educational. I firmly believe that using digitalization with virtual reality for educational model will always give beginners a different sort of learning curve. Imagine when you're working in your second year pre-clinics and you want to work on the phantom head. And at that point of time, if with virtual reality, you can just see how good angulation you can get even while dealing with the posterior-most teeth. It will definitely help you to have a better learning curve when you start your journey with restorative dentistry. Clinically, implementation has definitely started, and still there are many things which are under research and definitely is going to add some more value. Right now, what you can see on your screen is the use of virtual reality. Now, virtual reality can be used either for the restorative dentistry or for the endodontics. As you can see over here, this was developed by Jay Morita, where you can just increase the size of the tooth and check that rather than little canals, how many foramens are we dealing with. It will also help you to orient your endomotor. It will help you to orient your handpiece, which is usually parallel to the tooth. Here you can see it's easy to get that parallelism while doing access opening. And this technology can really be game changing if you know when to incorporate it. When you're working on phantom head in the preclinical times, it is really going to make life easier and give you a different sort of learning curve when we try to implement that. Initially, many dental schools have been using different dental simulation or the different simulation devices, but use of virtual reality can definitely help to work on that. If you look at the graph of the static and dynamic navigation or the article published in the last 10 years, it is going high, high, and higher every year. And when we look at the most common words which are found in the digital dentistry article, it is rapidity, specificity, and accuracy. And that's what we are trying to deliver in endodontics when we try to incorporate digitalization. Now, everything started to change when CBCT was introduced into dentistry. Particularly, as an endodontist, I can always say that CBCT has been a game changer. It has not only increased our knowledge about the root canal anatomy, but it has helped us to deliver the predictable outcomes when we are dealing with difficult anatomies or we are dealing with the retreatment or the failed root canal cases. When we could have CBCT, it directly opened the door of the third dimension. We could see on all the dimension how we can make an effort to save the tooth. We all know that endodontics is mainly important because of the infection of microbial origins. But with digitalization, we can knock on the door and then we can clean the biology. Apart from CBCT, intraoral scanners, 3D printing, and CAD/CAM, along with navigation system, has enhanced the user experience in digital dentistry for endodontics. I started my journey in 2015 with 3D printing. I've been using dynamic navigation since 2019 and 2020. Digitalization is nothing new. Implantologists started using the technology a decade before we endodontists started adopting it. In implantology, it all started with the implant-driven processes to prosthetic-driven implantology. We are taking this cue from our colleagues and using the same technology for saving the teeth instead of replacing them. What you can see on your screen is the fundamental basis of guidance or navigation. Usually, when we are doing freehand drilling, there are unlimited range of drilling trajectories into which your drill can penetrate. But with guidance, with navigation, we want our drill to go in a single pre-planned trajectory. If you are a Marvel movie fan, and it's like you are Doctor Strange, you have 1 million opportunities in front of you to save the world, but you have to decide that one opportunity where you end up saving the world. When you are an implantologist and you want to place an implant, even if your implant is slightly here and there can be some conal apical deviation, still that implant can survive if the initial stability is good. But for an endodontist, even the 0.2 mm apical deviation means you are ending up with a perforation, and now that tooth is going for another implant. That's how precise we have to be as endodontists, and that's where guided navigation or the guided surgery adds some value to the treatment. Now, how to start the journey with digitalization? Here are the steps of guided endodontics. The first thing that we do is that we take CBCT of the patient. Following the CBCT, we take intraoral scan of the patient, and following that, we superimpose them in a software. And then we do our virtual treatment planning on a software to create a 3D printed guide. Once it has been designed, it is sent to the 3D printer. And after 3D printing and post-processing, you can use it for your treatments. So what we need a STL file, which is impression of the patient. What we need is CBCT or the DICOM data, and we need a planning software, usually implant planning software, which have been modified for endodontics. And following use of the software, now you can do your communication and the pre-surgical preparation. That's how endodontic guide design would look like if you look at the 3D meshwork. But there are a few important factors when we talk about static navigation or 3D printed navigation. The first one is endo guide classification. Second one is the target point and the virtual drill path. Third is the offset. And fourth is the sleeve type. So we have to address all these points. Friends, what you can see on your screen, these are the sleeves which are used for 3D print after 3D printing for static navigation. There are two types of sleeve available. One sleeve which can be directly fitted inside the guide, and second, which you need to hold with your hands. It is called hand-held sleeve. Nowadays, dentistry is moving more towards the sleeves which are either incorporated into direct 3D printing or they can be fitted after 3D printing, because hand-hold sleeve will give you more deviation. Now, when I create a guide and I want to place a guide on top of the tooth, the first thing is the thickness of the guide. Guide should be thick enough so that it doesn't break. The minimum thickness of endodontic guide has to be 3.5 millimeter. At the same time, your guide should be passive. If a guide is too much active, it can exert unnecessary pressure, and for that we give offset, which is a clearance between the teeth. Between the guide and the teeth, the clearance of 0.15 mm is what we are advocating. What you can see on your screen is virtual drill path. If I get a case of calcified upper central incisor, root canal has already been attempted, and now you want to deal with the root canal in the same tooth, you need to deviate your entry point. Either you can get access from the incisal edge, or on right hand side on your screen, what you can see is that you are getting access from the palatal side of it. Because if you are drilling through the incisal edge, it is going to compromise aesthetics. And here we are trying to save that so that we can achieve beautiful access openings, which give you better cleansing ability. Now, before I dwell further into the science, it's important to tell you that whether it is static navigation or dynamic navigation, this is image-based navigation. So when you are having image-based navigation, image has to be crystal clear. Any error in CBCT will lead to wrong navigation. And when I say navigation is wrong, that means free navigation, freehand surgeries will be much better in that scenario. If you want to avoid that, make sure you are taking proper CBCT scan. When I say proper CBCT scan, that means the first step, resolution has to be good. We need minimum 200 micron resolution. If possible, you can take a CBCT with high definition mode as well. Number two, always take a CBCT with open mouth of a patient. Now, clinicians sometimes tell me, doc, there is already a bite fork, but bite fork is not enough. You need to place bite plate or cotton rolls between the posterior teeth and then take a CBCT. So there will be enough clearance between the upper and lower arch. So the software will be able to work with it. And third, but the most important part for endodontics, small field of view. If you tell me that you want to do access opening in a tooth having calcified canal, then first we need to locate the canal on the CBCT. And to do that, if you are having large FOV, which covers even the zygoma of the patient, it is of no use. We need a CBCT which is more focused, which is having limited FOV, and as a clinician or a radiologist, you can go through it and trace the canals. Once you have your small FOV, high resolution, open mouth CBCT, now you should be knowing what is the scope of 3D guided endodontics. You know the science, but you should know where to apply it. So the most common use is application in calcified canals. We all know that with aging, there is secondary dentin deposition. With aging, there is tertiary dentin deposition. Long-standing dental caries will again lead to repetitive dentin deposition. And eventually, the pulp chamber will recede. It will slightly shrink in the size. And with aging, calcified canals are very common. Another common reason is the traumatic injuries. To deal with such scenario, guided access opening is amazing approach which gives you more predictable, the most conservative access opening. Second part is endodontic surgery. When we want to do root and dissection, this is highly predictable. Auto transplantation, instrument retrieval, and educational model and clinical simulation. There is another treatment strategy which we have now devised. It's called selective retreatment. Maybe today time is less to talk about selective retreatment, but it is again a concept where we are trying to apply guided endodontics and we try to reach out to only the infected root and deal with it. To begin with the calcification in the root canal system. So on your screen, you can see a radiograph where tooth number 2-1 is completely calcified. It's called pulp canal obliteration, pulp canal calcification, or calcific metamorphosis, where entire canal from the cornal to the apical end is calcified and you cannot even visualize that on the screen. The most common reason is trauma, aging, excessive orthodontic forces, and sometimes pulp capping as well. Direct pulp capping is one of the main reasons which leads to calcification. Now, if we forget about digitalization for some time, what would be the conventional approach for the calcified canal? So if you are a clinician for calcified canal, all you need is a microscope. You work with magnification without microendodontics. That is no endodontics. You use ultrasonic tips, and the only thriving force is the experience of the clinician, which will help you to go ahead and chase the canal. But when we want to go with the guided approach, this type of long shank burrs are needed. So what you can see are called moon spur. You can see on the screen that first virtual drill path is being planned, then guide has been designed. You just drill through the guide, open up the canal, do your cleaning and filling. That's how it's going to work. Now, calcific metamorphosis, that's how we are dealing with it. Now, what I want to highlight with this particular slide is that even with static navigation, don't go blinded. First, you need to take a bird drop, take one X-ray and check whether you're going in right direction or not. What happens sometimes is that if your error is in treatment planning, you will again end up doing perforation. If there is any error in 3D printing, still it can give you some error. So we need to be focused on all the steps where error can happen. So error can happen with intraoral scanning, error can happen at the level of planning, and error can happen at the stage of 3D printing. If all three are accurate still, as a clinician, first I take a radiograph after I take the first drop. I check whether I'm working properly or not. It is in the center. I have to maintain my law of canal centrality, and then only I indulge into it. Now on your screen, what you can see is a small video where first we are traversing through the DICOM data of CBCT. We are trying to localize the root canal, which is completely calcified. In the sagittal, coronal, and axial section, I'm traversing through it, and I'm deciding that which is the center of the tooth, and that is called canal centrality. After maintaining canal centrality, now I'm superimposing impression, and this is my DICOM plus STL file, where you can see DICOM data is completely encapsulated with STL file. After that, you design your guide. Usually, if I want to work in tooth number 2-1, I would like to take support of 2 teeth on each side. That means 5 teeth will be involved. So while taking CBCT, you can also keep that in mind. That adjacent teeth should be covered properly. And the most important one, there should be no motion artifact. Because if there is motion artifact in the CBCT, the guide will not fit precisely. And there is high chance that you will have some corneal or apical error. That's how the final guide looks like, which is designed. And then you send it for 3D printing. And that's how it looks like. Now, sometimes we are trying to put a sleeve directly on it. So as I mentioned again, you maintain the canal centrality, plan a virtual drill path, use the target point. Now, what is your target point? Target point is the first point where root canal is visible. So you mark it, let's say, in this case, canal is calcified up to 15 millimeter. So my virtual target point is 15 millimeter. My virtual drill path will have a length of 15 millimeter. So I have to use my drills accordingly while I start my journey clinically. Here you can see the DICOM data and STL files are superimposed. Virtual drill path is done. Now, it's very easy to say that it's superimposed data, but the question is how? So there are few softwares like Blue Sky Bio, DDS Pro, Co-Diagnostic X. These softwares allow you to superimpose your DICOM and STL files. You need to select 3 to 6 different points on STL and DICOM, means impression and CBCT, and it will merge the data. Once data is merged properly, now we can go for the drilling and open up the canals. So that is the target point, and that was the area which we need to drill through. Now that is another system which is called 2-INGIS system. A beautiful system where you just need 2 slots which are 3D printed, and after that you fit your micromotor or aerotor head into it and drill through it. A beautiful concept which has a less chance of deviation, but sadly we cannot use it in the more posterior teeth because it requires more mouth opening. 3D printing is slightly bulkier. So that is the only challenge. And you can see you need a small drill with it. That's how canals are calcified and opened. So guys, if you remember, I was talking about selective retreatment. Now, selective retreatment is another concept where we try to deal with only one root canal system if infection can be localized. Just to brief you about the concept, if you're dealing with maxillary molar, which is having 3 root canal systems or 3 roots, if I can localize infection just to the 1 root or just to 2 roots, I don't need to touch the 3rd one. As endodontists, remember how painful it is. You've done a root canal, you've done post and core, you're given a crown, and after 5 years, patient comes to you with pain. There's some periapical infection. It's biology. The root canal has failed. Now you will need to remove the crown, you remove the post and core, and you do the retreatment, which now no one does. You just remove the tooth and go for implant. That's the time where guided endodontics comes to your rescue. You take a CBCT, localize infection just to 1 root, and then drill through the crown, drill through the core, reach that particular area. Use your rotary files once canal is open, remove the gutta percha, get access to the apical area, cleanse it thoroughly, and save the tooth. And that is the concept, selective retreatment. You don't need to treat each and every root if the infection can be localized radiographically. You can even use guide, just like for this case, for the posterior teeth, but not in every case you can do that. So the biggest burden while dealing with this is mouth opening. Look carefully. There are a few mistakes being made in this. Do you think this is good to go? No, not really. With this, our root canals can fail. So we will repeat in slow motion. So now you know the guide was not stable. The water coolant is not going inside. It is going to lead to more and more heat generation, which will damage the periodontium. Another thing, now we are trying to use it for the surgical purpose. Now, when I want to do a surgery, I say that I want to remove the apical 3 mm of the root, because it is having the maximum number of lateral canals. But is my impression even recording it? No. For that, you need to take an impression with proper extension in the impression tray, and then it might help you. That is the modified impression tray. You can take a proper scan where the periapical areas are recorded properly, and then only superimposition will make some sense. There are different tray files which are used for implantology, autologous bone collection. We are using them for endodontic purposes. The concept is that I use one drill, I remove the bone, I remove the root end, and get access to the periapical infection directly. Once your guide has been 3D printed, now the first thing you need to do is check its fitting. You can never start a case without checking snug fit. If it is too loose, it may not lead you to the right direction. It should be too active, otherwise it will break. So you give anesthesia. After anesthesia administration, you give incision, reflect the flap, reach to the target point, check adaptation, drill through it, do root end preparation, root end filling, and we are done with the surgery. But the main drawback is that not every case will give you good interocclusal distance. When I want to open a calcified canal in maxillary, second molar, it's difficult, guys, because mouth opening cannot be so good in every patient. We need different guide rings. It is time consuming because we are dependent on a software, we are dependent on a third party. It is expensive because if in one tooth, two canals are calcified, I will need two different guides. And the worst part is it does not allow you a change in the treatment plan. Let's say if on a CBCT you decided that I want to drill up to length of 18 millimeter, you cannot drill up to length of 20 millimeter by using the same guide. You will lose the guidance. And that's why it is static, and to overcome have we have something called dynamic. Now dynamic is called dynamic because it is giving you real-time feedback. Let's say I'm sitting in a city of Ahmedabad in India, and if I want to travel to Mumbai or I want to go to the airport, what will I do? I'll just take my mobile phone, I'll open Google Maps, and I'll enter my destination. And it will show me that I have to go 2 kilometers straight and then take a right turn and then go 5 kilometers straight, and I'll reach my destination. What if I can get the same for my endodontic treatment? What if I can get the same for my implants? And that is the concept of dynamic navigation, real time. So we are using navigation dentistry, and what you can see on your screen is the navigation being utilized into endodontic procedure. The yellow color is the virtual drill path, and the green color is real-time navigation. The yellow color is showing you what is the target point, up to which length I have to drill, in which direction I need to drill. And over here, it is exactly showing that. The biggest advantage is that it doesn't require any long drill or burr. We can use my high-speed handpiece, I can use my piezo dispenser, I can use my electrosurgical handpiece. There's no need of 3D printed guides. Multiple drill paths can be easily planned and executed, and this allows treatment changes to be made at the time of drilling. Let's say I am drilling inside the tooth, and I realize that no, I want to change my angle. Will your 3D printed guide allow that? It won't. But with dynamic navigation, you make the change on a screen, and it will make sure that you follow that. It's easy to implement dynamic navigation. So it's flexible, it's very much immediate, it is much more predictable. At the same time, it's a simplistic in nature. It helps us to provide better irrigation as well. Here is one of the system which allow you to do the calibration, registration, and tracking. Now, these are the terminologies for which I can only share a few articles because it's difficult to teach you how the entire workflow is. But all you can remember is that this is the concept of the trace and place. So we have one complete system on which we are planning the treatment, we are doing the trace registration, and we are placing our drill inside patient's mouth for real navigation. We can also superimpose impression. As you can see on the screen, it is being superimposed. 3 points on DICOM file, 3 points on STL file, both are being taken. So now there's superimposition taking place, and you can see the DICOM data is encapsulated in pink color. So that is the superimposition which you can use. Now, these are the trackers which we use. Now, I tell you what is the concept. When we have dynamic navigation system, it work on the concept of triangulation. So one point is steady, which is the camera system. The second point is on patient's head, which is called maxillary or mandibular tracker. And the third point is on your drill, which is called drill tag. Now, if there is a triangle and you know two coordinates, it's easier to find the third coordinate. And that's what we are doing with dynamic navigation. On your CBCT, when it has two landmarks, it will give you the third landmark. It will show in real time where you are drilling and how you are drilling. There is a mandibular tracker. The concept is scan, plan, trace, and place. Please pay attention on the screen where you can see actually how dynamic navigation can be used for a model of the central incisor. So first thing you do is you take a good CBCT. After taking CBCT, you take the DICOM data. We don't need STL file. Just on the DICOM data, I can fit it inside the system. Now I'm doing my virtual treatment planning. I'm making sure in all the direction I'm going fine. After doing my planning, now I'm going intraorally and I'm applying rubber dam to my patient. And that's where you can see the green color is starting to change and superimpose the yellow color. And this is called guided endodontics, which is dynamically navigated. You can see up to which length are we negotiating. And that is the beautiful access opening which you can achieve with this effort. That is dynamic navigation endodontics for you guys. The same can be utilized for the posterior teeth as well. We are taking a CBCT, we are uploading it, and let's say there are two calcified canals. I want to open mesiobuccal and distobuccal. You can plan both of them in the same thing. You don't need two different X-ray or two different times. Okay. Only thing that we try to take care is that keeping ourselves away from the percussion area or the danger zone. Here you can see drilling is done under rubber dam, but I'll show you how it looks like on a software. You have selected a particular virtual drill path, and now with the green color arrow, you are actually chasing it properly without any risk of perforation. Because you are confident when you're using it for 15-20 cases. When you do 50 cases, you become more confident, and 100 will lead to overconfidence. But that's where we need to stop. And we need to recalibrate ourselves to work with the slow dentistry. So here we are following what is guidance given to us, but at the same time, our clinical skills we have to keep in mind. Sometimes if the camera is not calibrated or camera loses its calibration, which just happened recently at one of the events, you need to be aware and you need to recalibrate your system to work precisely. And these are the cases which I've been showing to you, are very familiar cases. This is something what I would like to show you at the end of the day. What you can see on the screen is the first case with which I started today's session. In this case, we are having a virtual drill path, which is yellow in color, and the green color is my drill, which is being used for pisectomy. I have already drilled through the mesiobuccal route, and now I'm going towards mesiolingual. Just see, you can see in 3 dimension that in which area am I drilling, whether my drilling is precise or not, or I need to change my position. The another concept for doing this is a cortical window technique. So I create a window, take out the bone, remove the root, remove the infection, and put the same bone again as a bone graft. Or I mix it with my allograft and use it as a mixture which will give better chances of good bone formation around it. So beautiful technology and beautiful execution. Here we are showing you, if as an endodontist I show you the case of surgery, maybe it doesn't give you the wow factor, it doesn't give you scientific evidence that how corneal or apical deviation is. But what if I tell you that being an endodontist, I had placed this implant. This was in 2020, the first implant which I placed with it. And I superimposed my pre-treatment and post-treatment CBCT data to check my entry level corneal deviation was 0.2 mm. Means what I planned and what I executed had a deviation of 0.28 millimeter. Apical deviation was 1 millimeter. And the most important, which comes only with experience, angular deviation, it was only 2.93 degree. It is something so much negligible that it is much better than the freehand surgery. Now, there have been systemic reviews, there have been articles in and around, which I'm not going into the detail, but all I can conclude by saying is that dynamic navigation is better than freehand and static navigation in terms of the corneal and apical deviation. You can get angular deviation with static and dynamic navigation both. But with more practice, dynamic will give you much better angular deviation. We have been lecturing in and around India, Dubai, and Indonesia to spreading the knowledge and awareness about digital dentistry. We also run our own programs for digital dentistry, which are certified by American Dental Association now. I have just conditioned you, briefed you something about digital dentistry and endodontics. And if you really want to know about this, you can reach out to me. We are using 3D printed models for education. Before I end this session, this is what I like to highlight. This is the use of CBCT in endodontics, a position statement, where we tell clinicians where to use CBCT and where not to use CBCT. So if you feel that in your case, there is some root canal complexity, now officially you can use a CBCT. You can justify the usage of CBCT. We are not worried about extra exposure because we know endodontics for multi-rooted teeth is a difficult task. And with CBCT, it can make your life easier. So don't hesitate to use CBCT where you want to, because it is going to be the first step when you are climbing the ladder of guided endodontics. Nothing we do can change the past, but everything we do changes the future. To make change in your life and lives around you, one change at a time. With that, you can reach out to me for any questions or any of the queries regarding this science. I'm open for question and answer if needed. Thank you, everyone. And thank you, team, for putting up this beautiful program together.
Thank you very much, Associate Professor Niraj Kinarivala from India for the most interesting endodontic presentation. Do we have any questions coming from the audience at this moment? I don't see that. And there will be a recording of this session and all of the other lectures on the YouTube. So maybe something will pop up later. Thank you very much, Niraj.
My pleasure. Namaste. Thank you.
Thank you. So let me come to the next point on our program. There should be a 15 minutes break. Is it true? Or can we proceed without break? I would prefer not to do break now. Is it okay, Professor Constantinescu?
Okay, please continue with Professor Fromovic.
Yes, very good. So
thank you so much, Simona. Thank you.
Thank you. So let me please welcome Professor Ofir Fromovic from Israel, who will present today his lecture about, with the title, Fifth Generation Implants or 5th-generation implants in a new concept with a biologic understanding for immediate loading with aesthetic results. So let me introduce first Professor Ofir Fromovic, who is a leading global expert on dental implants, and he invented many implant systems for Straumann, BLX, DLX system, Nobel Biocare, Alpha Biosystem, and so on. that have influenced the world of implantology significantly. Dr. Fromovich graduated 1988 after completing postgraduate in orthodontics from the Medicine and Pharmacy Institute in Bucharest. He held a professor at the Annunzio University in Chieti in Italy in 2005. He is now a lecturing professor at Titu Maiorescu University in Bucharest, Romania. He has received various scientific awards and certificates of excellence for his contribution to academic education and science. His work created a global impact in research in the field of dentistry, specifically in dental implants and dental prosthetics. His main research areas are on dental implants and abutment design, tissue regeneration, GBR around dental implants, surface technology, and biomechanics. Professor Fromovich has lectured extensively nationally and internationally. He has also conducted many advanced implant and life surgery courses. He has authored and co-authored books and contributed to book chapters in implant dentistry and other scientific publications. His private practice is limited to dental implants and has received several honorary awards for his volunteer work with special needs patients. Professor Fromovich will speak today about new technologies which led to the development of stronger implant materials and surface treatment that could improve the healing process, facilitate osseointegration, and thus increase the treatment predictability, and also reduce the overall treatment time. On the other hand, immediate implant protocols that have revolutionized implant dentistry have become more popular, and we are validated as safe and acceptable treatment modalities. A vast body of scientific evidence confirms that implant primary stability plays a crucial role in the decision-making process for an implant to be immediately loaded. Thank you very much, and with no further delay, please, Professor Fromovich, take the floor.
Professor, we cannot hear you.
Please,
Okay, now you hear me?
Yes, we can hear you now.
Okay, I share my screen, but I don't see it.
You need to go to your PowerPoint. That's in your tab below.
Yeah, the PowerPoint. I do it before. No, I do share. Yeah, I know. I do the share. Entire screen, and then I put here, and then I do the share. But still, I don't see it.
You need to, after you share the screen, you need to open the presentation from your computer.
Okay, the presentation already open, but let's see. Let's see it. Okay, we open it again. Yeah, my presentation is open. Can you see it?
Yes, we can.
Okay, so thank you very much, all of you. Bună ziua. I will speak in English. So what I like really now to reflect, and first of all, I do it all the time, and I like to do it the same. I was graduate in Romania, and I'm very proud of it. So all what I achieve is come from the background that I get in Romania, and I like to thank the university and all my professor that was helping me to achieve what I achieved. So, mulțumesc frumos. I will go to English, and what I like to talk is the 5th generation protocol and behind the implant. And this is, as Simona said before, I was invented the Alpha Biosystem, and I was the owner, and then I invented the Nobel Active Implant System, and then lately I developed the Straumann BLX TLX, what I call the 5th generation implant, because this implant can work on a 3D. So when you look more deep to try to understanding biologically and mechanically to find the best solution for what we have to achieve. So the idea comes from the nature, when I was looking at clue of animal, lion claw, eagle claw, I see that they can penetrate easily to elephant skin, crocodile, whatever. But when you need to take it away, they have a very good stable. So the idea of looking inside to see the logarithmic, to see how it's work, I find something very fascinating, that the insertion would be with no friction and the retention would be very high. So I decided to take the lion claw and make it as a thread, but as you see on the left side, I make it both sides. So it can go to right and left. So it means this implant can work forward and backward. And with this implant, what I call an instrument, I can do many very special things, especially when I go to immediate loading. So just a few clue about this instrument. As you can see on the right side, this implant or instrument have a round apex to protect Schneider membrane or nerve or whatever. And it's a dual dip thread. The dual dip thread is exactly like a two drill that start to lead this implant and give the first fixation. Then we have dual horizontal condensing thread. Each thread is like a lion claw, is double. And if you look on the left side, you see a big cortical cutting element. This is, you can see here both nicely, is the lion claw, both of them, with the full dynamic chip flute. This is like Archimedes that will take the bone or whatever up where. Between the thread, we have a C shape. As you see here, this is like a round osteotome that condense. And then is a progressive dual double thread design that go up and down, and a very small neck that can go for bone level and can go for tissue level with a scratcher for the abrasive system and Volkmann canal. So this instrument can do cut, collect, condense, and disperse. So if you look here very nicely, and you can see it here, you can see on the right side, on the left side, you can see that I have an artificial bone, that I have an undercut here between the perspex, and I have vertical and horizontal drill. So if I place an implant, and as I say, this implant is doing cut, collect, condense, and disperse, what it means is that the implant will feel the density of the bone. And if the bone will be soft with elasticity, this will condense it. If the bone will be very hard, that will jump to the lion claw, this bone will get cut. And this bone will move on the dynamic chip flute or the Archimedes screw and will push by the inside, by the C-core, will push to empty space or to create like lamina dura. So if I will place it, you can see the movement of the bone and you can see the condensation here that will appear. So look at this. On the right side, you can see what happened. On the left side, you can see that this instrument start to push bone to make like lamina dura and start to mix it. So the red color start to mix with the white, start to mix with the blue with the red. So it means when I go forward and left, everything is working. Now I take the perspex away and I will take the implant out. When I take the implant out, I will take air blow and take it away, and you can see a beautiful condensation that look like lamina dura and very soft around. So it means this implant will achieve what another implant can achieve in 1 year. This can be achieved in 1 day because it's making the lamina dura like the one. Now, if you see here 2 red line, and the question is why you have these 2 red line, to this red line is because the implant or the instrument feel that it don't need to condense because it's an intimate relation between the implant and this one. And then in this implant, we have a very special connection that called torque fit that have like interdigitation. So we have 7 degrees of Morse tapered, modified thorax, tube in tube, and everything is with rock solid, of course, is a very special and very good material. So the idea of this was an holistic approach of sharing energy. So when I was designing this implant with Straumann company, we thought about everything. We thought about the occlusal stress that have to come, and now we share it with contact point. And we thought about the connection for the biological width, to keep the biological width in a very narrow place. We have 2.7 millimeter there to keep it. And then we share the stress on the cortical or on the sponges. That it has to be a very, very special way to share it. So if you look at final element analysis on the right side, you see a very high stress of the red color, and you see that the implant is really equal. So it's mean if I take this implant and recommend to put it in 70 Newton, what normal implant don't ask you to achieve, it means that each part of this implant will have less stress than another implant that have, because all these 70 or 80 Newton will be shared nicely all around this. So it means it will be very safety and very good for immediate loading. And then still, I will not need to make a very big hole and to destroy the cortical and reversal system, because this implant can stabilize himself even in a soft bone without making damage. So it means I can drill very small and use an implant that condense and make the spongeous bone to be like laminatura. Now, the advantage that we have for biologically is that we can have one abutment for all the diameter of this implant, that this would be a biologic achievement, and of course, very easy to work with the system. You can see here the implant that was placed on the bone, and when I take it out, it's full with bone, and it's made like lamina dura in day one. And of course, we use all the Swiss precision of Straumann to this company. So in general, I don't want to talk too much about the implant. I want to talk mostly about clinical experience, but just to let you understand that we have here a very special implant. That the implant is doing cut, collect, condense, and disperse. It means if I make a small osteotomy, the implant will fill the bone 360 degrees and condense when it is soft, will cut when it's hard, and will disperse the bone all around it. So I get like lamina dura. The head of the implant is small. All the abutments are small with a very narrow emergent profile, like a tulip. So I have all the conditions to have the best experience with this implant. Now, this implant will work, each 2 millimeter of this implant will work like a full implant. So if I take an 18 millimeter implant and just place it 10 millimeter, it's full 10 millimeter that can be for immediate loading. And you will see it now in there, what I can do with this implant. So one of the quality of this implant that it can change direction, but normally this implant you drill straight and you place it straight. You don't need to change direction. But in case for here, for example, that I see the socket that are very close distally to the tooth, and if I will place a normal implant with a normal grip protocol, the implant will escape quickly and will be more distal. Now this I can drill a little bit on this angle, place the implant and make a little bit stress, let the lion claw to work more mesially, and then I can rotate the implant and place it on the exact location that I want, and this due to the lion claw and the active of this implant that can really fit himself. And of course, the osteotomy that I do is very small. Now let's see cases that I can do with this implant that can really change my clinic and give me a very good benefit. So for example, we see this patient and look how narrow is the place and how missing that we have here. You can see the X-ray here. So in a case like this, that is a very big defect. Normally, when you use a normal implant system, you need to drill big and to place a big place. So I drill with 2 millimeter, 2.2 millimeter more palatinally, 2.8, and you see that I don't have enough bone here. So it's mean the 2.8 is the distance from here to here. So it's mean it's almost nothing. It's less than 2.8 millimeter here. So by placing this drill here, and the core of the implant is a very small core, I will start with this implant with this direction, and it looks funny. But the idea of starting this direction is not to break the buccal bone, is to let the lion claw to work more palatinally and to achieve in the art cortical palatinally to give more engaging. So slowly, when I place the implant in this way, I can really position it in the right place. And normally is a tip for you. If you want to have a beautiful aesthetic in any implant that you use, but especially in BLX and TLX, you place it 2 millimeter below the bone and 4 millimeter below the CG. This will give you long epithelial junction because this head of the implant is very small and all the abutments that coming are very narrow. So this will create you the beautiful aesthetic that you can ever achieve. So I place the implant below the bone. I use a small abutment here. And of course, I'm going to use bone augmentation material. And normally you put bone augmentation material in 30% more than the process that you need because this will resolve a little bit. You put a membrane. Don't let the membrane to touch the abutment and to touch the teeth because we want a biological closed sealing here. And a closed sealing is where you have bone augmentation with clot and the gingiva, because if the membrane will touch this and this, some fluid bacteria can really penetrate easy to the membrane and we don't want it. Another tip is don't put the first temporary crown below the gingiva, put it above the gingiva. So this will let the gingiva to hypertrophic and to have more gingiva. And after maturization, then you can really remodel it to make ovoid pontic around it. So prepare the tooth very nicely, very small, very smooth. And then you can use a rubber dam, place it, and don't go below the gingiva. Even, I will say, make a space, and this space will create with a gingiva hypertrophic immediately. So you can see before and after. So you can see that I will have a remodeling, very nice, and I can keep very beautiful aesthetic in this area. So you can see before and after. You can see now that the gingiva is already more up. And this is really very fast because in another implant system, you will really to do some implantation, expect, you know, it can go for 1 year or more. Look at another case. Similar case, but here I don't need to change direction. I can go straightly. So you can see the CT and you can see that we don't have enough bone. So you can see here, we have a little bone and we have a very big defect. But as I told you, this implant can really achieve very nice stability. So I clean everything very nicely. As you see here, I don't need to change direction because I have enough wide. But you can see here that my measurement is 12 millimeter inside the bone and 18 millimeter to 2 millimeter below the bone and 4 millimeter below CAG. So I drilled the first drill, then I drilled the second drill. I take 375 millimeter implant and 375 millimeter implant with this rock solid and special material can be good for all indication, for molar, for everything. So it's very, very strong. So I put it there, and when I have 12 millimeter is enough. So because I can engage in 12 millimeter, as you can see here, leave it up. It's very, very, very strong. 2 millimeter below the bone, 4 millimeter, put bone augmentation, and exactly the same procedure. Okay, a lot of bone augmentation, don't cut the gingiva, and you can see here. You know, I will get a nice result on the implant here better than the tooth because I can really put the gingiva more up and get more nice aesthetic here. Let's see another one, and I try to explain how I do the immediate loading and give you some tips and tricks to really know how to make it, especially with this implant system. Of course, you can do it with another implant, but with this implant, it would be more easy, more safety. So this case have to be extract. We have fracture, we have no support. So first what I do, normally I take the diamond and go on the epithelium before I extract, because when I do immediate loading, I want a nice, clean epithelium. So I cut the circular ligament, I cut all the debris that I have on the tissue because the tooth will go away. And then you have to extract the tooth. Now you have to be careful not to break the buccal bone. So whatever you try to take this implant out, try to use both sides. It means you start from left and right and do it slowly, slowly. You have some special instrument if you want to push it away, which you make like impression and you take it away. You can use many other systems, but whatever you do, do it slowly, slowly, because the buccal bone is very important for us and we want to keep the buccal bone. So you do it static, and as you see here, I'm using two instruments from left and right, not to extract a lot of stress on the buccal plate. And this will allow you more easy, because if you just use one instrument, you make a lot of pressure on one side. So by using two instruments, mesially and distally, you make more vertical pressure than outside pressure that go to buccal, because the palatinal is very strong and all the pressure that you do will go to buccal and you will break the buccal. By cutting the diamond, you cut the fiber, so you liberate the teeth more and it will be more nice extraction. After this, I take the diamond and I go over the gingiva and the bone. I want it very clean because I want a nice repairing. Then I will check exactly where is the buccal bone. Because as I told you, I want to place the implant below the buccal bone. And this will allow me to see if I need to peel the bone or it's ready used there. So you can see here now everything is clean. This will be the preparation. This will be the inclination that I want to place the implant. And now I can check and see that I have the direction because I want to build more bone to the buccal. Because if your implant will be very close to the buccal bone, you don't have circular, you don't have the PDL, you don't have the anastomosis of the blood. So a very thin buccal bone will resorb. If I place the implant more palatinally, and I will place some bone there, so as a compensation for missing of the blood that the PDL have, I will have a compensation of a wide of bone that will keep it. What I was writing an article in Charles Babbush's book, 3D critical size. So it means if you have a very small bone, it's resolved. If you have a wide bone enough, it can keep. What I do first, I put a drill inside the hole, the socket, and place bone. And then normally I go left a little bit with the drill. He's showing in the video right, but he's left. And to push the bone around it, but still to leave open the space that I want to place the implant. This is the BLX implant. You can see I will take it very sterile out of this. And then I can really put some direction, in the beginning, a little bit direction, let it fall, and then I will really place it to the place that I want. And it was done exactly just to give you the direction that I want to give you. You can see on the left side, yes, that now I like to take the handle and then place it on the right position. And as I told you, place it below the bone. You can see on the right, on the left side, both of them. And you can see that I will orientate it, the thorax to be facing buccal. So if I need to use angulated abutment or whatever, I can use it in a very nice way. And this is very nice. And then you can see that the torque that I have achieved is very nice. Yes, even when it's so narrow, I can get a 50 Newton and an 80 Newton in this implant. Now, as you understand, the implant, as I told you before, each part of the implant is working like a separate implant. So if I have, let's say, 10 millimeter full of the bone and 6 or 8 millimeter outside of the bone, this implant is still very strong for immediate loading with immediate extraction, as you see here, because the stability, all this lion glue and the mechanism was condensing the bone, give you a very high. Now, the core of the implant is small and the threads are very big, so it means you have more bone from the buccal to the core of the implant. So facing another implant that have very small thread that you don't have enough bone because the other implant is really full, the socket. Here, no. Here you will have a lot of bone and a very good stability, and then you can really go to a beautiful aesthetic. Now, after you can see that we have the torque and it's very good, because if you don't have experience and your torque is below 35 Newton, I don't suggest you to go for immediate loading because no need to take the risk. But if it's really stable, then you can really go for it. So you can see it's 50 Newton and 80 Newton is very good for me. You can see it before, you can see on the right side with the implant on the level. So we have bone around it. And then I decided to do the multi-unit abutment. Now the multi-unit abutment are in different height. What is important is to keep the biological width at least 2 millimeter, because if you will not support and keep it for 2 millimeter, you can have a resorption and moving of the gingiva, because this is the minimum need for the body. It's like when you do a normal crown preparation, you never go to the level of the bone and put the crown there, because then you know that you're going to have a resorption of the bone to accumulate the biological weight. Same is with the implant. So what I do normally is place the implant 2 millimeter below the bone and take 3.5 millimeter abutment. Now the 3.5 millimeter transgingival abutment will allow me at least 2 millimeter of free gingiva, because I'm 2 millimeter below the bone, I'm 3.5 millimeter above the bone, and this will create a nice space for the gingiva to really heal and to have a very beautiful aesthetic. So you can see it here. I place the multi-unit. Now when I'm orientated the thorax to the way I want, then I can really fix it. And then you close it to 35 Newton, each one of these abutment. Of course, if your implant is 35 or 40 Newton, then close it to 25. You don't want to exaggerate. Now look all this space. This space I will fill with bone. And I don't care if this bone is resorbed, but this bone will give me a support and this will remodulate it. So this connection is so intimate, because every interdigitation connection with the thorax and the 7-degree and the thorax with the support. So I don't have a pump effect. I don't have a micro motion. So you will see many times the bone is even on the abutment and stay there for a long time, because this system is so stable and so precise. Don't forget that Straumann is using rock solid, that is zirconia with titanium for the implant, and titanium with niobium for the abutment. And so we have hemidesmoson connection, we have a very nice surface for both of them, and everything, of course, is very precise and no pump effect. So you can see it here. Now you can see the direction. This pin that lead the abutment will let me to know exactly the connection that I want, the direction that I want to have. Now, I have another idea, is I take the metal sleeve, the temporary metal sleeve for the multi-unit abutment, and I coat it outside with acrylic or with composite. Now it will be ready for me to really put the temporary crown of them. After I place them, I still put some more bone, but remember, you don't have to push too strong, because they have to be spacey between the bone. If you put bone augmentation and you condense very strong, you don't let the blood vessel to go between the chips of the augmented bone. So just lightly place it inside and then clean it to leave like 0.5 millimeter of no chip bone below the clot, because the clot is the way that the gingiva will jump over and will give you everything that you need to have it nicely. So you can see it here. Now, why it's blocked? Okay. Now I took, so I have to put my power socket is jump away. Good. So now you can see that the guy was coming with a temporary crown, and this temporary crown, I took them to use them as a temporization for him. So what I do, I just trim away very nicely what he can with the temporization that he can. Then I make it like a shell, and then I try to see that it's not going below the gingiva, and it gives us the nice smile design that I need to have. Then I put some composite or acrylic, attach it, take it away, and prepare it. Now, another tricks and tips that you need to know if you want aesthetics, so don't go below the gingiva, let the gingiva to hypertrophic, make this buccal to be flat, don't make it curved, because if you make it curved, you let the gingiva to be run away. What we want now is to have as much gingiva over it. So we make it narrow and smooth, and you leave a space for the papilla. Now, when you do all of this, you have a chance that the gingiva will remodulate. You keep the biological width in a very nice way. And then you have a lot of chance that after maturization, you can really make ovoid pontic or aesthetic the way you want, and this goes fast and nicely. So now look here. So as I told you, you don't need suture, you don't need nothing. Just let the gingiva to be free. Look at the left side and see that the gingiva is free. nothing push the gingiva. So it's mean when the healing, this is very clean, and when the healing will occur, this gingiva will jump over, and this is what I want to see. Now, when I look at the type of occlusion, and don't forget this is flat, so it means gingiva can jump over. I put it in, as you see, and with the screwdriver, you close it to 50 Newton. This is very enough. The screw are very clever, very good screw, and the system are very reliable. What is important that when you're going to do the occlusion, you make a centric relation contact and avoid guidedness, because we don't want to have a lot of guidedness on an implant when we're going and doing immediate loading. So we will make the guidedness on the natural tooth, and we keep it in this nice way. So you can see light contact, and when I do guidedness, the guidedness will be on the canine and not will be on the frontal tooth that I have here. I decided to make some composite to make it some more nice for him, you know. So we make some composite because it was under the anesthesia, and I want to surprise him with a better smile. So because I saw that for having smile, we need to make it a little bit long. So a little bit composite etching bonding. When he wake up, he will be very happy to see that he have a very different smile, a nice smile. This is very important. As you see, you look at the X-ray and you see that we build a lot of buccal bone, okay? And not only buccal bone, we have big cortical stabilization. We go from the upper part of the floor of the nose to down. And if you can see, even you can see some bone was pushing out when we do big cortical, because this implant can push the bone outside. You can see it here, because if you do reverse and forward, the implant will inject bone augmentation upper. Or sometimes if you want, you can put some bone and it will push it. But here I did not push bone because I do reverse and forward. The implant was pushing the bone by himself outside with the Archimedes screw and this one. And now you can see that you have the long epithelial junction and you have the bone overheat. So this will keep for a long time and will give you a very beautiful result. We prepare it a little bit, you know, just to give him the shape that we want to give him. And see him when he come after the operation. Now he have immediate loading. All his teeth now are long, so his smile are more nicely. And look at him in the same week, he come to the clinic. He's very happy, no swelling, nothing. So this what we want to achieve exactly. Now look at another case that I will show you how I do transinusal. This is a doctor from Cyprus. This doctor is coming. And what he want to do is immediate loading, because he was before the corona. And I say, you are crazy. How we can do immediate loading? Look, you don't have enough bone. You have pneumatization of the sinus. Is going very much mesially. And if I can place is maybe if I try to make all on four, it would be too short between the two canine. So I cannot do cantilever. Look at your teeth down. So I decided to do transinusal implant, to take the BLX implant. Start here, open the sinus here, start here, going through the sinus, engage of the floor of the nose, exactly here. Use this one, go to the floor of the nose. So we decide to do 1, 2, 3, 4 implant here, transinusal implant here and here. There we go. And as a safe, because we don't know what keep, as a safe, we put 2 implant here and sinus. So this is really over-engineering. It's a lot of implant, no need, because we can use 4 implant or 5, 6 implant is enough. But in this case, we decided to go more because we don't know, the guy is not living here, he's living in Cyprus. So extraction of all the tooth, open the window and make extension mesially, because I want to see the direction that I start from here and go to the floor of the nose. This is the pterygoid implant, 2 implant for sinus lift. And as the extension you see here, we're going here through the sinus with bone augmentation and engage the floor of the nose. These are the 2 frontal teeth on the frontal. So 2 frontal and the transinusal. Exactly to the left side, exactly the same. Open, transinusal is 24 millimeter implant. Engage here, engage on the upper part, as you can see here, and exactly the same. 2 implant front, transinusal, 2 for sinus, and 1 for pterygoid. What I find out after replacing the implant, that this pterygo was strong, 2 implant in sinus, this is for later on. Transinusal was 50 Newton, 4 implant was very strong, transinusal over 50 Newton. So we decided to go immediate loading on this. The other one, the pterygo was not strong enough, so I decided to leave it. So you can see this before and this after. So you can see this was strong, 2 sinus, transgingiva is getting here, exactly on the floor of the nose, as you can see here. And now if you look here very nicely, you can see all the bone and all the other one, and you can see the transinusal that engaging the floor of the nose are very strong, and you see how all this bone was built here. So you can see before, after, and after the maturization when all the bone was going there. So this was in the same week he was going like this, and until now, he's going with the temporization. He don't want to do it. He said that he's feeling good and he is lazy. But the result of the X-ray is fantastic, and of course we can finish it beautiful way. Another case, it's that we do all in 6 because it's enough, but this lady decided that she wants sinus lift. So this was long time ago. We designed everything on digital, but I use a freehand for this. So we make a tray and we make a prosthesis to be ready. And then this shows us exactly where we want to place, so we can use digital one. And then you can see we place 6 implants. That is enough, okay? But the lady want more. It's okay. We can make more. 2 sinus lifts. So what we do here in a case like this, we make 6 implants. We make all in 6 for temporization, and we wait for the sinus. So she wait like 8 months, 1 year, and then we open, we change the temporization, and we go for the definitive one. So the lady after this get the definitive one. So this implant allow us really to make more easy, more fast, and more reliable treatment. Look at this case. This is a very old implant, 15 years old implant in the mouse that have a very big defect. Look here. This patient is an engineer, 75 years old, that was going like 1.5 years to different doctor and ask for treatment. Everybody say, okay, extraction, bone augmentation. After bone augmentation, we wait 4 months, then we place the implant, and then 4 months more. So 1.5 year treatment, and he have to go with prosthesis, and he did not accept. He came to me and I said, no problem. You're going to get today immediate loading. But now let's understand why the doctor was afraid to do. So look at the X-ray on the CT scan and look how big the defect and how dense bone we have here. This implant, the BLX and TLX implant, are good for type 1 bone and soft bone, because in type 1 bone, the drill protocol will be the same, and the implant will give me more space. So in type 1 bone, this implant have a very big advantage because you have a very narrow thread of 25 degrees that engage the bone and leave a lot of space for a new blood clot and a new regeneration. So we extract everything. Look how a lot of granulation tissue. So we take all the implant out from here. We clean everything nicely, and then you can see here, like the transinusal, I have a little bone. I can go here, go lingually. Here, you can see I have 12 millimeter. I can put an 18 millimeter implant, make bone augmentation, but 12 millimeter is full implant stabilized. That is very good here for immediate loading. So you can see now the implant direction that I place, you can see, and this is very strong. It can go to 60 Newton, 2 millimeter below the bone. Here I go below the bone as well. So I place all the implant 2 millimeter below the bone or even more. It's dependent on the situation. All the implants have to be the same level. And then I take a multi-unit, very high multi-unit. Bone augmentation, because I have a chamber. This is very long, like 3.5, 4.5. Small membrane. You can see not big membrane because I don't want to have the essence. I want to have blood clot here and here and here. This blood clot will close the gingiva in a very nice way. You can see the level of the bone, implant below the bone, long epithelial junction, and everything now look beautiful, and the direction is good. So we take an impression. Today we can take digital impression. Those times we took the normal impression. You can see how beautiful it look. all of it in the same day. We print very nicely, and the patient was going on the same day with the bridge. So this really can help us and give us a lot of good position. Look at this tissue level implant, a lot of the advantage of tissue level. This is my assistant, she broke the tooth. Same day, I don't drill because the implant have a very big thread. I just put bone augmentation and put the implant. Healing, I decide to change those tooths here. So we prepare the tooth, we prepare digitally, so you can see here that I can make the crown, the tooth, I can make it bring back, so I can make the papilla again, make the crown to the size that I want, so I can really decide where I want to place it. Impression, this is the part, and you can see, look, 18 months after, look how amazing is all the bone augmentation around it. So you can see before and after. Look at this girl. She have the smile, teeth are moving. She come to me and I say, what is the problem? You see, she cannot even close the mouth. So when we look at the teeth here, and when we look at the x-ray, so when I look at the x-ray, I was very happy because I see that I really need to extract all the tooth, because you can look here on the CT, all the tooth are really lost. When I look down, I was even more happy because I see that this is not good. So I can really modulate the lady and make it aesthetic and beautiful. So all in 6 is enough. So I designed to make a sculpture of her. So put it to anesthesia, make a forced smile because she was under anesthesia, cut the bone to have exactly SNA, SNB on the right position that I want. Then you can see that I cut like 6-7 millimeters of the bone, and I leverage after this all the bone to the same level. Place the implant more palatinally because I want to achieve nice aesthetic impression post. Upper and lower, you can see here, normally I make a small hole, see the sinus, and then place 6 long implant, 2 millimeters below the bone, 3.5 millimeters transgingival. And then you can see 2 days after how this lady look. Look how the faces look, how everything is more smooth, before and after. See here, see it here, and see before and after what we can do really in 2 days. And this operation was very fast to do. So see her here and see her here. Okay, about the white color, this was her decision, not mine. I don't like so white color, but she like white, and she's so happy that she changed the smile and have a white one. But this is exactly what we try to do. Now I have 5 minutes more, so I will finish with the last case, that is making Zygoma and BLX together. So for patients that really don't have bone and don't want to wait 1 or 2 years and don't want to go for sinus lift. So this lady is around 65 years old. Look at her, she don't care about herself, she don't feel good, and you can see why. So when I look at the CT, I see that she have a lot of losses, long implant that are really outside the bone. And if I look at the right side, I see that I don't have enough bone. So if I want, this is missing here. So if I want to do all in 4 and 6 or pterigo, it will be very difficult. And she wants something very stable. So I decided to share BLX and Zygoma together. So normally when I do these cases, I like to plan it before digitally. Sometimes I will do freehand or digital or tray, but I like to plan it exactly to see where is the crown will come. So because you lose a little bit of orientation for the prosthetic that you want to achieve later on in this case. And then you can see what I do here. So extraction of everything, but look here, I don't cut where I extract the tooth. I cut more palatinally here, and then I suture it. So it means first I go with diamond, clean the epithelium, cut here, and suture it here. Now when I suture it here, I will have more gingiva to the buccal part, because if you don't have gingiva to the buccal part, you can have the essence, especially in the Zygoma implant. So you can see here, I sutured it. Now I have more gingiva up. I was using a titanium tray to see the direction that I want to place for the implant, because for the Zygoma is really orientated on the nice position. My idea is that I use Zygoma or Normally, zygoma is a normal implant. I don't want to go to the protocol that zygoma start palatinally, go to the sinus and go to the zygoma. Then normally you can get a lot of inflammation, you can get a lot of sinusitis and periimplantitis because you don't have enough bone here and a lot of bacteria can penetrate easily to the sinus. So if this zygoma will be full of bone around it, I can know that it will be protected biologically, and this is the way what I do. So I mark where is the zygoma have to go. I cut it here and I make slot, as you see here. I open it, I go below the orbita, clean all the ginger, take the Schneider membrane out, put membrane inside, as you can see here, and make the slot. This will be filled with bone. It's bone below, and then this one. So now I can go to the zygoma, and I know that I separate the zygoma from the bone. So you see, fill it with bone, start to place it, and now start to place the zygoma. This is a Zaga implant by Straumann. Have a flat surface because we all want to have more bone here, and we don't want to have the essence. So I place the implant. This is the pterigo. This is the BLX that coming on front, even with all those defects. Fill everything with bone. Here I decide to put membrane and to use the fat from the chin because it will give me more nice epithelium around it. Taking impression the same day. Here I do a scarf tissue. So I see that I have more tissue in the palatinally. So I take this tissue and put it forward. And then this was the right side, left side, I'm doing exactly the same. Open the slot, exactly the same techniques. And you can see the implant, you can see all the bone augmentation around. I love to have more bone, even here. I will put some more bone. And I go lower, and you see lower, I do the same. So lower, even if I have those defects, yeah, it's no problem for the BLX. Because you put it 2 millimeters below the bone, 3.5 millimeters up, and then you put bone augmentation here, and it is very stable to get a very nice healing. And then you can see now the X-ray. So the two zygoma is here, the pterigo, as you can see it here, very strong, 4 BLX and BLX down. You can see it here, you can see all the bone augmentation all around, that we have a lot of bone locally, and look here, you can see how nicely we have bone around the zygoma for both sides. So this is really amazing to have zygoma for both sides. And look what happened to a lady that she feel good. She start to make up, she start to dress, she smile. And this is why we go to the clinic. We want to change the life of the patient. From a patient that are negligent and don't feel good, we want to go to a beautiful patient that are very happy. So what I try to show you here today is how we advance with the techniques, with biologic understanding, and with the implant that Straumann was putting, because this implant really changed my life and many other. You know, I have to tell you to be careful because it's like drugs. If you start one time to use this implant, you will be less secure to use another implant because it gives you a lot of confidence. And the idea that I go to my clinic is really to help the people, because for me, the develop implant and to doing implantology is a mission. And I recommend you that when you go to a clinic, the first things that you think about the patient, that you treat it like a father, mother, and sister, and then you don't need to take care about nothing because you will be success. And with this, I like to say thank you very much for listening to me, and mulțumesc.
Thank you very much.
Thank you so much for your contribution and for your help. Mulțumesc frumos, prietene Ofir.
Plăcere.
Thank you very much, Professor Ofir. And now, according to the program, there should be 15 minutes break. So we can meet each other at 11:40. Is it okay for everybody? Professor
I think yes.
Constantinescu?
Now in program is coffee break. See Dr. Demiraki from Albania, from Tirana is available. It's okay to continue. Check in technical department and communication with you.
Okay, so Professor Constantinescu is proposing that we proceed without the break. But anyway, we are a little bit ahead of the program, so at least we should wait until 11:30, so we can do the technical break a little bit shorter, and we can see each other in 5 minutes. Is it okay with everybody? 11:30 continuing. Thank you very much. So I see you all here 11:30, and have a very nice day, Professor Orhim, and thank you for your very beautiful presentation.
Thank you. Bye-bye.
Hello? Can you hear me from the technique, please?
Yes.
Yes,
Is it okay when we start now? Do we have
the next
Dr.
presenter?
Gurian?
Yes, Dr. Gurian is here with us.
Perfect.
Hello.
Hello, Dr. Gurian Demir.
How are you?
Hi, I'm very fine. Nice to see you here among us. So let me introduce you. Dr. Gurian Demiraki graduated in dentistry at the Tirana University in 2003. Then he specialized in oral surgery in Germany, and he was lecturer. And between 2009 and 2015 was the chair of OMF surgery in the dentistry department at the Albanian University. He has a master and PhD in oral implantology. He's very well known international speaker and organizer of various professional courses, opinion leader for dental industry, and author and co-author of many articles about oral maxillofacial surgery, orthodontics, endodontics, and implantology. He has invented the sticky tooth grafting material and was co-inventor of the Baruti-Demirakai approach. He is among the top 100 doctors in dentistry in 2020 by Global Summit Institute GSC and Committee at Academy of Oral Surgery AOS member. He is Albanian president of International Academy of Implantoprosthesis and of Osteoconnections. AEO, and visiting professor at the University School of Health in University, California. So Dr. Demiraki will speak today about what can we do to save teeth and implants. And in his abstract, I would take out that autologous bone graft is the golden standards reference graft, and another similar materials would be an extracted tooth, and some systems currently allow an extracted tooth to be transformed, ready for autologous implantation. To use autologous bone and tooth graft whenever possible presents a procedure not always easy to apply. The procedure for soft and hard tissue graft preparation is not always simple and requires time and skills. However, the obtained graft exhibit very good stability and easy to use. Implant management system and those that create implant emergency profile comparable to natural teeth are also very valuable asset in the hand of the implantologist. New concepts of the placement, like the one umbrella incorporated into the strongly influence the long-term success. With any further delay, I would recommend that Gurian Demirakai takes the floor and speaks to the honorable audience. Thank you very much.
Thank you. So, can I share my screen now?
Yes, you can.
Okay.
If you need assistance, we are here to guide you.
Yes, thank you, because I don't use very much Meet.
In the lower part of the screen,
Yes.
bottom part, you will see a few buttons with a microphone, camera, CC, a smiley face, and the button on the right of the smiley face is the share screen button. You need to press it once. And now a pop-up menu should appear.
Okay.
And in the top, you will see a few different options. The first one is the tab, the Chrome tab, then a window, and to the right is your entire screen. You need to select entire screen.
Okay.
And then press share. After you selected entire screen and selected your screen.
Well, it's not available, the share, because someone else is presenting according to what you're saying.
Okay, 1 second. You can try now.
Still not available.
I closed the other presentation.
When you try to present, what message does it say?
There is no one to. So it was someone else presenting at the moment, according to this here. And if I say here share screen, I can't.
Can you go to the
Try
top?
if I can share some windows and so on. No, it's not. So it's not. I can't share my screen.
Can you
According
go
to
on your browser? Can you go to the top left where you see a microphone in the address search bar? You should see a microphone icon.
yes.
Can you press that? You should be able to see a drop-down menu with permissions, meet permissions. Do you have disabled the share screen permission?
Let me check because I can see now which one is which. Okay, wait a second. Now I can't press neither of the buttons. What do you mean? So I have here in the settings, general video.
Oh, you're looking at the settings? No, that's not required.
Where should this one be?
Let's try to press the present now again. It should pop up the notification to force enable it.
I pressed again the one from before. I try to share my entire screen and it can't share it again.
You need to press entire screen. After that, select entire screen and confirm by pressing share. You need to press the entire screen again.
Okay, now it's doable.
Okay, there we go.
Now I believe now it's okay. Can you see my screen?
Yes.
Yes, we can.
Perfect. So let us start. This lecture is meant for everyone, so I hope that everyone will learn something from my presentation. Because as an old say from Lao Tzu says, give a man a fish and you feed him for a day, teach a man how to fish and you feed him for a lifetime. So the ultimate goal for every dentist should be that the teeth and implants live till their life's end, possibly. But we know very well that teeth and implants need enough bone and soft tissues around them, no presence of infection, no occlusal trauma, and much, much more. The good news is that the patients are accepting our implants more and more as a solution, but they want less surgery as possible and they want more aesthetic results than before. Just to remind a good old say from Professor Linde, the bone sets the tone and soft tissue is also the issue. So what are these issues we are talking about? When we remove a tooth, we will have dimensions in white, according to this study from Horowitz and Associates. The dimensional loss in white after the 3 to 6 months after the instructions are 3 to 6 millimeters in wide, 2 to 3 millimeters in height. So it's a very considerable loss that happens directly after we remove a tooth. And going back to biology, osteon, which is the principal building structure of the bone, has this configuration with 0.25 to 0.35 millimeters in diameter, and the length, which can go till 1 centimeter in the long bones. Actually, it's much smaller in the jaws. So, giving you some food for thought, is it easy for this type of very small structure to try to fill this large gaps that we can have and that we can need to fill, such as this one, which is around 4.5 to 3 centimeters big. So it's very difficult for the bone to fill this gap. We learn a lot from theory, we learn a lot from practice, and we learn even more from mistakes. And some other good thoughts: a good physician treats the disease, a great physician treats the patient who has the disease. And other similar saying that the patient is the one that we need to, try to make him heal. And these are the concepts that we currently use to do that: osteoimmunology, a biological treatment, and of course the long-term care, which is very important for us, for our patients. Very important is that we start with very good knowledge of the patient's state of health: anamnesis, clinical considerations, lab examinations, interdisciplinary consultations, which are often required, but not often very well given and taken from our profession. Necessary blood analysis: well, I check very well before I start my treatment, and we have seen that a lot of patients have got a deficiency in vitamin D. Lately, that we are checking in most of the patients that we treat, most of them has got deficiencies with very low vitamin D in blood and high cholesterol, which normally doesn't help our patient. We need to have a very good preoperative condition if we want to start with a good healing possibility. So we need to have a very well and a very clean site of operation with very good preoperative hygiene. And of course, if we want to treat teeth that have lack of bone, we need to fix them preoperatively. And of course, we need to very well check the occlusion, because many of our cases start with bad occlusion, which makes then the situation very bad. If we don't fix it priorly, the chances of our case to go in good direction are very low. What do we need when we start some surgery? Of course, we need a good surgical set, which is different from the surgeon that is creating it. It takes some experience to have a good knowledge and good knowledgeability of what we are using and what we often use. Of course, this one can be enhanced all of the time with new stuff that we need. And also, other things that I'm bringing to your attention is the BCGF, blood concentration growth factor kit, piezo surgery, which is very important in my cases. And of course, we need to have a good field of view. This is some of the instrumentations that I use to create the field of view. Of course, you can use others. Of course, I'm giving my suggestions because I want, to give my opinions and what we use in our clinic. And of course, trying to be able to maintain the mouth opened. And this is some of the standard kits that we use, which allows us to have a good suction and to create a good field of view. And illumination, magnification, recording. I've started with 3.5 times and now I'm going to 6 times. I use the microscope not much, but most of the cases we use the 6-time magnification at this distance of 340 millimeters. And of course, a very good field of view created with a very good illumination. And of course, it's very important that you record your surgeries, because as I told you before, you have to learn also from own mistakes. When you receive your cases, of course, there is something that it could be done better or could be done differently, which can improve the next cases that you use. So it's very important that in the 21st century, you record your surgeries. I'm using this camera that is mounted in my head here, but of course, many other possibilities are to be used. A laser, diode laser, I use in most of my cases, very important, because it helps me clean the surgical operatory place. And this is one that I use. Many others, of course, can be used. And this is how we proceed with our surgeries. When there are major surgeries, we have a table that is non-sterile and another one that is sterile. If we want to, do extensive grafting and cleaning and so on, this is, in my opinion, very much appreciated. Anesthesia that we use, local anesthesia is, of course, the one that we prefer, but however, it can be enhanced with the intravenous anesthesia. And of course, if the case is very big or the patient wants to, be much more serene, we can also go till endotracheal intubation, which is, of course, an anesthesia that needs, of course, an anesthesiologist. But even if sedation is done, most of the time we require an anesthesiologist so that all the patients is controlled, and of course he can take the blood for us and other stuff that we are going to show in a minute. As I told you, blood analysis, if we are using general anesthesia, are a must. So in this case, X-ray, pulmonary X-ray, perhaps sometimes are needed, EKG with patients of cardiac diseases, and other interdisciplinary consultations according to the conditions of the patient. These are, as I told you before, the blood analysis. Let us come to the main problems. We need bone grafting, which, of course, we know why we use it usually. These are the indications: solid preservation, periodontal disease defects, failed restorations, implant stability to reduce the time to complete restoration, and, of course, aesthetic demands. As I told you before, the bone sets the tone. What do we look for in them? Well, in short term, we need to, have them with complete turnover, those to be reliable scaffold, bioactive to instigate the remodulation, provide quick results, to be easy to handle, and to minimize the risks. So performance and predictability. Other considerations, of course, are indication and grafting sites, age and state of the health of the patient, medication of the patient. Smoking, of course, is very important. So a patient that smokes is very difficult to, keep good hygiene, and will make it very difficult for you to have a good outcome. Doctors' skill sets and experience are, of course, needed in this case. And patient considerations, because some patients, perhaps out of religion and more, wouldn't like to, that we handle them in a certain way. What do we see in practice? Not always the thing go well. We can see graft loss, bone recession, unpredictable result, and bone loss where we cannot find it where we had. We can use allograft, xenografts, synthetics, and of course autologous, which we can divide in bone and tooth. The last one are my favorite. When we talk about autologous bone, of course, we need to have some place to get this bone. And where can we get it intraorally? The retromolar region, maxillary tuberosity, and the chin are the places where we can get a large amount of bone. But, of course, these are some of the instrumentations that we need in this case. And the good old-fashioned surgical hammer and chisel. However, not all the time we need a very large quantity of bone. So the implant site with an osteome like Unica that I'm showing here, which can take with small rotation bone chips in the implant site, but of course not only there. And these chips, you can use it alone, or you can mix it with tooth graft. You can, of course, mix it with other biomaterials in order to have a good mixture of autologous bone plus the rest of it, in order to, have the good properties of autologous bone and cells to enhance your graft. Another way to get autologous bone are the safe scrapers, which being a big fan and using them for several years, as you can see, I have a large collection. But the later ones, the twist, are very much recommended because they can scrap very easily cortical bone, and you have autologous bone available from the patient, which can make your grafts stable, and you can use them soon enough. Another source of bone graft, autologous bone graft, is the tooth. Well, of course, it requires teeth and processing of it, but it's not a good thing that millions of teeth every year, or even more worldwide, are not used as autologous graft. How can we do it? Well, the procedure is easy. The one that I use needs 7 or 8 minutes to process. So you extract the teeth. Afterwards, you clean it. You make it dry and ready to grind. And you grind it with 13 seconds sequence, which can you, of course, repeat it as long as you finish the grafting that you have. And afterwards, you have some cleans to do to make this graft bacteria-free and to make it available to, use. So this is shown as it is. So you clean, you dry, you place it in the chamber of the Cometa Bio grinding machine. You sort it, you extract this graft, you apply the cleansers to make it clean and bacteria-free. You place it and you suture it. Of course, another most welcome and better improved one is to make it sticky tooth, as I've been doing it for many years. So this is a procedure in real time. You take autologous blood from the patient, you centrifuge it, and the fibrin will start to clot, and in a couple of minutes, you can, of course, enhance it with pre-clotted grafts. These are the clouds that we use usually. And we crush them to enhance the growth factors, bone morphoprotogenic proteins, and stem cells, which are in the circulating blood, to enhance the properties. As you can see, in real time, it will start to clot. And will become sticky and with a consistency that allows it to be placed very well and to be stable where we place it. So as you can see, this is a very large quantity in this case. There are at least 4 wisdom teeth, for what I remember in this case, which is around 12 cc of biomaterial, autologous biomaterial available in a short time to use in your big grafting procedures, as the ones that I'm going to show you. The research done in this case is very old. We have research done since the 70s. And of course, we know very well that the components inside the bone and the teeth are similar. But of course, there is bone morphogenic proteins and growth factors, which are more in the tooth than there are in the bone. And according to the quantities, hydroxyapatite, collagen type 1, and water, they are similar to the autologous bone. So it's very easy and very good to use. So if we grind it, we will have super xenograft for the animal, super cortical for the dentin, and super calcaneus for the cementum. The pulp and the PDL would be eliminated through the procedure. About histo, as you can see, it handles very well. These are lots of histo done that show the ankylosis, which is very tight and very good between tooth and bone. Higher magnification, and of course there are lots of publications to back it up. Many of them you can find in the Comera Bio site. A couple of mine are also there. So if you have time and you can visit their scientific publications, you will see that many of them are available, and that can show you that this there is such a big research done in this direction, which of course makes make also sense. So the protocols, the mineralized tooth graft, which is the standard protocol, which, as I told you before, requires 7 or 8 minutes max from extraction to grafting. And you can, of course, partially demineralize the tooth graft for a bone acceleration protocol, which requires a couple of minutes more, and you have to, add one more component to the cleansing procedure, which is EDTA as a middle cleansing procedure, which enhances 1 or 2 minutes more. And of course, later on, you can make it sticky tooth with the use of BCGF protocol or APRF, PRF, LPRF, IPRF, whichever you are using. And of course, the tooth can be stored for further use. Even if we have a piece of tooth, we can, of course, use it later on. There are very nice studies done that shows the oncolysis and osteointegration of implants with bone and tooth. In this case, this is a very nice one from 2018, where you can see tight proximity of teeth and implant. As we all know, the autologous advantages, I'm not going to go through it because I don't have much time. And what about the soft tissues? Well, if you want to harvest some soft tissues intraorally, the palatal site is, of course, the most known and available one, the tuberosity, and of course, we can get some grafts from whichever place we can. Of course, we can use also some flap transpositions. A small quality of these soft tissue grafts can be found all over, and we can use them if we have them in excess. Roll flap techniques are used in implants placement. Displacement techniques are, of course, used. Soft brushing with the stretching of the soft tissue fibers is one of the techniques that I often use to enhance my grafting properties. In this case, this is the soft brushing kit. And in this way, we are making place for our hard tissue graft plus membranes, and we are stretching the fibers and improving our soft tissue quality. Another very nice procedure that I often use is the tunnel technique, as you can see in this case, which is very elegant and very, minimal invasive. And in this case, with the same soft brush tooth from Chacron and Simon Pieri, we can make place for the hard and soft tissue graft with this type of small incisions, which then later will be used to graft the sides. Of course, the fibrin clot is a good source of soft tissue graft, which is available in the blood. We have just to collect it. So how we do it? We take the venous suction set and we suction it directly from the blood of the patient. Then we centrifuge it. In this case, I use this centrifuge that I can show you, which divides the blood in these sections: serum above, according, of course, to gravity; white buffy coat, the cloud with fibrin clot. Directly beneath it is the growth factors and the CD34 plus circulating stem cells, the red buffy coat, which are clots and cells, and the metal ions are at the end, very end, which of course are the heaviest ones. All of this can be used in your grafting procedure, but the first two are the most important one. Of course, if we go back to biology, the circulating blood has got cells which can then, of course, be differentiated in different types of cells, which in our case, osteoblasts are the one that we need, or perhaps even the connective tissue. So there are many advantages of the use of autologous cells to regenerate a patient. It's natural, no side effects, no toxic tissue, promotes the clot in seconds, reabsorbed in days or months, and stimulates the reparative processes and tissue growth where applied, which is very well documented, but not in our short presentation to explain, because it can take hours to do that. And this is a protocol that we use, the blood concentrated growth factors, a protocol which is based on natural biological mechanisms, and as you can see, has no danger, and of course is can make a sterile dedicated protocol with several programs we can use. We are now proceeding with patient hematic parameters that can allow us to have a protocol which is exactly what the patient has according to their blood type and blood condition. But this is for the future. However, for the moment, we have this protocol which is working from 2012 till now. This is a very old video, as you can see, to create fibrin cloud and the serum, as you have seen, which is divided in this way. And after removing the serum, this is the fibrin cloud with, underwards, the CD34 plus and the bone morphogenic proteins that are in the circulating blood, together with the cloud with the growth factors, of course, attached to it. Membrane making, another old video, because I want to show that this is not something new and unstudied. We have been doing this for decades now. So this BCGF spheral kit that we use can allow us to crush it, as I have shown you before, into the graft, and to make it very easily usable, and to create our sticky bone or sticky tooth. And of course, to use it as a soft tissue graft. The white buffy coat, as I told you before, can be used as a filler, as a membrane, or to enhance the graft. Very old cases. And what happens if we have some old, exceedingly sticky tooth that we have? Well, this is a real case from 2020. A couple of years later, the patients brought us this sticky tooth that was old. As you can see, it's rock hard. But applying the cleansing solutions as the protocol of Cometa Bio shows, and we can reprocess it and remake it again usable in this procedure. We had an infected tooth, we removed, and then we added to that graft, and now we have some old and young one. And this is the new sticky tooth that we have in our grafting procedure, where we place an implant and we graft it immediately afterwards. Or you can use it for other procedures somewhere else if we need to use it. So, giving you some more food for thought, nature does not hurry, yet everything is accomplished. The aim of medicine is to prevent disease and to prolong life. The ideal medicine is to eliminate the need of a physician. So let's proceed with clinical cases. And stop me because there are many of them and I don't know how much time I have left. So sticky tooth cases, many of them, but this is one that I want to show to start. A perio use of this one, a female of 48 years old with a granuloma before in the regular 36 with furcation infection, some of the nightmares of perio, and the granuloma later on in the other side, same tooth. Why am I going to show it? Because this procedure was used in the same patient twice with the same result after several years. So this was the situation 2 years before the treatment of this tooth, a long time ago. This was the situation. As you can see, the endodont in this case was not so nice. However, even after the patient got a re-endo, as you can see, the furcation was problematic, and also there is some problems in the apical area. So in this case, we saw this fistula, which then later on we treated, as I have shown above, with autologous bone, used a little bit of biomaterial, and as you can see, this is the furcation after we treat it, laser cleaned it, and then we place autologous bone in it to fill the gap. As you can see, also the apical sites are treated. Afterwards, more sticky bone is placed in the apical receded sides. And vestibularly, as you have seen, the defect was very big, and we used some more to, create a good vestibular bone graft in this place, and membranes to enhance the soft tissue properties, and of course also to divide the hard and soft tissues during the healing period, which is very important because the bone morphogenic proteins that will act in the graft are opposed from the soft tissue antigenic situation that wants to destroy it. If we put membranes, we are going to stop it and make our healing very easy. We sutured it, as you can see, with DPTFE, which is one of my favorite non-resorbable suture. Detox it with good antibacterial gel during the healing. And this is the X-ray 1 year post-op. This is the intraoral situation 1 year post-op. And the problem started 2 years later in the other side, which were handled similarly as before. Notice the same suturing technique and so on. And the healing with CBCT, as you can see, are similar, which makes it a predictable type of treatment. A patient which was treated when he was 60 years old, which normally was like 12 years ago, with sinusitis and the broken 16 and the radix of 15 in sinus, with a dentulia of 36 and periodontitis, all treated simultaneously with extraction of 16, Caldwell look with the removal of and cleaning of the sinus, immediate bone grafting, sticky tooth, and immediate implant placement, a couple of one in the upper one and the 36 in the lower with BCGF membranes covering. So as I told you, this is a 12 years old case. As you can see, there is infection in the sinus side. Of course, this is the radix of 15, which was causing much trouble there, but there is, of course, no bone to place a couple of new implants. So we removed this tooth, and prior to doing that, we placed an implant in the lower one, so we could, of course, get also some more autologous bone from the implant site in the lower jaw. So as I told you, these protocols are very old, like 15 plus years old. And with slow rotation, we get this good quantity of bone chips to mix with our grafting. And here, these are the expanders that we use to expand and condense the bone before we want to place an implant there. BCGF membranes, the placing of the implant, which is impregnated with serum, plus the growth factors and the rest of it, which are in the circulating blood, which we can find in the clots. And I used in this case the glove technique, which with the help of fibrin allows us to create a very good condensation with the implant. And we placed some bone to graft it in this place and sutured it afterwards, plus injection of serum to keep it clean. Serum has very good antibiotic properties, which are in the first 24 hours much more enhanced than any kind of antibiotic that you can use. Keep that in mind. And then we go on with the procedure in the upper one. Remember, this is an old video from like 12 years ago. I started cleaning with laser. We created implant sites, and piezo was used to create a window, as you can see, which was removed. And then the membrane was perforated, and the small radix, which was this one, was extracted together with the mucocella. And afterwards, we cleaned, we added some sticky bone, sticky tooth there, because as you have seen, we have plenty of it to use. So the cleansing, the membrane is lifted, implants are placed, and as you can see, the procedure as before, with the glove technique, as I showed you, which allows us to have a bone implant contact as much as we can. We inserted the two implants, grafted very well inside the sinus and, of course, also out of it, replaced the bone, small bone cutting that we had before, BCGF membranes, and sutured it, which was the situation like 12 years ago. These were the implants, very well grafted and so on in the healing of the procedure. And this is, as you can see, the look procedure after the healing. This is also the lower one. Implants were placed, and all was well for like 10 years. But later on, after 10 years, of course, he was under control all these years. We have an infected 48 with exposed bifurcation of 46, which is a very nice perio situation that I'm going to show you, which I used the 48 as immediate sticky tooth to close the hole after extraction, so bone grafting in the site. And also I wanted to improve the situation of this recession in the bifurcal area of this tooth. So this is the extraction, cleaning afterwards, grinding. This is the sticky tooth produced, and this is the tunnel technique which I used to improve the situation in number 46. This is a graft in use, and this is the situation a couple of years later, and these teeth are still in function in his mouth. So a long time for this patient. Another one, 45 years old, vertical fracture of 15, resulting in bone resorption, bone missing vestibularly. I'm going to go fast. Vertical fracture, which makes it impossible to treat. We have to remove these pieces and use it. But as you can see, also, there is a big gap here, and we can't easily place an implant there because there is no bone. However, also the situation is very bad in the other teeth, which is 16 and 14. As you can see, there is a lack of bone vestibularly, which is, of course, even in other teeth. But since we are in this region, we want this one to be very well treated. So we removed the rests of the tooth, which we used for sticky tooth, detoxed it, and these are the fractured piece of teeth, some biomaterial plus bone chips. And this is the sticky tooth that we had. And we use cervical, which is a system to create a very nice emergency profile and to place an implant very well. So the cervical guide and the cervical mold are the two parts of the system. The one allows you to place the implant in very good prosthetic position, and the little one allows you to create a very good emergency profile. I could have gone and talked for this very long, but we don't have much time, and I'm just going to show you how to use it. So this is the situation after we use the mold, and we place some minor small tissue graft to enhance vestibularly even more. This is the retromolar graft that we took in this case. And this is the tooth after we finish the procedure. And as you can see, the implant is very stable, but of course also the 16 and 14 are well grafted, which will make them maintain very well their position. There is new bone everywhere. As you can see, the implant is fixed and very well. And the situation was much more stable as before. This is the result. And this is the result at 1 month and at 6 months after the procedure, which of course improves with time, as we know with soft tissue grafts. Another case, 58 years old with periimplantitis, unconventional treatment, bone loss in mandible, vitamin D avitaminosis, as I told you before, is a big problem. We did grafting and placed new implants in this case. This is a preoperative situation. This one is a grafted implant plus teeth, which of course didn't go very well. And this tooth here had problems and needed to be retreated. Of course, the situation was similar in the upper jaw. The patient wanted to keep his implant, and we wanted to help him, improve the situation as much as we could. This is the CBCT preoperatively, which can show lack of bone in the upper and the lower region. This is the situation with the implant in the lower region, which has bone loss, of course, because of the not so orthodox, so to say, treatment connecting tooth with implant. And this is the reconstruction of site 45, which then was used as a single tooth crown. We placed another implant, as you can see, with the cervical technique in Regio 46. And of course, we did some more grafting in the lower jaw because of the previous situation. And these are the emergency profiles of the two implants that we placed. So number 35 and 46 in this case, with this very nice emergency profile. And of course, we grafted the other implant as well. And this is the post-operative CBCT showing a very good new bone everywhere. This is the emergency profile that we get with the cervical technique, as I showed before. And this is number 46 plus 47, which of course can't have the same emergency profile because the implant was placed much, so to say, not so biologically correctly, but we connected them together in order to enhance his life. And this is then the situation afterwards. Another patient, with fracture 22 and the lateral cyst, which is another problem that we can treat in our cases, so saving other teeth. This one can't be saved because, as you can see, it's fractured vestibularly so high, which makes it impossible to have it, but we can use it as a sticky tooth graft. So removal, as you can see, there is almost no bone vestibularly. However, we placed immediately an implant and grafted immediately with sticky bone, with sticky tooth in this case, plus BCGF membranes to create a good vestibular emergency profile. And in the same round, we also treated the lateral cyst in number 11, which, as you can see, is also not so small problem. We grafted, and this is the situation after the treatment, which is stable now for many years. It's like around 8 or 9 years old in this case. Another one with dentula in the frontal area. We decided to place some implants, but of course we treated also this other teeth, which had some periapical infection in the same situation. They were retreated before surgery. Of course, I prefer to retreat endodontically in all the cases that I do, because you can be sure of the situation of the treatment before. But this is not possible all of the time, but as much as you can, you have to retreat endodontically if you want to have a good healing in these situations. Exposing the surgical site for the teeth in the periapical area, and of course, implant site in the frontal region. The patient, as you have seen, is old and of course wants to have a good eating solution, but as much aesthetic as she can get in this situation. So we did the detox, and afterwards we placed the implants with collecting some bone chips and slow expansion, as I showed you before. In this case, the site 22 cracked after expansion, but however, it doesn't make much problem because, as I told you before, I'm going to graft it everywhere, and it's going to be improved very much afterwards. So this is the placement of the implants, and then we go on with soft grafting procedures to stretch the soft tissue fibers in order to make it, so to say, ready for the soft and hard tissue grafting. Washing with serum in the teeth resection site and placing some sticky tooth in there, sticky bone. As you can see, the bone chips are mixed with biomaterial in this case, but some of them, I wanted to place them directly in this site over the cracked situation and placing the mixture above it. So this is the situation after placing it everywhere, plus lots of BCGF membranes to cover it and to, have a very improved soft tissue graft, because as the extraction were very old, the situation was not good, of course. As you can see, this is the fixing, so periosteal fixing before, and then we place some double continuous DPTFE. Paraflan sutures were used in this case. This is the situation in 2 weeks. And we placed, of course, a partial prosthesis. The patient had this situation which wasn't aesthetically good. And during the healing time, this was the situation afterwards. We improved the emergency profile with cervical VPI, as I showed you before, creating this very nice emergency profile. And afterwards, prosthetics started with implants and teeth. And this is the final situation, which is very much improved with nice aesthetic in this patient. Another one, 62 years old, with implants and bridges done 15 years ago, with a resorption in the entire maxilla with apical resections done starting from 12 till 23, with immediate sticky bone and BCGF membranes, plus a second procedure that I'm going to show you a little later. So this was the situation 15 years ago. We have this old panoramic X-ray to show. Implants were placed at the time, and this is then the treatment finished like 15 years ago. Like 4 years ago, she came with almost no bone vestibularly in the implants, as you can see, but of course with periapical problems in all the areas, as you can here see. So what we did in this case, this is a surgery. As you can see, the situation in number 23 is more dramatic than the rest of it. However, we wanted to try and save also this one. So the apical resections done in all these teeth with MTA after creating the surgery site. And as you can see, this is number 23, which was almost with no bone. And of course, total techniques were used for the implant sites because we wanted to graft them very well vestibularly. And there is sticky bone everywhere to cover teeth and implants in these cases, plus a lot of membranes to cover them. These are the sutures. And this is the post-op CBCT, showing not much problem, except for number 23, which has cracked during the healing. What do we do in this case? Well, of course, we remove it and we use it to graft the site. The patient didn't want to have treatment with implant in this case, so we just did a socket preservation, plus placed a new, bridge, which in a 70-year-old patient, aesthetic wasn't her primary problem, and we finished it like this because she didn't want to, remove all this, the prosthetic situation to redo a new one. She was happy with her appearance. But as you can see, the grafting went very well, and the hard and soft tissues are stable till now, which is like 4 years later. Another patient, female, 35 years old, with root resorption in number 11, and lack of bone in the maxilla with lots of aesthetic problems. As you can see in the CBCT, there is almost no bone vestibularly. Plus, as you can see here, there is this number 11, which is untreatable because of the internal root resorption. So we started with some rebuilding before we started our surgery. This one was, of course, removed and used as grafting. Of course, other teeth were also prosthetically treated before we started our surgery. And this is the tooth with internal resorption, which was extracted, and all the sides were grafted. This provisory treatment was placed in this region, and we waited for the healing. This is the maximum edema. This is the healing, and this is the situation after all has healed, like 6 months later. And this is the CBCT that you can see of the before and after, which shows you improvements and new bone everywhere, because this is a young girl and with her life in front of her. And then afterwards, we went on with some prosthetic treatment in the upper one. As you can see, the situation is very much improved, plus a small treatment in the lower one, which the patient wanted to, have changed. And this is the situation afterwards, having a happy patient that can now smile freely. Another case, a patient, 15 years old, with a large cyst, sits in the region of the alveolaris inferior nerve are very difficult to treat, as we all know. But with our technique, it's not very difficult. As you can see in the CBCT, these teeth are involved in this cystic situation, plus the nerve inside it. As you can see, we pre-treated them endodontically and fixed them, as I showed you before, and removed from occlusion. Afterwards, this is the wound exposure with a laser incision. We cleaned. Piezo is used most of the times in my procedure to expose the sites. And you can see the nerve in the lower region of this big hole. Sticky bone was used to cover this big defect. And prior to that, we place a membrane above the nerve so that we don't, compress it with our bone grafting and allow a good healing. BCGF membranes, as you have seen vestibularly, there was almost no bone, which we wanted to, of course, improve. And this is the situation 6 months after the treatment. As you can see, from no bone at all, we have plenty of bone, and these teeth are now stable. This is the situation after 3 years. The patient was not seen because he doesn't live in Albania. And he came after 3 years to check the situation, which was the following. Now, another patient, 63 years old, with an even larger cyst in the almost same region, but in the other side, showing that this is not one case. We have many of them. Teeth were treated. This one has the particularity that this is a previous, so to say, instrument that was left inside, but we treated it right, and we left this one and bypassed it because it doesn't make any problem. It was very difficult to remove it in that position. And this is then laser incision, as I told you before, exposure of the site in question. Piezo, as you can see, is used. We do some apical resection, not as much as we would normally do, because we want some long roots to be able to then sustain these teeth. Cleansing and grafting, as I showed you in the previous case. And this is then the CBCT 6 months later. This is a situation intraorally, and the patient went on with her treatment because it was a referral, and she went on treated with the doctor that referred it to us. Another one, a larger cyst, also referral. This cyst started from 21 till 25, and of course we had here in this case a retained canine in number 43, which we used to make sticky tooth out of it. It was the situation after an automotive trauma, which was done years ago. The treatment was extraction of this tooth, which we used as grafting material, and endodontic treatment previous to our surgery, which we finished with sticky bone, with sticky tooth in this case. These are the teeth, and this is the cyst, as you can see, plus the canine in the lower one, which needed to be removed. This is about 27 millimeters and 22. Endodontic treatment was done in the clinic that sent the patient to us, of course. And this is then the preoperative situation. This is the preoperative site, which we removed the cyst and placed the grafting of sticky tooth and filled it with membranes. This is X-ray in 3 months after the surgery, which, as you can see, almost invisible, the situation previous to this one. And this is the CBCT control at 1 year. As you can see, all is healed, even the side of 43 that we removed. These are the sutures during the healing side. And this is the prosthetic treatment done in the clinic then. Another even bigger cyst from 21 till 26 with involvement of the sinus in this case. We extracted 4 wisdom teeth because we wanted to, fill this large cyst without going to other sites that she was suggested to do, such as the iliac site. Wanted to take some hip bone in this case, but we thought that we could do it with our wisdom teeth. And as you can see, this was the situation 1 year previously to her coming to our clinic. She started doing some endos in hope to, reduce the situation, which didn't improve, and she came to us with swelling and now with nothing to lose. We endo-treated this other 3 teeth. Just wanted to emphasize that these 3 were MTA amputated in the apical area, and these 3 we just used plain gutta-percha, which we placed to exceed above the teeth, because I wanted to see if the healing had any difference in this case. And this is the site before we started the surgery. As you can see, endo is done very well, and we had in this case a famous endodontist to come and see during the surgery because he wasn't sure that we could treat this case. We were very happy to prove him wrong. This case is like 6 years old now. These are the wisdom teeth that we extracted and used as sticky tooth in this case. And showing you the cyst situation. This is the cyst which was removed and sent, of course, for biopsy, together with the other ones that I showed you before. Everything we remove from the mouth is sent for biopsy. And it came out a plain cyst, so we had nothing more to do. And this is the apicectomy and cavity after cleaning. And we placed like 12 cc's of sticky tooth in this large hole that we had there. And we placed the collagen membrane, but not for others, just for the case because there was some sharp edges in the bone, and we didn't want them to, destroy our soft tissues above. Membranes as before, and the continuous suturing. The teeth were, of course, as you can see, done together and removed from occlusion because we didn't want it to destroy our site during the healing. So this is the situation at 1.5 months afterwards, and this is the CBCT at 9 months after the surgery. As you can see, there is bone everywhere, and almost no one can say this is a site that was treated with this kind of technique. This is the intraoral situation. We started with some treating for this teeth, and this is the intraoral situation afterwards. As you can see, the situation is very good. Another patient, class 2 malocclusion.
So sorry, Dr. Gurian.
Okay.
I'm sorry for interrupting. We are a little behind schedule right now. Could you please go to conclusions?
Okay, I'm going to wrap it up now. I have
Thank you very much.
show you. However, don't worry. So, finishing my presentation, socket preservation should be a standard of care, and with sticky tooth, it's very easy to be done because we don't want to lose what we had before, as I showed you. It's very simple, and it's a profitable surgery that anyone can do. This is according to Gordon Christensen. With some thoughts, always check patient before you start a treatment. Never start a treatment without a high resolution CBCT. Retreat endodontically and prosthodontically most of the time, as much as you can. Remove as less tissue as you can, and close the holes, of course, in the implant and teeth, of course. So help the patients to heal themselves. And with this old photography and some information about where to find me, I am finishing my presentation, hoping that you enjoyed it. And if you have some questions, please, you can address it to me now. Thank you.
Thank you very much for your valuable presentation, Dr. Gurian. Do we have any questions in the chat, please? I don't see. Okay, so thank you very much once again for this interesting topic. And my question is, do we have Dr. Florian waiting for the presentation according to the program?
Yes, the last time I spoke to Dr. Florin, he said he's waiting, and now I just need to double check. If you could give me at least 5 minutes, that's okay.
Thank you.
Thank you very much as well.
So in the meantime, I will speak about the abstract of the presentation of Dr. Florin Constantinescu, who is speaking today to the audience about the 4D digital dentistry workflow applied in neuromuscular approach. Dr. Florin has submitted the abstract because with this title of the presentation, because over the past few years he is dealing with notable progression in functional and digital dentistry. And he writes that various acquisition systems like intraoral scans, facial scans, dynamic CBCT, and tracking of free mandibular movements have emerged in the last period. And they are offering unprecedented levels of detail. Consequently, dentists can now gather both quality and quantity of data about their patients. Employing the neuromuscular approach alongside the 4D technology enhances treatment precision and also predictability by integrating physiological metrics and accommodating patients' preferences and requirements, as Dr. Florin Constantinescu is stating. The treatment plan of the patient steps involve mandibular deprogramming, functional dynamics digital analysis, occlusional stabilization with orthotic appliance, and final prosthodontic treatment with minimal invasive crowns and veneers. The patient the patient who will be shown in the presentation consented to the proposed treatment plan and academic use of clinical documentation. Lately, we state by Professor Florin Constantinescu that digital dentistry revolutionized diagnosis and treatment planning, offering clinicians precise tools for personalized patients' care. So I would like now to call Florin Constantinescu to take the floor and show his presentation. Hey, Dr. Florin, I apologize to you for the delay because your Guri endemic Raki took a lot of more time as he was supposed to, and I apologize for you that you had to wait for your presentation, but I hope you can do it now. Thank you very much for being with us.
Excuse me, 1 second. Can everybody hear me?
I can hear you, but you are frozen on the screen.
Yes, we'll start presenting with Mr. Florin.
Okay.
Okay, now the presentation will start. Thank you very much.
Thank you. We cannot hear Mr. Florin. I'm really sorry we don't hear Dr. Florin.
Okay, I will need the second.
Hello, everybody. Thank you so much for the kind introduction. I will start to share my screen.
Thank you very much for having you. We can hear you perfectly now.
Okay. I hope everything is good now. So, my name is Florin Eugen Constantinescu. I'm coming from Bucharest, Romania, and I will be presenting to you today the 4D digital dentistry workflow applied in the neuromuscular approach. As you can see at the bottom, there are some logos. One is from our clinic, the other is from the university that I graduated, Carol Davila in Bucharest, and the other is from the University Jaume Primero in Valencia, Spain, when I'm together with a group of friends teaching at dental implantology master. So if you are trying to visit Romania, please also visit Bucharest. It's a wonderful city, and if you are planning to do so, do not hesitate to give us a call and maybe organize a private tour. This is the place where I spend most of my time in the clinic. So I will try to bring in front of you a bit of my experience. We, as a family, starting with my father, of course, are in the neuromuscular dentistry since the early 80s. I started to use this approach since my early beginnings, and we have tried to contribute our experience through articles along the time. I am blessed to be using a lot of technologies, and we are using several systems so far, and we are also participating in research, and as I mentioned, published some articles along the way. This is our journal, so please do not hesitate to enter and visit the website and read wonderful and interesting articles. And not only, you are most welcome to send also articles to be published. I would like to acknowledge a very good person, a mentor that unfortunately passed away recently, that Professor Francesco Mangani, and he had a very important quote saying that we should let the knowledge and not the trend of the moment be the guide of our hands. I always have this question in mind, whether did our teacher give us everything there is to know in school, and that was that, or we should always keep searching for new information. Of course, if you learn more, you try to be better every day in your practice. When you are approaching a difficult case, we should always think of a global approach, whether it's mechanical, functional, periodontal, and also dental facial aspect, and to carefully evaluate everything. So with the neuromuscular approach, we can measure muscles, we can measure movements, and we can understand how the patient reacts. And if there is a situation of pathology, we always have to understand what is to be treated. And as a goal, it's important to let the patient tell us what he or she may need. We should measure, observe, understand, and follow our patient's physiology. My approach changed when I met this wonderful person, Giuseppe Rampola, a dental technician, master dental technician from Italy, that introduced me to his technique and also instruments regarding mandibular movements with an optical system. And he showed me the link that was missing between analog and digital, and ways and more ways to get an individualized treatment. For instance, if you want to still set an articulator, we can print nowadays the condylar path of our patient according to the patient movements and the CBCT. And of course, this brought important novelty in our practice and changed the way we see everything and understand. He welcomed to this new normality and showed me that there is a lot of new important instruments that we should consider. For instance, the robot that is doing exactly one-to-one the movements that the patient is doing while chewing, while doing any mandibular movements that we can replicate in the patient's mouth. And of course, this led to an important change in our protocols and to our way of seeing and evaluating the patient in our neuromuscular approach, that we wanted to integrate all these wonderful data in order to understand better our patients. So always we have the patient in center, and we are using now the CBCT, and not only the dynamic CBCT, we are using the systems for electromyography and jaw tracking, sonography. Of course, we are using intraoral scanner and facial scanner, but with the help of the optical system, we are also using the robot, which help us bring a different type of end result for our patients with functionalized prosthetic work. So as I said, our protocols have changed and improved, and although there is a good amount of information with the basic data that once we were gathering, now we are getting far more information that help us treat our patient in a very individualized manner. So when we are approaching digital in a digital way our patient, we should understand how this data can be precisely collected and gathered, put in the softwares for the CAD design, in order to understand our patient and to get more and more a cloud of information when we are doing prosthodontic setup for difficult and important cases, such as implant cases, full mouth rehabilitation, and so on. So I would like you to join in this new normality that we are now since almost 4 years treat our patients. So we evolved, in my opinion, and this is a new way of communicating with the patient, and we get this as a very, very important aspect, because in the lab, in the clinic, with the patient, we see and we plan everything, and we show everything since the beginning, and so we get the patient on board to understand every single step of the way in order to get the patient compliance and to be predictable with our results. So of course, digital dentistry helped us in the beginning to perform our surgeries also in cases where there is a very important pathology, like genetic pathology, such as dentinogenesis imperfecta. But with the help of the digital and the CAD softwares, we can plan carefully and precisely our surgery in order to obtain a very precise result. And the important phase when we are supposed to deliver our final restoration is to check and double check, and to know which type of technique we use, whether we still use the analogic technique of impression, or we are using a digital one. Of course, in my opinion, if we are using the analogical impression, the best in impression technique is the plaster with plaster for the implant level impression. Of course, we are using more and more, and on a daily basis, the intraoral scanning, And by gathering, as I said, all the data, we can provide a functional and dynamic individualized design, so we can show and bring the patient on board and show every single step of the way how the change will be in transforming the vertical dimension, transforming the initial situation of our patients. And when we are delivering, as I said, we can, with the help of the robot, see and when we are delivering, when we are delivering, the patient recognizes exactly the occlusion without any difficulty. So this is a very important, very important step in our opinion. So no matter what we are delivering as a final restoration, whether it's zirconia or layered zirconia or full monolithic restoration, we can test everything before the delivery phase to our patients. So it's very important to get out of our comfort zone and understand there is possibility always to improve, and by stepping out of the comfort zone we can be a better version of ourselves each day. There are a lot of situations when we are facing difficult cases, and we should always try to understand. And as a reflection, if we have a tough case, we should always try to think what should we do and what technique should be used in that situation. Of course, there is always some steps in the approach. When you are at the beginning of the career, maybe you can not see a difficult situation, and you don't, by not knowing the problem, you don't know how to solve it as well, or you can keep a blind eye that you acknowledge the problem but do not know how to solve it. Sometimes we rely only on the lab, and we ask the lab to do a magic for us, but not always, of course, that magic works. We do not provide enough information. So if you know the protocols, and if you know to carefully diagnose the patient, you can provide a different type of treatment. What should we keep in mind is that we do not, and of course our patients do not want to get old. So in our daily practice, we have to understand that our treatment has a potential to improve and to restore the macroaesthetics of the face, and also we have to know that our work can provide an anti-aging effect, which is very much appreciated by the patient. So we should understand what is this concept of anti-aging, and not sell anything which is not deliverable, but we have to know that there is also this big and important potential in dentistry to give and to reverse the process of aging for our patients. So there is this great friend of mine, Dr. Alessandro Galuzzi, who's also very keen on modifying and improving the patient's lives with his technique, the vertical box. So he, through the physiological registration and also with all the full digital protocol, he is delivering great results to his patients by carefully evaluating all the movements and everything there is to know. In my situation, I see more and more that we can provide a better treatment, a better type of dentistry for our patient, which is very much appreciated, and of course with some very important aspect of also anti-aging. So it is very important to measure, because if we measure, we can compare and we can send our measurements, and we can provide as our measurements as a legal proof if we want. And it's very important to understand that with the neuromuscular dentistry, we aim to see and to understand better the physiology of our patients. This case that I will present right now, it's a case that has been published together with my mentor and my friend and my professor, Professor Fabio Savastano. And we had this as starting point, a very deep bite with a very poor dentistry. Of course, the patient was in pain, had TMJ problems, and had a very bad situation. But we jumped to our approach, which she did not know about until that moment, and we got the patient trust. We obtained through the muscular relaxation a different situation and a different type of patient. Of course, this case was started at the beginning in an analogical way. We can see that there is a huge difference when we relax the muscles, and we get a different patient just by letting the patient relax. So from the initial position, we got our myocentric position, which was the starting point of our treatment. So we increased the vertical dimension at an important level, and as I said, it was published, this case. And what was important that we at the first step, we increased by more than 7 millimeters the patient vertical occlusion. We provided at the beginning long-term provisional that we checked, of course, also with the lateral cephalometric X-ray. And after we started to work underneath, either to perform our extractions or do the endo treatments that were required. What is very important is that we are measuring muscles, and although it's not easy at times, it's manageable, and we can obtain a full muscular relaxation of the muscles involved in our mandibular movements. And by evaluating this, of course, we get a different type of approach, different type of situation that the patient is appreciating, and not only through aesthetics, but also through the functional aspect. So this was an intermediate phase after wearing the long-term provisionals. And as you can see in this picture, there were extractions going on, and we checked always. We are checking after some times the differences, if there are differences, or if we are on the right path with our treatment. So it's very important to understand how the patient is functioning in order to proceed and to finalize our work. And what has changed, and we improved our protocol with the optical system. We started to do the next step, which was the face scan, which allowed us to integrate with the optical jaw tracking system, integrate every single movement of the patient, whether it was with the teeth touching, the teeth not touching, or the chewing face. And this in the lab gets us a 4D avatar of the patient that can allow us to understand every single aspect that there is to know and how to design the prosthetic treatment according to the patient individualized movement. So although there are still articulators and so on available, I received this final provisional as a final step of verification for our case. And although the patient was at the time of implant surgical reentry, we placed this provisional without any issues. And as you can see here, the mounting of the case is very straightforward, and the patient is recognizing the occlusion without any difficulty. Everything comes together easily in a smooth manner, and we don't have to spend time on occlusal adjustments, and we don't have to worry about anything else but cementing our prosthetic. So, as I said, we are still doing occlusal checks, but more often than none, we are putting our patients to eat directly and to understand that everything is already on the right path and everything is correctly and precisely done. Sorry for that. And when is the time to go for the final restoration? If you want, you can always check and double check, but if you obtain the proper muscular relaxation and the patient is stable, you obtain the correct activation of the muscle. And you can see here the masseters are activated and not the temporalis muscles, which normally tend to be activated when there is a pathology. So this is the situation at the time of impression. Of course, we use the digital impression and we deliver the layered zirconia as a final type of restoration. We see that when we are respecting and we are delivering the correct occlusal plane, this occlusal plane respects the equator of the tongue, which is a very important aspect in our opinion. So we integrate very well the prosthetic if we are designing everything according to the patient's needs and according to the patient's movement. And when we check and double check, everything is everything fits, everything is according to our plan. So this is a summary of what was performed for the patients, whether it was endodontic treatment, extractions, and also implants that at the beginning were not considered, but because the patient got on board and felt confident, although there was a important surgery of bone reconstruction in the posterior mandible on both sides, we delivered successfully a good case that was appreciated by the patient. And of course, we improved the facial aspect of the patient, and also the function. There are a lot of publications that are coming, and very important publications that we should consider regarding the individualized planning of our prosthodontic cases. I will step now to the next case that I would like to show you, a difficult case, patient of 75 years of age with a very tough history and with problems, as you will see later on. The main thing was that he had difficulty in chewing, some broken teeth, also a very serious general situation that he was having dialysis that kept him busy every Tuesday, Thursday, and Saturday since 4 years ago on a weekly basis. So the main request was to do as less anesthetic as possible, less surgeries, and of course, no implants. After our initial evaluation, you can see now in the patient mouth every type of restoration known to us so far, and very poor initial oral hygiene. We aimed, as you may wonder, to comply and not to do surgery, at least to reduce the level of surgery that we should do for this patient. Of course, we relaxed the muscles, and we obtained a new position that we used for our provisionals. Considering the prosthetic and the functional diagnosis, so there was a lot of tooth wear, and of course there was an overload of the forces, especially on the anterior zone, which made the lower incisors move. Of course, the function was not okay. We analyzed from all the aspects, whether CBCT and so on. The periodontal diagnosis was very important as well, because we had missing teeth, we had compromised teeth as well, and we always aimed to save as much as possible. So the prognosis overall was moderate, but we tried to save as much as possible. We tried, as a goal of our therapy, to eliminate all the chronic infection, to do the endodontic retreatments or treatments of the remaining teeth and the buildups in a reduced number of visits, and also to improve the masticatory function of our patient. So the treatment plan was, after the initial periodontal therapy with scaling and root planing, to deliver the provisionals, afterwards to extract the compromised teeth and to perform our endodontic treatments, and with the help of the functional dynamic digital analysis, to deliver in the end the metalloceramic restorations. So after saving every single tooth that was to be saved, we did the reconstruction of the pillars, and in this situation we also used both analogical, just to show the difficulty of a full mouth rehabilitation when it is the time of analog impression. The patient had huge tongue. It was a very tough situation to get this impression. I'm sorry, that the video has a glitch over here. Anyway, there was this impression that was made at 8 hands, as you may have seen in the video. So was the Casartelli technique for individualized impression, but of course we used the intraoral scan, and it's not as difficult, of course, and it's in my opinion it's more precise, and we also perform the mandibular movements with the help of the optical system, and by gathering all this data. Okay, we recorded also the chewing phase, and when everything was gathered, we delivered everything to the lab. This is the situation of the salvaged pillars of the patient. So it was, for me, it was the first case of full mouth from wisdom tooth to wisdom tooth, upper and lower. And when was the time of testing the framework, we received this. So we received not only the framework, but also the future situation of the patients. So we got this to test also the phonetics and the function. So because we did not do anything to fit this structure easily, we got the approval of the patient to do another registration just for academic purposes. And we can see here that although the initial movement was very limited on the left side, by designing everything individually, as the patient is showing us, we obtained a better movement, a better shape that was in the end recognized. And of course, seeing is believing. It's very important to have also the video proof of our treatments from time to time. And although everything is tested, and as I said, when we are doing this type of registration, we can have a cloud of information that is very much appreciated when we are delivering our prosthetic work. And with the help of the robot, even in a situation of metal or ceramic restoration, we can have this wonderful result. Unfortunately, the videos are not moving. Sorry for this. And what is important, that when we are delivering our final restoration, there is no occlusal retouch that we have to perform in a full mouth restoration. So as I said before, it's very important when we are delivering a correct occlusal plane, the tongue is respected, and our occlusal plane is on the equator of the tongue. And as a summary of our treatments, we have here all the endodontic treatments, the extraction, and of course, the implant that had issue was submerged just to be more delicate in our surgical phases. And what's very difficult for a patient when is getting new teeth, of course, is the function. And what's important is that although at an old age, if we are delivering the correct prosthetics, the function is there without any difficulty instantly, even at delivery. So, as I said before, our treatment, although it's not set for this, is also giving to our patient anti-aging effect, and the function is very important as well. So, as a start of maybe future debate, always there is this question that gnatologists have regarding the hinge axis. Where is the hinge axis and how you determine the hinge axis and so on and so forth. In our opinion, we should let the patient tell us where the hinge axis is if we are searching for the hinge axis, and to understand every single aspect of our treatment plan, because the patient is coming through our door with everything there is to know. We just have to carefully evaluate everything, gather all the data, integrate it in our CAD softwares, and then after carefully planning, we should start with the end in mind. So knowing the end, you know every single step of the way what procedures you should be delivering to the patient. And as to a conclusion, as a take-home message, as I said before, we should start with the end in mind. As Christian Coachman said, we should embrace technology and respect the learning curve, whatever system we are using for mandibular tracking. We should understand that very important to use also the facial scanning and how to use the layering of the intraoral scanning. It's very important to use the CBCT when we are doing the diagnosis, whether it's normal or dynamic CBCT. Also, if there is the need, the MRI as well, if we have a TMG problem. It's very important to plan everything in 4D in order to deliver a functional, dynamic, individualized design for our patients. It's very important that we can improve our communication with the patient and involve him in the treatment plan, and to get the patient acceptance. So it's a very good tool when you are using this 4D avatar, and when you are using all the data from the patient, because the patient is actually telling you what he or she may need, and you just have to measure, observe, understand, and follow the patient's physiology. Of course, it's very important to upgrade the protocols. You should always go for immediacy if it's a case of implant surgery, but it's very, very important to plan every single step in advance. So, as our forefathers said, it's very, very important to be an internal student. So we have to keep learning and to open our eyes to the novelties if there are important to our development, and not to be afraid of making mistakes, because also mistakes are part of our learning curve. But if we can improve on a daily basis, we will for sure deliver to our patients a better type of treatment. And in my opinion, an individualized treatment is the best way to approach a patient. So I thank you all for your kind attention and hope to see you soon in our future events. Thank you so much.
Thank you very much, Dr. Florin Constantinescu. It was very interesting lecture as always. This approach is very unique.
Thank you.
Sorry for the sirens, but we are here at the University Hospital, so it's always like this. Let me please summarize the morning session from December the 2nd, the InnoBioDent virtual conference. It has been featured a series of insightful presentations by esteemed professionals in the field of biological dentistry. Please let me bring you now a summary of the key lectures presented between 9 o'clock and 1:30 this morning. As first, we have heard and seen the presentation of Professor Kenneth Lee from Australia, who spoke about 3 phases of the same beast, manifestations of airways, cranial distortions, and malocclusions. Kenneth Lee explored the interrelated nature of airway issues, cranial distortions, and put them in correlations with the malocclusion. He emphasized the importance of a holistic approach in diagnosis and treatment and highlighted how these conditions coexist and influence each other. The second presenter was Professor Niraj Kirivalla from India, and he spoke about digitalization in endodontics. He discussed the integration of digital technologies in endodontic practice, covered advancements such as digital imaging, computer-aided design, and 3D printing, illustrating how these innovations enhance precision and patient outcomes. As a third presenter, we welcome Professor Ofir Fromovich from Israel, and he spoke about the 5th generation of implants, a new concept with biological understanding for immediate loading with aesthetic results. From these presentations, we learned how to get the concept of 5th generation dental implants, which are designed for immediate loading while achieving optimal aesthetic results. Dr. Fromovich elaborated on the biological principles underpinning his approach and shared clinical classes, and he was demonstrating its effectiveness. As a third presentation this morning, we had a topic, what can we do to save teeth and implants, presented by Dr. Gurien Demiraki from Albania. Dr. Demiraki focused on strategies for preserving natural teeth and maintaining implant health. He discussed preventive measures, early detection of potential issues, and interventions aimed at prolonging the lifespan of both teeth and implants. As last speaker, we had today Dr. Florin Constantinescu with the topic of 4D digital dentistry workflow applied in neuromuscular approach. Dr. Florin presented 4D digital workflows and protocol to enhance precision in treatment planning and execution of conservative and prosthodontic treatment. He is using advanced diagnostic tools such as intraoral scans, CBCT, and mandibular movement of tracking. The approach enabled personalized care for patients with post-orthodontic surgery complications. The treatment plan Dr. Florin was presented combined functional analysis, occlusal stabilization, and minimally invasive prosthetics, achieving improved aesthetics and functionality. As summary, I would say that this session provided valuable insight into the latest advancement and holistic approach in dentistry, emphasizing integration of technology and comprehensive patient care. Thank you very much for listening to our presentation this morning. And let me please say goodbye to you and wishing a successful conference this afternoon led by Marian Constantinescu. And I give over the floor to Professor Marian Constantinescu with a big thank you for organizing this beautiful virtual conference.
Thank you so much for your conclusion for the first part, third day of the conference. Thank you for your support and for your friendship, and to continue together this project. Thank you so much, Simona, for your help. Thank you. Thank you very much. Good day at your activity today.
Thank you very much, Professor. Appreciate it. Highly appreciate your activities and friendship.
Mr. Marian?
Da.
Să continuăm cu o pauză de măcar jumătate de oră de lunch break.
Continuăm cu pauza de prânz și intrăm în programul normal, conform orarului.
Da, dar ne-am decalat. Trebuia să avem o oră. Acum nu mai avem decât 20 de minute din pauza de masă.
Asta este, nu avem ce să facem. Deci nu putem să-i amânăm pe ea, pentru că noi n-am respectat programul.
Înțeles. Imediat acum o să pun mesajul.
Puneți, vă rog, mesajul cu începem la ora cutare. Mulțumesc.
Hello.
Hello.
Hello. Hello, Marian. Hello, Michael. This is Gregor Slavicek from Austria. I just tried to connect and it seems to work.
Yes, we are now in a short lunch break, so feel free to take a break, just a few minutes. In 20 minutes, we'll be back.
Okay. Can I just...
Can you see that again?
I just want to try to share my screen, if it works and how it works.
Okay, I can assist you with that. You are on the Google Meet page, right?
Yes.
On the bottom side of the screen, you should see an arrow pointing upwards inside a box. Can you see it?
Yes, I did it already, yeah.
If you press on it, and after that select the share now in the pop-up screen. Did you do it? Are you able to see a screen where you can select tab, window, and entire screen?
Yes, but the message is I cannot share. I need the allowance.
Yes, please select allow.
Hmm.
Doctor,
the moment,
can you hear me?
yes.
If I'm not wrong, your name is Dr. Gregor Slavicek. Just wanted to check. Can you hear me, doctor?
Yes.
I wanted to confirm if you got our email regarding your schedule. We sent it last night of approximately, I think, 10 hours ago, 10 hours, 12 hours ago, or even more. You are scheduled for 14:45 set.
Yes, I got it. Yeah.
Okay. Okay. After this lunch break, we will have Samantha Jajev to present, and then it's going to be your turn for your session.
Okay. And I use the video call link, meet Google.com, and is this correct?
Yes, Google Call, Google Meet. Yes. This is the correct link.
Yes. Okay. In the moment, okay. And how to share now my screen? I see this item, but I'm not allowed to share my screen.
It says that you're not allowed. You need to allow it. There was a message asking you if you allow the app to share your screen when you first pressed the present now button.
I understand.
Please continue. When you try to present, it's gonna be a message that will say you will take over from someone else. There is no problem with that because the one presenting right now, it's a companion. It's presenting just a few slides with every presenter and professor, and with a few words presenting them. And you can press on share now, so that you can take the spotlight from them. In my email, in the email that I sent from Stanisky Theodor, and the email address was, one second, roposturo @gmail.com. In that email, there is a short video guide on how to share screen on Google Meet. It's 45 seconds, and it shows exactly those few steps.
Yes. Okay. I did it. The only problem I have is that when I do it now, I get an information, share now, but it is told I cannot share. I need the correct allowance for that. I cannot share my screen because I need allowance.
You cannot share because you need the allowance. So you can, it is what options do you have to press? What buttons are you able to press on that option?
Can you try again presenting your screen? Let's see if this works right now.
No, it still tells my screen cannot be shared. I need a special allowance.
Okay,
No,
you can
not.
try. No, still not? Not even now?
Still not.
Okay.
Could you leave the meeting and join again using the link? I am not aware if his system or his browser is the one not allowing.
I think that when he entered the conference, he denied the permissions and only permitted the microphone and camera, maybe.
Yep.
It's a good thing that he reset it. Okay, let's see now.
Okay, welcome back. You are muted. First, please unmute yourself. Now let's try again. Press again that arrow pointing upwards inside the square.
I did.
After that, press share now.
No. Still, I get an information. I have no allowance to do that.
And what buttons does that box have? Does it have an OK button or allow now?
No, just close this window, close it again.
What browser are you using?
It is Firefox.
Firefox.
Do you have any other browser that you could enter?
I have Google Chrome. I can try Google Chrome.
Yes, please
Yes.
copy the link and enter using Google Chrome.
Okay, I will close now and I will.
Yes.
That is strange.
Yeah.
Oh, welcome, Dr. Samantha Jajev. Sorry for not, we were in a discussion trying to test things out. I just saw you joining. So sorry about that. We'll be
That's
short back.
fine. I'm hoping I'm not going to have the same difficulty.
If you want, we can try with your presentation as well, because you're the next presenter, the session 25.
Yep.
Yes.
So it says that I can take over your
Yes.
Yes.
Yeah.
And you share now. You press share now, and you will take over, and you will open your presentation. The best one is the entire screen. You have three options.
How's that?
Let's see.
We are waiting for it to load.
Okay.
It is not loading.
Ah, no.
After you press entire screen, you need to select the entire screen, which one of them you want if you have multiple. And after that, confirm by pressing share again.
Share now.
Okay, yes, it is working.
Okay.
Oh, wait. No. This is Mr. Slavicek's presentation.
Yes.
Yeah.
Oh, okay.
Okay.
Well, Mr. Slavicek, your presentation works fine.
Now we need to close it because Miss Samantha is next, Dr. Samantha, and we'll do the preparations before, or would you like to be first presented? Mr. Marian will join. And I forgot to present myself. My name is Stanislav Theodor. We are from the technical department for this conference. And Mr. Marian will join shortly, and he will have a short presentation for you, and then we can start with the share screen and everything.
Okay. I'm just going to change over to Chrome because I'm on Firefox as well, so I think I'm having the same difficulty.
Thank you very much.
I'm going to log out and then log back in again.
Welcome back. You are muted, Miss Samantha. Let's see if you can share the screen again.
Okay.
Perfect.
Yeah.
Yep.
Fantastic.
We can see it. I can see you. I can hear you. It's perfect.
Fantastic.
If you want, you can stay like this, and once the break is over, which is in 4 minutes, we can begin.
Fantastic.
Hello, Samantha.
Hello.
Hello. Just now, 2 o'clock going.
Yeah, nearly there.
Oh. In the second part of the third day of our conference, first speaker is Dr. Samantha Yugdev, is a general dental practitioner based in Oxfordshire, UK. She started talking on interest in complementary therapies and their value in dentistry when she realized that patients were making varied choice in their care of their own health. She gained a membership of the Faculty of Homeopathy. Shortly after this, she was invited to join the teaching team of the National Center for Integrative Medicine, gradually increasing her involvement to developing their online courses. She is now education lead for homeopathy with NCAM and sits as their representative of the Faculty of Homeopathy's Academic and Examining Board. She also chairperson of the British Homeopathic Dental Association. Recently, she was awarded Fifi Hawen. Now, Dr. Zhugdev present trauma mail and its use in the general dental practice setting. Please, Samantha.
Thank you, Marian. So today I'm going to talk about one aspect of homeopathy that I find really useful in a general dental practice. So looking at the learning objectives, what I hope that you'll get by the end of this session is that you'll have a very basic understanding of the value of homeopathy within dentistry, specifically, have an appreciation for the evidence and the research that's actually being carried out on the homeopathic complex with Traumeal, and be able to apply this knowledge in your own practice and the value that it can bring to you and your patients. So just an overview of the principles of homeopathy. So the ideas behind homeopathy is that we have like treats like. And that we're treating a whole person, not just a set of teeth or a set of lips or anything like that, is that we're treating a whole person, and that this is individualized to a whole person. So for an example of this is the reason why I put up a picture of red onions, is this is actually one of our homeopathic remedies, which is allium cepa. So if you think of cutting into an onion and about the symptoms that this might have, is that you would expect it to have, you know, sort of a burning sensation in the nose and the eyes, lots of tears that are very profuse, very watery and colourless. And this is a remedy, the allium cepa, that we use in things like, you know, common coughs and colds when we present with this burning and all of this profuse tears and, you know, maybe nasal discharge. And also it's quite useful in allergies and hay fever. So this is an idea that, you know, obviously coughs and colds we all present slightly differently. So this is an idea of individualization where it's specific to somebody who's experiencing their cold in this way. We can also look at it as a totality, so it has lots of other expressions of allium cepa, and you know, we might even look at somebody's mental state, even what their dreams are when we're getting really deep into a case. So the similar is where we're treating like with like. And then the potentization is usually the bit that gets homeopathy into a little bit of trouble, is that actually we're diluting the remedy. So, I mean, there's a lot of value to having the red onion raw or cooked, but actually what we're doing in homeopathy is we're diluting it to a point where the red onion itself isn't bringing about those symptoms, like if we were cutting into it. And what we do is we dilute it and what we call succuss it, which is basically banging it very, very hard to transfer the energy of the original substance, in this case red onion, and transferring that energy into the liquid. So that's a very brief overview of homeopathy. So this is a picture of Dr. Samuel Hahnemann, who is the founder of homeopathy and practiced medicine just over 200 years ago. You sort of got to think about what medicine was doing at the moment. We gave a lot of people poisons, so arsenic and mercury, that actually probably made them more ill. Bleeding was, the therapy of the day, where you actually remove people's blood. And so that's how the doctors practiced. And he decided that even though he was trained as a conventional doctor, is that he thought that this was making people worse. And he did experiment and he came across homeopathy. His teachings, which we still carry out today in classical homeopathy, is we give one remedy for one condition at any one time. And the purists in the homeopathic world still hold true by this. And it is a fabulous way of treating people. It's really, really beautiful, and we get really, really amazing results from this. The problem with this for dental practitioners, maybe especially, is that we need to sit down with the patient and ask them loads of questions, find out how they're experiencing everything, and it can take a long time. Sometimes we're lucky and we can get to a remedy in 10 minutes. But sometimes it can take an hour or more just to try and guess at a remedy. So it's beautifully complex, and like I said, we get amazing results from it. But when you're in a dental practice and actually your primary scope of practice is actually to, dig out the decay and fill it, or carry out periodontal treatment and management, whether it's taking a tooth out, is that, we don't have that time to spend with the patient. We're actually more interested in what we can do for them as dentists. So we want to look at more practical ways of integrating homeopathy. I mean, it's definitely got its place in dentistry, but most of the time in general practice, we just want something that's quick and we don't have to think too much about it. So this is when we start to think about what levels we're actually treating in the dental practice. What's our patient expectation? What's our expectation of what do we want to achieve for our patient? So obviously on dentistry, it's actually quite a low level. We want to treat somebody to keep them comfortable while we're taking the tooth out, or while we're doing scaling for hygiene, or just making them comfortable, while we put anesthetic in. We might go a bit deeper, but actually most of the time, and what our patients are expecting, is that they just want to be more comfortable. They might want to feel a little bit less anxious as well. So what do we want to achieve as dentists? Well, as dentists, whatever patients might think about us, we don't really want to cause any discomfort at all, which is why we use local anesthetics and why we're careful about how we practice our dentistry. So, how can homeopathy help us achieve comfortable, calming dentistry where patients are happy to come back to us and have everything maintained? What is acceptable to the patient? I mean, the patient might start looking at you a bit strange if you start asking them questions about what they do and don't like to eat, or even what they're dreaming, or how they feel about something. Some of them are quite happy to share this information, but some of them are a little bit more reserved. And then thinking about how much time we have as a busy dentist, and how much time the patient has. I mean, it'd be lovely to sit down for an hour and a half with our patients and have a really good chat with them. But actually, most of the time, we just want something that's easy, quick to give at the point where we want to give it, that doesn't take up any of our time, or maybe a few seconds. And also, we're not keeping the patient hanging around longer than we need to. And we need something that's easy to use. I mean, you think about any of our dentistry, and we're much more likely to use something that we're very familiar with, that we know a lot about, and that is easy to implement into our practice. So homeopathy can offer this as well. So this was a really lovely study. It was done by asking dentists that work in general practice about how they use homeopathy, whether they use it for chronic and acute prescribing, what sort of techniques they use and what sort of remedies they use. And the lead author on this was a wonderful woman called Sue Farrow, who sadly passed away 18 months ago. And she was my mentor. So she taught me everything that I know today. And this is just a picture in memory of her. So this was a really good paper and very thoroughly researched. And they came to the conclusion that complementary and alternative medicines offer safe and effective strategies within the dental practice. So it's something that we can use and that we can use it within our scope of practice. So they looked, a lot of the dentists were using single remedies and getting great results of them. And some of them were using homeopathic complexes. And they found that actually the complexes were working in the dental practice because of it targets different aspects of the cytokine system. Also, they found that in acute conditions, especially with the complexes, is that they gave promising results and also the patients liked the homeopathy and the practitioners liked using it because it was easy to use in the practice. So today I'm just going to concentrate on one of these complexes, and there are a few out there, but this one I personally find the most valuable, and this is Traumeal. So when we're talking about a complex, it means it's got several different remedies in, which I will go through in a bit. But also the beauty of this remedy or complex of remedies is that it's easy to use within the practice. So we've got it in tablet form, we use it in drops, we can use it in cream or gels, there's even suppositories, we can even inject it. So my personal use for this complex in practice is that I use it in tablets that I can give the patient to take away after I've taken a tooth out or I've done hygiene treatment. And I also use it a lot in drops as well, because it's easy while the patient's just lying there just before you're about to take a tooth out, is actually to get your nurse just to drop a few drops of this onto the tongue, and it starts working straight away. My personal use for it in my own personal life as well is it's great to use the gel and the creams for sports injuries. So what levels is this working on? So these are the remedies that are present. So most people have come across arnica because it's associated with bruising, and it's very, very widely and easily available. We've got things like hamamelis, which is witch hazel, which is another well-used and well-known herbal remedy, and echinacea, which lots of people use to improve their immune response when they've got a cold or flu. So there's lots of different remedies in here, and this slide is really just showing what levels it works on. So we're dealing with the redness, the heat and the swelling that we'd expect in inflammation. We're dealing with sepsis, so it's helping with the immune system, and it's helping against any bacteria and infections we've got, and the immune and the body's response to infection. These remedies particularly help with wound healing, and then we've got these remedies that help with pain. So I'm going to cover a little bit of this later. So there is actually quite a few different papers that have been published on the effectiveness of Traumeal. Some of them fantastically actually deal with the dental side of things as well. So this was a paper that was taught in depth about how Traumeal might work to produce the results that we expect from it. So this was looking at particularly any conditions in the maxillofacial region, and they concluded that actually Traumeal produces positive results in treatment of various inflammatory processes in the area that we deal with as dentists, and also useful in various dental diseases. So what levels, how is this working? So just a summary of how it's working. So they found that the components of Traumeal actually helped with basic metabolism and immunity. So you're looking at healing and the body recovering and fighting off any infections. So it's anti-inflammatory as well. So if you go back to the synergy of Traumeal, we were looking at reducing the redness and swelling that we associated with with inflammation. It's got some antiviral properties, so it's linked with immunity, and also the viruses don't like it. It's analgesic. It's got hemostatic properties. It can help with shock, so that's not just physical shock, but also the mental shock. And indeed, I've observed this in practice. So it's only anecdotal evidence from me, is that when I give this to patients who I've suddenly told that they need to have a tooth taken out, is that actually you can visibly, once I've given the remedy, see them just take that out breath and that just relaxation. It's not much, but it's enough that they're happy for me to proceed when I've got to take a tooth out. It stimulates the immune system, and actually it's been shown to restore microcirculation, so improving all of those little capillaries and the blood vessels that we rely on for healing in the mouth. So this study was a lovely randomized triple-blind split mouth clinical trial looking at periodontal flap surgery and the healing afterwards. So they made up identical tablets of Traumeel, so they look the same as the ibuprofen. They weighed the same, and they split patients up into the two groups. So one group was given ibuprofen and one group was given Traumeel. And they were told, to take as many tablets as they needed for as long as they needed. Obviously, you don't want to take overdose on the ibuprofen. It needs to be taken every 8 hours or something. So, they were given instructions so that they wouldn't, if they were in the ibuprofen group, they wouldn't be overdosing. And they looked at how many tablets the patients took, what their sensation of healing after this surgery, and also how long they needed to take, the medication that they've been given. And then they looked at examining both groups. So they found that actually the Traumeel group needed fewer tablets. So they just didn't need to take as many because they were more comfortable quicker. And actually they had an improved perception of the pain that they were in. They also found that the Traumeel had no adverse reactions, and actually 3 of the group of the ibuprofen did have side effects. So it just shows that actually we can compare the two, and we can see that Traumeel is at least as good as taking ibuprofen after oral surgery, and it's safe. This was another randomized split mouth triple blind clinical trial looking at wisdom teeth extractions, thermolar extractions, and they actually injected either Traumeel or dexamethasone into the masseter muscle, because obviously we associate third molar extractions with a lot of swelling, a lot of discomfort, and that prolonged healing. And this found that there was actually no difference between the pain in either group, is that they were absolutely comparable. They were comparable in the amount of swelling and the comfort afterwards. So, obviously dexamethasone is quite a strong steroid, and we traditionally use it and get great results from it. But it does have inherent side effects with this, and there's not side effects with the Traumeel. So they propose that actually Traumeel could be a good alternative to dexamethasone for controlling pain, swelling, and trismus after third molar surgery. And of course, it's a lot gentler. And if you're taking it in tablets or you're giving the patient tablets afterwards, is that you can get good results. So what is in Traumeel? So this is sort of going back to the classical homeopathy is looking at each of the remedies separately. So, for certain things, we could give each of these remedies separately, but the beauty of Traumeel is it's in one package and it's easy to use within our surgeries. So belladonna, which has sort of got this berry, it's traditionally used in infections, and it's when the pain is throbbing, and it's associated with inflammation. So it's usually when you've got, maybe an abscess on the tooth and you've got that throbbing pain, there's a lot of swelling, there's a lot of throbbing from it. it's really painful and the patient's very uncomfortable. So that's one of the main ingredients in it. We've got aconite. This is a flower called monk's hud, which is actually quite toxic. And this is a really good shock remedy, so especially mentally. So this is a really good remedy to use if you see people have that adrenaline response. It comes on very quickly. They get this sort of shaking and absolute fear. So they're absolutely terrified that they might die. But it's also good for pain as well. So in this case, sticking and tearing pain, but it's especially good for that mental shock. So Symphytum, which is comfrey, so certainly in the UK, it's a massive weed. It takes over the garden, it takes over all over the roadside, and it's great for feeding your tomatoes as well. And this, its traditional name in herbal medicine is knitbone. So it's been used for hundreds and hundreds of years and made up into a poultice and then strapped to the broken bone to help knit the bone together and help it repair. So it's understandable that this is a really good remedy that's present in Traumeel. So there's actually a really nice study as well that's looked at Symphytum given to rats, and they put implants into rats and they looked at the bone density during healing. So the rats that didn't have the Symphytum compared to the rats that did have the Symphytum, and the rats that had the Symphytum, they actually showed much better bone density around the implant. So, you know, this is a great remedy all on its own, just for encouraging healing and osseointegration after dental implants have been placed. And it's also present in Traumeel. So calendula is a beautiful marigold. Again, this is a plant that grows really, really easily and will take over your garden. And it's used in loads of herbal medicine. It's used in loads of creams and everything that's really useful for soreness, you know, lacerations, any open wounds. It's also hemostatic. It prevents pus formation and promotes healing. And it's very, very soothing as well. And again, this is present in Traumeel. So this is Hamamelis. So it's got these beautiful sort of straggly petals, and it's witch hazel. And again, this is a well-known herbal remedy that is really, really useful for trauma. Again, soreness, bleeding, really good for inflammation and injuries. And it's quite often used in, you know, creams and everything. So this is Achillea millefolium. Again, this is for hemorrhages when they're profuse and bright red. Of course, you might expect, you know, bleeding after taking a tooth out or doing hygiene treatment. And this is really good if you just can't get, it's just oozing red blood and you can't get it to stop bleeding once you've taken the tooth out. It's also really good for overexertion, which is why it's good for a sports remedy and in sports medicine. And actually, there's a lot of research on Traumeel as well used in sports medicine. So they looked at elite athletes and put them through a really, really vigorous training session, and then actually gave them Traumeel and looked at how quickly they recovered. And they did find that the group that took Traumeel recovered a lot quicker than the groups that taken ibuprofen or have been in the control group with no medicated tablets. So echinacea is another component of Traumeel. And again, I think this is a great herbal remedy that we often use for immune response. So it's great on its own in drops. If you've got a cough or cold or trying to prevent it because you've been surrounded by people with coughs and colds. And certainly in the UK, there's lots of that going around as we go into the winter months. But it's also good for blood poisoning. Like I said, it's a really good immunostimulant and really helps boost the body's immune system. So there's two types of echinacea in here. So and one of them is really good for low-grade fever, pain in the right ear, and carbuncles on the skin. So, you know, not necessarily specific to dentistry, but of course we want to improve that immune response when we've had an infection, we've had to take a tooth out, or we've got inflammation and infection of the gums during periodontal conditions. Hypericum, this is better known as St. John's wort. So, and it's St. John's wort is a really good anxiety remedy in the herbal sphere as well. And it's also got similar effects in homeopathy. And this has an affinity to the nerve. So whatever we do in the mouth for dentistry is that we are damaging nerves, whether it's just the nerve endings because, you know, we've gone quite deep and close to the nerve in the tooth, or, you know, whether we've done hygiene and everything's a little bit on the edge just because we've given everything a clean. You know, whether it's we've injected, so we've got that, you know, trauma to the nerve because we've given them local anesthetic. So this is really good remedy in dentistry. So it's also specific to puncture wounds. So like I said, you know, if we've given them a local anesthetic, this remedy works. And it has also, it also has an affinity for the venous system with capillary paralysis, but it's well known for nerves. And it's that hypersensitivity that people get where everything hot, cold, biting on it, sugar, everything just sets off the nerve, and this can just calm it down. This is Mercurius solubilis, and no surprise that this is really, really useful in dentistry, being mercury. And of course, you know, we've had a long association between dentistry and mercury. You know, we've been placing amalgam restorations for years. I place very, very few now, almost amalgam free. And some practices are amalgam free, but of course we have this association with dentistry and mercury. And this is really good for really nasty infections in the mouth. So, you know, periodontally, we're looking at the acute necrotizing ulcerative gingivitis when we've got all that suppuration. It really stinks. They've got lots and lots of salivation. It's painful. It's just nasty. It's sort of rotting flesh. So this is really, really good in those situations where you've got that really nasty infection that's really destructive. You know, it's not just there, it just destroys everything. It destroys the interdental papillae. Hepar sulf is from sulfur and also mixed in with the insides of oyster shells. And it's a really, really useful remedy in dentistry anyway. But like I said, it's in the traumeal as well. So again, there's that oversensitivity, mainly mental and physical now. So not as much as putting your nerves on edge, but just everything is just too much. It's really good for infections and suppuration. It's got splinter-like burning pain, and these people feel chilly, so they're always cold, especially when they're ill. So in the classical approach to homeopathy, it's a really interesting remedy because when we dilute things, we count how many times we've diluted it. So we'll dilute it once and then we'll use a drop of that and dilute it again. And Hepar sulf, when we diluted it 6 times in 1 part to 99 parts of the solute, is that it actually encourages drainage. So if you've got that swelling on the side of the mouth and you just can't persuade that pus to drain out, is that it works really well in a 6C just to try and encourage the body to start to drain and make a sinus so that we can actually get the infection to flow out. And then if we up the potentization, we dilute it a few more times up to 30C, is that then it sort of mops up any infection that's still lingering. So it's in quite a low potency, so it's not being diluted so many times in traumeal, but of course traumeal, you know, we're looking at immediate trauma, not maybe the long-term effects. But this remedy is just really useful, especially when we've got tooth abscesses. So in the initial stages when we're trying to get it to drain, and then in the latter stages, maybe after we've done the treatment, is just trying to mop up whatever's left and just helping the body along that way about getting rid of that pus. So arnica is usually the homeopathic remedy that everybody knows about. It has an affinity to small blood vessels, which bruise easily. It's also really good for mental bruising as well. So, you know, it's maybe the patient that's come into us and, you know, they're feeling really bad or really bruised about what's going on with their teeth, or maybe really bruised by the fact that they've had to go through all of this dental treatment or whatever you've had to do for them over a course of treatment or in one session. So because of its, you know, it's associated with bruising. So we know that there's a lot of research with arnica that shows that actually you can reduce the amount of bruising and it'll resolve quicker as well. And this is no different in dentistry. It also can help with mental shock, a little bit like the aconite. It's just not quite as powerful as the aconite in that circumstance. So Bellis perennis, so the humble daisy. So this has a very similar action to arnica, and it is associated with bruising, but it's when that bruising is really, really deep. So, you know, in dentistry, it might be more muscular. So it might be that they've been opening for a very long time so that you can do your treatment. And it's more likely to work, you know, when the muscles are feeling a little bit more bruised, not necessarily just on the surface after hygiene treatment. So I've finished a bit earlier, so I hope that's enough. But that's a bit of an overview of Traumeel. And like I said, it's really easy to use in the dental practice. It's very easy to get hold of through homeopathic pharmacies or looking online. It's made by a company called Heal. And like I said, so what I would do normally if I was taking a tooth out is that I would give them 10 drops of Traumeel in liquid form onto the tongue. And then I would numb them up as normal. I might give them another 10 drops onto the tongue just before I take the tooth out, depending whether I think the patient needs it a little bit more. And then I'll take the tooth out, and then I might give them a few more drops, especially if they're still oozing blood a little bit or I'm struggling to get them to stop bleeding. Then what I'll do is I'll give them a little bottle of Traumeel tablets, which they can take, and I'd advise them to take them 3 times a day for the next few days, and then when they're feeling better, just to stop taking them. So my personal experience of using Traumeel after, you know, taking a tooth out is the patient's just a little bit more relaxed. You know, obviously it's quite traumatic and a lot of people are anxious about it, but you know, my experience is that they're a little bit more relaxed and a little bit more open to having the tooth taken out. Occasionally they still get dry sockets and still get post-operative problems. It doesn't eliminate it completely, but I do find that they stop bleeding quicker, and they do come back with fewer problems. But like I said, that's anecdotal. But as you can see from the research that I've gone through with you, is that it's actually showing why Traumeel might work. And actually, you know, we've got some nice RCTs that are actually proving that it's at least as good as ibuprofen and definitely better than a control group of a placebo. So thank you very much.
Thank you, Dr. Samantha Yudzev, for your contribution, for your friendship, and for your support in Stomatologia Journal project. Thank you so much.
My pleasure. Thank you very much.
Hello, Gregor.
Hello, Marian. How are you?
Well, I try to continue.
Very good. Good to see you again.
Next speaker is Professor Gregor Slavicek. Dr. Slavicek is a specialized in dentistry, medical doctor. He is currently director of Steinbeiß Transfer Institute Biomedical International Dentistry in Berlin. He has been CEO of OREHAB Main GmbH in Stuttgart. He graduated from University of Vienna, Medicine and Dentistry. Also specializing in clinical research at the same university. He attended additional postgraduate orthodontic training at the University of Aarhus, Denmark, with Professor Melsen, and postgraduate gnatological training at the University of Florida with Professor Landin and Professor Gibbs. He is an honorary member of the Italian Gnatological Society. He was awarded an honorary professorship by the Ukrainian Dental Society. He was visiting professor of the First Medical State University in Moscow, Sechenov. Now, topic of our friend is 12 facts on how gnatology contributes to green and sustainable dentistry. Thank you, Gregor, please.
Thank you very much, Marian, and welcome to this lecture. Since I was a student in dentistry and medicine, I was in touch with gnatology, and that's why I think I can make some comments about gnatology and how gnatology can contribute to green and sustainable dentistry. Gnatology has a long history. This year, 100 years anniversary, and the fathers of gnatology, B.B. McCollum, Harvey Stallard, and their student, Charles Stewart, founded in 2024, and in this year's the Gnatological Society of California. And McCollum stated that gnatology is the science that deals with all biological aspects of the stomatognatic system and the therapy of the oral organ, especially the jaws and teeth, the therapy of the TMJ, masticatory and accessory muscles, and the vital relations of the organ to the rest of the human body. 100 years ago, this statement, these fundamental principles, was called by Stallard the knowledge of the jaws, gnatology. Charles Stewart, for his entire life, searched for instruments to understand better mandibular movements and to improve also the therapeutical possibilities. Gnatology in the beginning was a fundamental, we can call it today an disciplinary discipline, a fundamental part of stomatology, which is the base for all other disciplines. This was the main idea. But in the 70s, 80s, last century, there was a change. First, the change was that gnatology was called the discipline for the dysfunctional patients, the patients with temporomandibular disorders, craniomandibular disorders, TMJ pain. And today we know that this shift of gnatology only to be focused on that particular problem was not a good development. So when we look back, we have to say knatology started in 1924 up to the 1990s. And since that, we can call it new knatology or contemporary knatology. But the search for geometrical principles of the stomatognatic system started long before, and some names that you understand what we are talking about. Spee, with the curve of Spee, Bonville triangle, still the principle of a lot of articulators which are used today, also in the digital world, were still present. Knatology, we are looking for instruments to reproduce mandibular movements, to establish an occlusion which is in harmony with the skeletal frame, maxilla and mandible. And knatology aims to develop occlusal concepts and to support oral rehabilitation with the goal to improve occlusal functions and to improve patients' quality of life. Today, knatology is not only this focus on the dysfunctional pain patient. We have a combined aspect. We have to combine these two aspects, the medical aspect and the technical aspects, and at the end, oral rehabilitation. We use today reference planes, Frankfurt horizontal, axis orbital plane, to exchange and transfer data. And this is so important. From 1924 to 1980, approximately, there was a lot of complicated instrument development with pantographic, full programmed articulators, etc. But the step into the practice was not possible. In the 1990s, suddenly a change happened because of two things. First, a reference plane was introduced, Frankfurt and axis orbital plane, which allows to transfer the data. Second, recording of mandibular movement was simplified by the development of axiography, the recording of axis movements. Today we understand that we have to start with a reference position, which is still retral reference position, unforced retral, but the therapeutic position is part of our therapy. Initial therapy, one aim to reduce symptoms, second aim to establish a therapeutic position. Today, we also understand that we have to visualize occlusal functions like the chewing efficiency, the chewing test, or how the patient is really praxing, how the patient is using the teeth, the occlusal surfaces during this occlusal function. And then we know a lot about occlusal geometrical and mathematical principles, vertical dimension, occlusal plane, position and inclination, harmony of dental arches, curve of Spee, curves of Wilson, lingual morphology of the upper front teeth, correct overbite, overjet, incisor relationship. We know compensation mechanism. We know that we have a 1-to-2 dental relationship from buccal, but 1-to-1 dental relationship from lingual, distinct fossa, past fossa relationship, and a sequential occlusal concept which can be individualized for these patients undergoing an oral rehabilitation. So now 12 facts. Very briefly, very short, time is running, so I have to go on. Occlusal function chewing. We know chewing and cognitive decline are very close related. If there is a problem with chewing, for here in this study published in 2020, a longitudinal cohort study, more than 20 years observing period, shows clearly the risk if mastication is reduced, the risk of cognitive decline or even dementia is increasing, significantly increasing. We know that also from a lot of other studies showing this link between mastication, the stomatognatic system, and the brain, cerebral blood flow, brain perfusion, oxygenation. A lot of information about this subject in the literature. And we know also the pathomechanism from experimental studies. So we can say it's very robust evidence that mastication, the occlusal function mastication, and brain functions, brain morphology are linked and interdependent. So we have to maintain mastication to prevent the cognitive decline, to prevent also the costs. When we talk about green and sustainable dentistry, the secondary costs of a patient with a mental problem are extremely high. So we as dentists can contribute by maintaining this mastication on a high level. And in some publication, it's called mastication for the mind. The later the onset of a cognitive decline, the more resources are saved. So it's a big task for oral rehabilitation. Chewing in general health. There's a lot of literature also showing that reduced mastication leads to an altered food choice, high caloric nutrition with all the consequences, reduced masticatory function, reduced chewing cycles, reduced communication challenges, and structural changes in the brain. So we have health problem related to a changed, reduced mastication in different aspects. So also here we can avoid secondary costs for this patient, for the society, when mastication is kept on a high level. Oral rehabilitation to maintain mastication. So we can conclude from these studies, tooth loss, the less the better. The more teeth in the mouth, the better mastication, the less risk to have a physical or psychic health problem. Occlusion in oral rehabilitation, discussion, long discussion. Do we need more than premolars? Do we need to replace molars? Here we can say the good old sentence from Blake, extension for prevention, not in the sense of Blake, but we need a posterior occlusion. We need a good masticatory performance. And for the aged population, we have to maintain masticatory ability. But of course, we have to understand also the comorbidity. So, and we know how to understand if the patient can still chew well. This is the chewing test from Oral Minds here. And we have we have a lot of information already about what do we expect. And we know also how to make an interpretation if, for example, here, a 33-year-old male with chewing difficulties, with a loss of occlusal relief, with flat occlusion, shows this chewing test, far from optimal. And our task is to restore and to bring this chewing function again to physiological. So second, we have to avoid chronification from a medical perspective. Each chronic disease increases the need for medical services, for medication, for healthcare and nursing. So we have a lot of resources, and this is one aspect from a green sustainable dentistry to avoid this cost and this load for the environment. Dental interventions. We should not wait until the patient is in a very bad intraoral status. We have to react earlier. Yeah? And if we see such a thing, we can ask ourselves, even after first sanation, why a 28-year-old female is in this situation, why we have not reacted earlier. And if we count here all the interventions, how many endodontic therapies, how many core posts, how many crowns, how many fillings, how often the patient has been at the dental chair, then we can understand that this was a big load for the environment. And we should try to reduce this by making a proper strategy for these patients, because this situation, 20 years now, started already 10, 15 years ago. So we have to do that. And when we see the footprint of a single tooth, I call it a career of a single tooth, and with a cumulated pollution for the environment, you can say the caries-free teeth with the number one, then crowns, then endo, then re-endo, then core post plus crown, then extraction, then implant crown, and so on. So in total, the pollution for this single tooth is very high. And this should be also aspected when we talk about oral rehabilitation. Can we prevent this career by sufficient, not single tooth relations, but a sufficient overall strategy to avoid this high and often needed interventions. So fact 3, we should avoid retreatment. We should avoid the retreatment. We should stop this career, avoid second and third treatments, even in orthodontic. Why we have to redo ortho so often? Why we have to redo? It's a relapse. Why we are not able to stabilize? No? We have to look for long-term stability, and here knotology can contribute a lot. Dental interventions. What has to be done should be done. No? When we see here this patient's main concern, a female with a good oral hygiene, she's bruxing, she has tooth abrasions and cramps in her head and neck, and this is her main concern. And after splint therapy, you can see the splint, we transfer this position to the articulator, and in this position, we know the patient is without cramps, without problem, and we can wax full mouth rehabilitation, but non-invasive techniques, direct composites. Today, we are very lucky with these techniques and with these materials. We can keep these teeth almost untouched, also part to stop. And this is just one technique, injection technique, and we can see the new occlusion. But not this occlusion is done, and in 10 years we will do it again. We have to monitor, and we will see this aspect a little bit later again. So number 3, we should be as minimal as possible, but as invasive as needed. Makes no sense just to make small intervention and then to say it's minimal. That's good. If it's more needed, we have to go for it. What has to be done needs to be done. Only to solve an acute problem, ignoring the overall situation, leads to increased needs of resources in the future. Chronic pain. A lot of problem in the population today. Lower back pain, shoulder, neck pain leads to reduced quality of life, reduced to activity of daily life, with sick leaves, with additional costs for the social insurance systems, and so on. And we have such patients here with 20-year-old female after orthodontic therapy, with noises in the ear. She feels tired all the time she's not able to work, she's not able to accomplish the normal everyday task, chronic exhaustion, with a lot of problems, with a lot of costs in the future, medical costs, sick leaves, not able to work properly, not able to pay taxes, a lot of things where we can hope to improve when we start to think in this chronic pain treatment. Here at the beginning of the spleen therapy, she showed again the amount of pain she's suffering, and this is maximum pain on the visual analog scale. On day 0, she got this splint. She showed again. On day 28, so 4 weeks later, with this simple splint, we have a much better situation. The patient is smiling again, has a better quality of life, and back to work. And that means also a good environmental impact. So knatology aims to enhance active life, and the craniomandibular disorder is not a disease, it's a status, and we with occlusion, with an individual occlusal therapy, should be able to say, first of all, this individual occlusion is the cause, and if yes, we have to go for a treatment. Workflows. Analog, digital. Sorry. The digital workflow is wonderful. I really appreciate these possibilities we have, and especially the situation because we have the data in the computer and we can use the data once again. But I'm critical. We should not lose the precision. Knatology is a science for precise workflows in the articulator, mounting accuracy, checking it, split cast control, and so on. With the digital workflow, for me, it seems that this precision is not lost, but shifted. We believe that the computer, the digital workflow, the CAD/CAM systems are doing it because it is digital. Be careful with that. We should not lose this precision. And at the end, for each full mouth rehabilitation, we need to go back to a manual analog check of occlusion. Otherwise, we are like in a black box and we lose control. Yes, digital workflows are helping a lot if we are not losing the precision and the accuracy, but we should choose the most suitable workflow for the individual patient. Maybe still analog wax up and then digital fabrication, or the full CAD/CAM workflow with analog elements in the beginning and of course analog elements in the end while finalization. Oral rehabilitation. That's an interesting question. When I thought about this presentation, how often we have to make an oral rehabilitation during one life? How often the patient is in a dental clinic to make a full mouth rehabilitation, or at least a substantial prosthodontic rehabilitation? When we consider a lifespan average of maybe 12 to 15 years of one rehabilitation, hopefully 18, even more with 20 years, then still we have to do it 2 or 3 times per one lifespan. And I try to illustrate this here. So when we see the patient here in a timeline over the years, starting in the age of 10, 14, usually the time where we make first severe interventions with full mouth ortho, not interceptive ortho, but full mouth Then we're dealing with malocclusion, dyspneic, and orthodontic therapy in the adolescent. And after that, it takes a while, maybe up to young adults. Then there's a need, maybe because of operations, as we have seen it before. Maybe the patient wants to change the fillings, or there is a need for fillings, and so on. So first peak here, first oral rehabilitation. And then after a while, maybe 20 years later, patient is now in the age of 45 to 50. Often we change again, maybe now to ceramic restoration, and we have a second oral rehabilitation. And again, 20 years later, a third oral rehabilitation, maybe dentures, maybe implants, maybe partial dentures, removable. We're already in the elderly. And then once again, covered denture, full denture, what is needed to do. So this is, for me, a quite typical patient's career over the years. When we see this blue line, it is the idea what we should do. Not to wait until there is a total breakdown, but to do special maintenance when the patient shows operations, and the canines are starting to be lost. We have to react here. And I hope with this concept to maintain these patients on a higher level without this big vertical difference between the red line and the blue line. Because this vertical difference from here to here, from the always these peaks in the red line, they are cost intensive, but also intensive in using resources and loading the environment. So here you can see this patient I showed you before with this direct composite restoration. After 1 year, maybe 2 years, it was shown in a follow-up with the Brax checker that the canines are starting to be abraded again. And if the canines are not protecting the posterior teeth, we will have more abrasions posterior. And after 5 years, this whole work has to be done again. So from this follow-up, on this Braxing analysis, it was shown that the composite on the canine is not strong enough. That's why ceramic veneers only on the canines are performed with the same data from before. The wax-up was used from before, the digital workflow, the digital data were used again. And now the patient is again on a stable situation. And these canines, with this ceramic restoration, are able to protect the system better. So repair what is needed, prevent the total breakdown. With digital data to maintain, to repair, what is needed has to be repaired to avoid frequent. So in 10 years, 15 years, a new complete restoration and not a wait and see strategy, but an active strategy to maintain the situation. When we organize, when we plan, when we communicate, then we are in the collaboration among disciplines. And we can try to use this collaboration between disciplines to, first of all, shorten treatment time, and second, to make the result more stable. But it requires a lot of planning, a lot of communication, and one management task. It's an additional load. But when we see such a complex oral rehabilitation from the start, 17-year-old female here, upper left picture, after splint, and after splint we can continue already with upper orthodontics. The splint maintains the jaw position. In this situation, the jaw joints are in a good situation. The disc is recaptured. The patient has almost no symptoms anymore, no noises, and so on. And maintaining this situation through the orthodontic therapy helps us to finish this case also in this quite complex case, less than 24 months. And after that collaboration, the occlusion is rechecked and stabilized, because here is a deficit in occlusion. Also, this patient has no caries, but so small restoration with composite, again, to stabilize, as we have seen it there. But it requires this collaboration task. It requires interdisciplinary dentistry. And with this, we can, and a good monitoring, we can expect a better possibility to stabilize this patient. And knattology guarantees the consistency in oral rehabilitation because we have data. And this data guarantee the longitudinal consistency over the 2 years treatment time or 3 years treatment time, and then later for the maintenance, but also the vertical consistency, what I call interdisciplinary consistency. All work together. And that's why the resources we need are reduced. And this is at least to some amount contribution to green and sustainable dentistry. Interdisciplinary collaboration. Praxing, stress management, stomatognatic system, the stress management organ. Praxing is a big load on our dental shoulders. Yeah? We have a praxing activity, we have a chewing efficiency, and the patient complains, the patient has symptoms, the patient shows and presents with intraoral signs, abrasions, facets, intraoral class 5 lesions, and so on. Or in the chewing efficiency, patients' concerns, questionnaires we can use, and the oral inspection may show missing teeth. But this is all subjective and not telling us exactly what's going on. When we want to objectify, we have a Prax checker, introduced by Professor Sato 20 years ago already, and we want to we analyze it, and we have this chewing test. So objectify also the praxing, then the patient will understand. And with this analysis, we can understand also the correlation to the perio. Because on the panoramic X-ray from today, maybe we just see the picture today, but the effect was already produced over the years. No? And the Prax checker tells us how this occlusion is used today. We have a possibility to understand the occlusal trauma, and the patient will understand and will accept now that not only maybe the diastema should be closed again, but there is a severe problem related to this occlusal function. And we can correlate with the Prax checker now the different facets to the periodontal tissue. I'm sorry. And here from colleagues from Stuttgart, Gerd Reichert, Yuki Miyakawa, and Gerd Rötele, they showed that there is a possibility to have an influence on praxing. Not the patient stops praxing. The patient is using this occlusion, the new restored occlusion after oral rehabilitation again. And we can monitor this occlusion again for 10, 15, 20 years with the Prax checker. So very simple tool, again, to see, is there a need to do something? So what we can see here after the orthodontic and oral rehabilitation, we have this excellent occlusion with a lot of tripods, also during the praxing activity with dominant canines, and 15 years later, still a good function. The canines are still working. And if you see, maybe in some years, it's better to change the canines again to protect posterior teeth again. So we have the possibility with occlusal rehabilitation to improve the stress management with praxing and stress management activity when we understand, when we visualize it. And with that, we can avoid these negative effects of stress on the physical and mental health, including pain and pain medication. That leads to the craniomandibular disorder, temporomandibular disorder, which is per se this the dominance of the knatology, which I'm not so happy about, just to make knatology related only to craniomandibular disorders. But also these patients require good occlusion. And the literature is full that the occlusion in the moment cannot be called a causal cause for craniomandibular disorder. I respect the literature. I read all these papers, and I can say yes. From the literature, we cannot make a general statement, but especially these patients require an individual statement, and that means we have to go to see this conflict between the stomatognatic system and occlusion, the joint, the chronic pain. Proprioceptive conflict, the joint wants to center, the proprioceptive of the stomatognatic system acts in one direction, occlusion acts in a different direction. And that's why we have this conflict. And when we understand with a systematic analysis the conflict, we can break this conflict, and with a splint therapy, simple splint, we eliminate occlusion, we eliminate this conflicting proprioceptive inputs, the conflicting signals, and we allow the CMS, the craniomandibular system, to dominate with the improvement of the symptoms, the signs, improvement of occlusal functions. And then after splint therapy, we have to go for an occlusal rehabilitation, not to treat the symptoms, to stabilize this patient. The symptoms were treated with the splint, reversible occlusal changes. And here we can see again, if there is a joint-related dominated position or an occlusal dominated position, we have this conflict, proprioceptive conflict. And this is how knatology can work when we work with an initial therapy. Prevention of negative effects on the CMS with this strategy to bring the CMS system and occlusion again in harmony. Dental diagnostics. Knatology has a clear protocol, very precise, instrumental supported diagnostics. This is in contrast to other approaches where we have selected diagnostics, not the systematic diagnostics. And systematic diagnostic means we start with a systematic approach and we convergent these diagnostics. We have a problem list, and based on that, we can say that this patient's individual occlusion is a cause. It's a hypothesis. And with this hypothesis, we can start with the treatment, splint therapy, reversible. And if the patient reacts positive to this reversible occlusal changes, positive means reduced subjective and objective signs and symptoms, then we can make the second step after interim analysis to make now the oral rehabilitation. So this, what you see here on the screen is a summary of today's contemporary knotlological oral rehabilitation concept. And it doesn't matter if the patient has the label craniomandibular symptoms or a clicking joint or even a destroyed joint. Doesn't matter. You have to go for it. And not direct to full mouth rehabilitation, but in steps, in sequence. So diagnostics should be used to identify causes. Knotlological diagnostic means I want to understand the problem. And if the problem is occlusion for this individual patient, I can react now. Diagnostics is not only to identify a symptom. That's not the knotlological diagnostic procedure. In doing so, we can go for all the personalized medicine which is required today. We can reduce the costs of oral rehabilitation. We have a shared decision making, and we visualize occlusal functions because we have the intra-individual comparison before and after splint, before and after interim restoration. Finally, number 12 now, we have to understand that the chewing organ is a complex organ. This is what I learned from my great teacher, my father, Rudolf Slavicek. It's a complex organ, and it's called so-called chewing organ. The traditional knotlological triangle, neuromuscular system, occlusion and temporomandibular joint, in the center, the psychic status, is here based on the cybernetic system concept, more complex, but showing the integration of the stomatognatic system in the organism and the relationship to the environment. The structures, the functions are in the center. This is what we have to maintain, optimize. Mastication, communication, verbal communication here is aesthetics, stress management, praxing, but also posture and balance, and the clear relationship to the central and peripheral nervous system. And the triangle here visualized from a pathogenetic model after oral rehabilitation, after the splint therapy, occlusion is still unchanged. We have changed mandibular position with the splint, and that's why we need to restore occlusion by oral rehabilitation. So this is on the left-hand side, a pathogenetical model, this knotlological triangle, but on the right-hand side, you see the therapeutical concept with initial therapy, proprioception, and leading to an oral rehabilitation. So number 12, fact number 12, we have to understand the complexity of the cybernetic system. We have to understand the interdependencies of functions, structures, central nervous system, peripheral nervous system, the psychic status of the patient, the interdependency with the organism and organism with the environment. So green, sustainable dentistry, knotlological contribution and summary, reduction of overall dental needs during an individual life, starting from the first small intervention to the overall amount of oral rehabilitations for this individual patient over the time. And knatology aims to reduce this amount in total when we use it systematic for every single intervention. We have to maintain the quality of life and the activity of daily life for each individual. These patients contribute better to a green environment. They are able to maintain our environment healthy. We have to avoid chronification because chronification is a big load on our social system, but also for the environment. And we have to think about organization and collaboration between disciplines. So 12 facts of how knatology contributes to green and sustainable dentistry. I thank you very much for your attention, and I hope I'm still in time. Yes, looks like. Okay, thank you very much for your attention.
Thank you so much, Professor Slavicek, for your contribution, for a very interesting lecture, and for your support in our project. Thank you so much, Gregor.
Thank you very much, and all the best for the rest of the conference. Thank you also for your efforts, Marian. I really appreciate your energy you spend in dentistry. So, thank you.
Thank you. Thank you for your words. Thank you, Gregor.
Yeah.
Greetings to Florian and Anastasia. Bye.
Thank you very much. I will tell them.
test. Hello, Dr. Rastelli?
Hello, Professor. How
It's
are
not a
you?
professor. I'm sorry. My name is Theodor Stanitsky. I'm from Technical Lead. I'm just using this account for now.
Okay, all right. So I just saw your message a few minutes ago, and I could not join before that.
Dr. Rastelli, can you hear me?
Yes, I can hear you very well.
We cannot hear you very well. You have an internet problem, I think.
Can you hear me right now?
Yes, we can, but it's very low. Like you keep interrupting. Can you join from
Let me see.
Okay.
Let me see if I can. Can you hear me better right now? Maybe I can try to go out and come back again. Just give me a few seconds.
Okay,
Let me try.
Yes, thank you very much. Doamna Rasteli a ieșit și o să intre din nou. Avea niște probleme la microfon sau de internet, una din două.
Can you hear me better right now?
Yes, we can hear you.
Okay, let's see. Hopefully we will not have technical problems. Let's see. Can I test my screen if it is working? Okay, great. Let's wait a little bit more. Thank you.
Yes, I think you can test it. It's better to test it right now.
Okay, let me see. Just let's double check my presentation is already. Let me see.
There's no hurry. We have a few more minutes before.
Yeah, I see. Let's see. Allow to share screen. Can you see my presentation right now?
Yes, we can.
Okay, great. So, all right. Thank you.
Hello. Now.
Hello. How are you?
Many thanks for coming. Now, next speaker is from Sao Paulo, Professor Alessandra Nara de Souza Rastelli, DDS, graduated at State University of Ponta Grossa, School of Dentistry, Paraná, and completed master's and PhD degree at Sao Paulo State University, Araraquara. She worked as a visiting scientist at University of Erlangen, Germany, ACTA of Amsterdam, University of Birmingham, and Wellman Center for Photomedicine, Massachusetts General Hospital, University of Harvard, Boston. She is an associate professor at University of Sao Paulo. She's head of the Biophotonics, Bio-Nanomaterials Laboratory at School of Dentistry. She works on the application of light sources, lasers and LEDs, in the oral health, antimicrobial photodynamic therapy, dental bleaching, photoactivation of dental material, and biostimulation. She is a supervisor of master's and PhD students, and more than papers published based on biophotonics field. Now, Professor Rastelli present clinical application and protocols of antimicrobial photodynamic in dentistry. Please, Professor Rastelli. Thank you for coming.
All right. First of all, thank you so much for your very nice and kind introduction. And first of all, I would like to thank you so much, Professor Marian and Professor Lekshman, for inviting me to join this very nice e-conference. It's a great pleasure for us to talk a little bit about our work here in Brazil, and of course, join this wonderful conference. So I will start to share my screen. Let me see if you can already see my presentation. It's okay?
1 second, please.
Okay.
It's okay, we can see it.
Okay, great. And can you hear me?
Yes, we can hear you very well.
All right, so thank you so much again. Before I start my presentation entitled Clinical Applications and Protocols of Antimicrobial Photodynamic Dentistry, I would like to let you know that I don't have any conflict of interest in this presentation. So, of course, I will not spend too much time talking about myself. We already have a very nice introduction. So the only thing that I really would like to emphasize and highlight right now is regarding that I am working on the biophotonics field since more than 20 years ago. So basically, as you already know, I am from Brazil. I am a professor of dentistry in a school of dentistry in São Paulo State. And I am based on São Paulo State in a small city called Araraquara. So, and here, São Paulo State is the biggest state from Brazil, where we can have more than 42 million people living here. And Araraquara is a small city with more than 200,000 people living here. So as I told you, I am an associate professor in a school of dentistry. I am in a public school of dentistry in São Paulo State University. So then I have worked with undergrad and grad students here at the university. And also we have performed different researches here, especially in my lab, where I am the head of the biophotonics and bionanomaterials laboratory. So as I said, as I told you, I have worked in the biophotonics field since more 20 years ago. So biophotonics field means that we have used and investigated the different interactions and effects of the different light sources that we can use in dentistry, such as lasers under different wavelengths and also LEDs. So we can use and apply the biophotonics for different approaches in dentistry. So I am a professor of restorative dentistry here in Brazil. This is the reason why I have focused my research especially over these all approaches applied to the different to the restorative dentistry field. So in the last 10 years, I have my research group. We have worked especially on the effects of the biophotonics on the antimicrobial photodynamic therapy, although we have also worked on different fields like dental bleaching, cavity preparation, diagnosis, photoactivation, and hypersensitivity treatments using the biophotonics field. But in this presentation, I will focus on the antimicrobial photodynamic therapy, but especially the clinical application of the APDT. But before that, I will show you some papers that we have published in the literature to show how this technique can work very well for for different applications in dentistry. We have focused our efforts to investigate the effect of antimicrobial photodynamic therapy, or APDT, especially over karyogenic and periodontal biofilms, although this technique can be used for other oral infections, which is the reason why we have focused our efforts especially on karyogenic and periodontal biofilms, because until right now, according to the WHO, dental caries and periodontal disease remain as the most common oral disease that can affect the people worldwide. So in this way, of course, we needed to do something to help people to reduce or avoid this kind of oral disease. Because as we can see here, more than 1 billion people around the world can suffer from one of these oral disease. Of course, it's important to, before we talk a little bit more about APDT, it's important to emphasize that not just the oral microbiota is responsible to start the dental caries or periodontal disease. Of course, these both oral disease, they are multifactorial disease, but the microbiota can play an important role on the development and progression of these two most common oral disease. So, and right now, how antimicrobial photodynamic therapy can work on this most common oral disease around the world? So first, it's important to highlight what is photodynamic therapy and how and where can we include this technique in dentistry. basically, photodynamic therapy associate the use of one light source that could be a laser or a LED and a photosensitizer, a chemical compound that is able to absorb the light and start some photodynamic reactions that can kill or control the oral microorganisms. Of course, it's important to emphasize that we could not kill all oral microbiota. We just wanted to control, especially those one under an increased number called the pathogens that can be that can get involved in the etiology of a different oral disease. So in this way, where can we exactly use antimicrobial photodynamic therapy in dentistry? To treat the dental caries, oral candidiasis, peri-implantitis, endodontic infection, labial herpes, periodontal disease. Of course, it is important to say science right now that we needed to mechanically remove the biofilm responsible for these oral diseases. So then it's important to say that photodynamic therapy is a complementary or adjunctive technique to be used in dentistry. Of course, if we have a dental caries, we need to mechanically remove first, and after that we can use APDT to decontaminate the cavity, or also to decontaminate the surface of an implant or the soft tissue to help to improve the clinical conditions. But of course, antimicrobial photodynamic therapy is also used with the other procedures for the different applications. So as you can see here, this technique, the photosensitizer needs to absorb some specific wavelength, and after that we can have like a photodynamic reaction where we can see the production of a different species of free radicals, like hydrogen peroxide, singlet oxygen, hydroxyl radicals that they are toxic for the microorganisms. So then we can start to kill these microorganisms after the photodynamic reactions. So especially type 1 and type 2 reactions, that they are more strong, that some papers have showed that we can have other two types of reactions, like type 3 and type 4, but basically most of the effect of antimicrobial photodynamic therapy is based on reactions type 1 and type 2. So before I talk with you regarding the clinical applications and protocols for the APDT, I would like to highlight some papers, some studies from our group here in Brazil, and also with our collaborators, international collaborators. And in this study, we investigated the effect of APDT, the antimicrobial effect, over a 48 hours Streptococcus mutans biofilm culture from the saliva. And we could clearly show that in this study where we used the methylene blue and chlorine E6 as photosensitizers, we could clearly demonstrate the effect, the antimicrobial effect after irradiation, where we could show 4 log reduction. It is which is already considered very good for antimicrobial purpose. But we could also emphasize and highlight that we could also demonstrate that APDT was also able to provide a reduction of the lactic acid concentration after APDT, which is interesting, especially, for example, for patients under high risk to develop dental caries. So then we in this study we showed very interesting results that we can use it in the clinical setting. In this another study, we showed the association of antimicrobial PDT using chlorine E6 and hydrogen peroxide. We know that hydrogen peroxide is a very well-known antimicrobial agent, especially under very low concentrations. And what exactly under these parameters used in this study in a multi-species biofilm cultured from the saliva, we could show that hydrogen peroxide could potentiate the effect of APDT because we can improve and increase the generation of oxygen by this association. So it could be very interesting, especially when we talk about of hypoxic media, for example, where in dental pockets or endodontic infection, usually we have a low amount of oxygen in these tissues, so then it could negatively affect antimicrobial PDT once to have the photodynamic reactions. We also need to have a local or molecular oxygen to start the generation of radicals, of free radicals in the tissue. So it's another possibility that we can increase the antimicrobial effect of APDT. In this another study, we investigated the association of a natural compound, curcumin, and its antimicrobial effect associated with a drug delivery system by mice cells to improve the interaction of the properties of this photosensitizer, and also to improve the interaction of the photosensitizer with the biofilm structure. So we know that it's very difficult to penetrate the whole thickness of a biofilm. So then if we could investigate different combinations and approaches to improve the APDT effect, of course, it's very, very interesting to improve the clinical application. And in this study, we could clearly show that we could reach a 4 log reduction. It's already higher than the minimal 3 log reduction needed to say that some technique or some material is considered a good antimicrobial approach for dentistry. We could also demonstrate it by confocal image that we could see a rate of dyed cells where we can see more red than green cells, that we could reach a very good inhibition or killing of the biofilm. So in this study, we investigated the effect of a PDT over single species biofilms of Streptococcus mutans and also of Candida albicans. So we could also demonstrate that over Candida, a 3.5 or 4 log reduction was reached with a PDT. Of course, and it's important to emphasize that APDT is not only the treatment that we will use it for some situations like periodontal pockets, periodontal patients, or for the treatment of endodontic infections. We need, of course, mechanically treat those patients, but a PDT could be a very good and important approach to improve the oral health once we can see a very good antimicrobial effect. Other things that we needed to highlight for PDT, because maybe someone could ask us, oh, why APDT is better than the other or the most common antimicrobials used in dentistry. PDT doesn't induce the microbial resistance. There is no side effects, even if we apply repeated times. So then, for sure, PDT could be a very good approach to use in dentistry for the different oral infection disease. It is another study that we performed here in our lab. We investigated the effect of APDT over a dual species biofilm. Of course, once we have a more complicated biofilm, we can see a reduction on the effect of APDT, but it keeps a very good result where we can see, especially for Candida, more than 3 log reduction, which is considered already very good for the clinical application. We have also associated APDT with other techniques. Like in this study, we associate photodynamic therapy with the use of ultrasound at the same time. So then, of course, we can see an increase on the log killing once we associate APDT with ultrasound, where here we can see the comparison between APDT alone and APDT and ultrasound. We can see a significant increase on the effect of this association. Once, especially, we can disorganize better the biofilm structure, and then the photosensitizer can penetrate, can diffuse better through the biofilm structure, and then after shining the light, we can have an increase on the log reduction of the antimicrobial effect. So what is new right now regarding the photodynamic therapy? As I showed for you, to start the photodynamic reactions, we needed to use a photosensitizer and a light source. So then we need, I will show you during the clinical cases, we needed to apply the photosensitizer, wait for some minutes, and after that we shine the light. So right now we are working on something different that we can improve the results, and there is no need to have a photosensitizer in contact with the tissues, because the photosensitizer is the photosensitizer doped this surface that is a super hydrophobic surface, and what exactly is delivered from this surface for the tissue is not the photosensitizer, and then the singlet oxygen or the other radicals. So then for this super hydrophobic antimicrobial photodynamic therapy, there is no direct contact of the tissue with the photosensitizer. There is no need of incubation time, no staining of the soft and hard tissues and restorative materials. And also we could already demonstrate that there is a reduced cytotoxicity once the time life of the radicals is very short. So then it's very difficult to induce a cytotoxicity, a cytotoxic effect over different tissues. So in this way, we have performed different studies using this surface in vitro and also in vivo studies, where we could demonstrate the ability of this approach, this new tool for APDT, to inhibit or to provide the killing of the different strains in a multi-species biofilm. So this is a study that our focus was to highlight the use of a super hydrophobic surface over a periodontal biofilm. And we could show, of course, depending on the parameter, because the light doses and also the concentration of the photosensitizer can play an important role on the final results. But we could demonstrate that this new approach can also provide more than a 3 log reduction, which is already considered very good for an antimicrobial approach. So we also performed in vivo studies by the use of a model, a periodontitis model, during 7 days in a Wister rat model. And for this study, we used a verteporfin photosensitizer, and we used 60 and 125 joules per centimeter square. For this photosensitizer, we needed to use a red light, and in this case, we used a laser, and we tested the single applications of APDT and repeated applications, and we evaluated the CFU counting, clinical parameters, and also the histological and stereometric analysis and inflammatory biomarkers after single and consecutive applications of APDT. So basically, we could demonstrate in this study that APDT under 125 provided the better results for the CFU counting and also for the clinical parameters that are important to show, especially in a clinical setting. And also we could demonstrate that after 30 days, we could improve not just the clinical parameters, but also the healing and reduce the inflammatory biomarkers. And 125, although in some points it was not different from 60, but generally, in general, 125 showed the best results. So let's have a look. How can we apply all of these concepts in the clinical setting? So for endodontic infection, as I already told you, so I believe I have more 10 minutes, right? So for the endodontic infection, of course, as I already told you, we needed to mechanically and we needed to go through the mechanical and chemical preparation. Of course, I will not talk about that. But after the mechanical and chemical preparation, we can use APDT before we finish the treatment. So then we can inject the photosensitizer. In this case, we use the methylene blue as a photosensitizer, and we wait for 5 minutes. Once we needed to wait the diffusion and penetration of the photosensitizer in the tissues. And after that, we shine the light. We shine the light for 1 minute and 30 seconds. For this photosensitizer, we needed to use a red light under 60 nanometers. So we can apply as many sessions we need, depend on, of course, the treatment that we planned for those patients. So this is another application that we can use APDT for gingivitis. We can also apply the photosensitizer over the soft or hard tissue. We needed to wait for the incubation time, and after that we shine the light. So of course, it's difficult to say how many times we needed to apply PDT to get some good results. Depends on the answer from the patient. Depends on the treatment by itself. Some patients, maybe 2 or 3 sessions are enough to provide a better result, but some of them, maybe they need to keep under treatment for a long time, for months, but there is no indication. There is no any problem if we wanted to repeat APDT to get a better result. So this is one important advantage of antimicrobial PDT in comparison with other antimicrobials that we have already used in dentistry science many years ago. This is a patient, this is a clinical case that was performed by Dr. Teodoro and Garcia. This is a patient that came to the dental office from the university with a complaint of pain during the chew. Although clinically we could not see nothing different, no signs for inflammation. The patient showed good oral hygiene, but once we get some x-rays, we could see that this patient already showed important areas of bone resorption. So, which means that this patient that was necessary to go through a periodontal treatment to improve the clinical parameters and also to improve and help on the maintenance of the oral health. So as a routine, the patient is clinically evaluated by the probing depth. As we can see here, the patient had the different sites with different depths until 8 millimeters. And what exactly we did was, of course, the patient was mechanically treated by the debridement, mechanical debridement, and after that, we associate the mechanical treatment with APDT. So for that, we needed to inject the photosensitizer inside the dental pocket, and we use these parameters as you can see over here. And for these cases, based on previously published papers, we used the 1 minute incubation time after photosensitizer application, and after that by the use of optical fiber that we can use exactly inside the dental pocket. It's a flexible optical fiber, so then we can re-irradiate the dental pocket through the whole extension, through the whole depth. Here we can see another application. We have used here in Brazil, we have used methylene blue in the clinical setting because it's it's a low-cost chemical compound already used in the dental field science many years ago. And here you can see the irradiation of the dental pocket using the optical fiber and other views. And of course, we check the clinical parameters before and after the different sessions. Of course, it takes time to recover, but we need to follow the clinical parameters of the patient. This is another patient that we could see signs for inflammation, but although the patient showed a good oral hygiene. We also have a look on the X-rays where we can see bone resorption and different sites with a probing depth higher than 4 millimeters. And we also used the same protocol for the antimicrobial photodynamic therapy. And here we did a comparison between patient 1 and patient 2 before and after 3 months of treatment with PDT. So we could see that PDT could improve, could reduce the probing depth in both patients, and we could here demonstrate a percentage of dental pockets that was significantly reduced after treatment. Of course, I am just showing you some clinical cases, but we can say that antimicrobial PDT can use it as an important tool to help to keep the oral health. So I believe it's my last slides. PDT is an important and efficient antimicrobial technique for dentistry. Once for dentistry, usually we have a more superficial infections, although PDT is not just used for infections in dentistry. Protocols should be standardized and investigated for the clinical applications. This is one of the most difficult things that we have to improve the use of APDT in the daily practice. Super hydrophobic APDT demonstrated to be a safe, low risk, and an effective treatment for APDT in dentistry, especially based on the advantages that I showed you in comparison with a conventional PDT, where we needed to apply the photosensitizer. Antimicrobial photodynamic therapy can be used to modulate or control the oral microbiome. Nanotechnology associated to improve APDT in dentistry, as we have demonstrated in our in vitro studies, and further studies are needed to determine the optimal treatment parameters and long-term efficacy of conventional and super hydrophobic APDT. This is something that we are working right now. Here, I would like to share with you my research areas interest. And of course, I would like to thank you so much, all of my students and also my collaborators, not just here from Brazil, but my international collaborators around the world. And I would like to thank you so much for your attention, and feel free to contact me if you have any question, or if you wanted to start some collaboration. I am open to answer for you. Thank you so much.
Professor Rastelli, thank you so much for your contribution at InnoBioDent conference and in all our program. Thank you so much.
It was a great pleasure. Thank you so much.
Thank you. Thank you.
Mr. Marian, you are muted. Can you unmute yourself?
Yes. Next speaker is Professor Mario Capellin. Hi, Mario.
Hi. I apologize.
Professor Capellin, born in Turin and graduated magna cum laude in dentistry at Dental School of Turin, Faculty of Medicine, lecturer on dental radiology, implant prosthesis and surgery, human resources management, and communication. He founded, currently directing, an homonymous dental clinic in Turin and Pinerolo. Since its foundation, the facility excels for high technological component that has recently led it to an entirely digital workflow. He taught at a postgraduate in management and marketing in dentistry at University Vita Salute Raffaele, Milan. In 2020, was author of Empathic, Ethic, and Effective Communication, the Success Key in Dentistry. He is a contract professor of ergonomics and dental discipline at University of Modena and Reggio Emilia. Eclectic personality, he obtained master in bioethics, summa cum laude, studied pipe organ, and is appreciated orchestra conductor. For artistic and humanitarian merit, has been honored by Rotary Club International with a Paul Harris Fellow and 3-time honored by International Lions Club with a Melvin Jones Fellowship. Now, Professor Capellin present his lecture from uninformed consent to shared decision making. Please, Professor Capellin.
Thank you very much for the invitation and thank you for the kind presentation. Okay.
You need assistance sharing your screen?
Yeah. I need to re-enter it. No. I think it is. Okay. Why?
Do you know where the present now button is? Let's start from there.
But I don't know.
Do you receive an error message on your screen?
Yeah, I think I must re-enter.
Okay.
I quit and then re-enter.
Okay, we'll be waiting.
Immediately. Okay.
Welcome back, Professor.
Yes. Do you see?
1 second. Yes, yes, we can see.
Okay, perfect. Okay. My topic is from uninformed consent to shared decision making, an ethical, ergonomic, and effective approach in dentistry. We can talk about this topic not only by an academic point of view, but clinical and practical point of view. But for explain well this concept and arrive at the end of this presentation with the concept of shared decision making, we have to do some quick notion about informed and uninformed consent. What is and why we talk about informed or